Start, right? All right, Sumit, ready?
Yes, Vardhaman sir, can we start?
Yeah. So I think we welcome you to the last day and the most exciting day of this BOA MOS Summer Symposium. And this is going to be a session on biometry, which is going to be chaired by our President IRSI, Dr. Himanshu Mehta. Will be co-chaired by Dr. Vinod Arora sir from Dehradun, Dr. Babikar sir from Thane, from Babikara Institute. Dr. Ilan Kumaran will be the co-convener. And I would like to now ask uh, Dr. Himanshu Mehta sir to start the proceedings, please.
Morning, friends, and thank you so much, Vardman. Wonderful job done by MOS BOA to have this session going, the last day of the seminar. We have had some fantastic attendance, and everybody is eager to learn. And this is where everything in ophthalmology, or most of us are doing cataract surgery, whatever other specialty we may do or we may not do. 80% of our job is cataract surgery, and the results in cataract surgery, besides your skill, is the maths behind it. And sonography plays such an important role that if you are planning to do a toric lens and or a multifocal lens, you have no choice but to master the art of optical biometry and all the formulae you have. Out of all the lectures that you can hear in the days to come, this is the most fundamental lecture which can change your life and your understanding about the subject. And your confidence will go up the moment patient starts seeing distance, intermediate, near properly, and you've got your key formula for your LASIK patients, for your multifocals, for your high myopes, high hypermetropes. So the regular ones are okay, but what do we do when we have problems? To have the opening batsman with us, we have none other than Dr. Sumit Lane, Assistant Professor, Department of Ophthalmology, JJ Hospital. Sumit, thank you for being with us. Wonderful to share your views on what's going on with the optical biometry recent advances.
Thank you, sir. At the outset, I would like to thank MOS, BOA, Focus, and whole organizing team for organizing such a beautiful and a huge conference. And thank you, chairperson, and all the presenters for being here. I'll be starting with optical biometry recent advances. So basically, why do we need so much of evolution in the optical biometry? Are we not at the target? So there is a paper about NHS cataract surgeries, and they evaluated their data, and they realized that more than 90% of their post-operative results are within plus to minus one diopter range, which is very good. Like leaving -1 or +1 diopter, it's not that bad, and more than 90% are still doing it. Then still, are we not happy? The problem is we were happy even with the 50 glasses, but the patient has increased demand with the increasing with the evolving technology. So the patient asked post surgery that why can't I see last line clearly, doctor, with the -1 diopter left inside? And then we keep thinking this -1 diopter was a refractive surprise, and what went wrong? What am I missing? So when we have a checklist to check that where are we missing from measurement errors, so IOL calculation to multiple other things, IOL calculation holds a major stake of it because it could be anything which can go wrong in the IOL calculation. And most of the ophthalmologists, the IOL calculation is done by a technician and it's just rechecked by us. So then where are we in this IOL calculation? To throw light on that, we have a different optical biometers. I'll be majorly showing you these three optical biometers of IL Master 500, 700, and Lenstar. And they work with the different technologies, and the very advanced one in that is the Swepso's optical biometer. So what is so much of advance in this Swepso's biometer, and what is so much different about this IOL Master 700? So what is so much new here? What is the problem? What is something that is new with the snap source technology? So basically, it uses a wavelength of a higher length of 1050 compared to 840 what we used to use in our OCT, the partial coherence interferometry. Of course, it increases the speed and also the length of the scan by doing a sub source. Now, I will not go into too much of detail in the physics, but I will be talking about three very important things about this IOL Master 700. Very first is keratometry measurement, or in short, we can say total keratometry measurement. We all have done our keratometry using Bosch and Lomb keratometers, And now we do understand that we miss a lot of things using a manual or even automated keratometer. So in such cases, what does Oil Master do? It basically uses a technology called as a telecentric keratometry. Telecentric keratometry, there are multiple dots and their reflections are taken from the anterior and the posterior surface of the cornea. And there is an algorithm which uses the calibration to find the actual posterior values and not the assumed posterior values. Also, it uses power matrices for the thick lens formula. Now, what is this thick lens suddenly coming up? Thick lens is nothing but a lens in the physics they define as where the anterior curvature and the posterior curvature of the same lens are at a significant distance from each other. And a thin lens is nothing but where anterior curvature and the posterior curvature are very close to each other, so that the measurement of the focal distance either of from the curvature will be equal, but does not hold same for the thick lens formula. So our natural lens, it's considered as a thick lens, and so we need a matrix which will do a calculation for this thick lens formula. Now look at this. It gives you a keratometry, total keratometry, and the posterior keratometry. Basically, this total keratometry is an addition of anterior and the posterior keratometry and gives you the actual corneal power. Now, what is so much of difference in having a keratometry change in zero point 0.5 to zero point 0.7 diopter? So it makes such kind of a difference. Here I will show you. Now, using a keratometry, we calculate the IOL power, and you can see it's around plus 16 diopter with the plus 2 cylinder. And similar with the total keratometry, what power do we get is plus 15.5. This 0.5 diopter left out here is not your surgical error or the IOL position. It is basically calculation of your IOL by measuring the correct keratometry. So the total keratometry measurement is very important, and it can make a minute difference of 0.5 to 0.75. Especially it is very important when you are looking after a toric IOLs and you might go wrong by 0.75 diopter, which is not a very good result for a patient who is opting for a premium IOL. Has it been true? Let's see, basically what all of us are using at a different formulae, and we will be talking about it in the session further ahead. But the Barrett True K formula is what has been used universally now. And of course, it has been shown in the literature that its accuracy also increases with using the IL Master 700. Second thing I would like to talk about the axial length measurement. The axial length measurement, the good thing about the axial length measurement is it gives you the actual in the real-time image. So you can see a macula, you can detect any macular pathology, and you can do everything under direct visualization. So if there is a macular hole or there are certain changes in the macula, that can be very well visualized while you're doing an axial length measurement. Another thing is because you're using a higher wavelength to measure axial length, you can actually go through the denser of the cataract. Well, we have seen a lot of optical biometers, even the thin PPC exactly in the center, they're not able to help us, or even the denser cataract. But since you're using a different technology here, the measurement of axial length through the denser cataract is much more easier using this kind of a subsource technology. Another thing I would like to show you in this picture here, which has been hidden behind the axial length, is this green man. This is nothing but the anterior topography of the cornea. And again, this is very important. Suppose you don't have a topographer, or you're directly going ahead with the surgery in which you want to know the what is the how is the curvature and the rough mapping of the cornea. It can very well tell you, are you dealing with what type of astigmatism? It is irregular. Is your cornea irregular? And can you go ahead with the surgery, and can you plan a toric IOL in such cases? So all the readings in one machine and the real-time axial length measurement is actually a very important feature of this biometry, I must say that. Addition of the IOL formula, of course, there are IOL formulae which are inbuilt in the machine, including your Barrett suits, Barrett True K formula, Barrett Toric, and the Barrett True K without total keratometry. And all these are very much important formulae which we are using in day-to-day practice. And nowadays, you know, the Barrett suit formula is a paid one, but it is freely available along with the optical biometers. So of course, it gives added advantages. Since again we will be talking, I will not go in that detail of calculation of IOL power in cases of post LASIK cases, or even the silicon oil cases, where there is the different algorithm altogether set in the machine to calculate IOL in such eyes, which is again useful. I must say that since we are using IOL Master 700 here in a high volume center like JJ Hospital, our results are upgraded to a much higher extent, and the patients are much happier. Irrespective of the surgery done, let it be SICS or phacoemulsification, the IOL calculation and the post-operative refractive errors have become much more predictable than before now. Another thing before I end, I would like to talk about this is telecentric keratometry. Telecentric keratometry you must have seen in a lot of even topographers. The reflection-based topography is used. Telecentric keratometry is something where you need not adjust the distance of the patient's eye and the machine. In this, even at any distance or a minimal change in the distance, the difference between this small dots reflected on the cornea does not change, and they appear exactly at the same position where they appear if the patient is not sitting properly on the machine and still not keeping his chin properly on the chin rest. So a non-compliant patient does not harm your readings because of this technology, and even a not very much trained technician or the first time user can use this technology very well in their hands. So in conclusion, I would like to say optical biometry is becoming better with the technology. Optimal use of a proper machine and the repeated readings help in the better IL calculation. We would recommend that even if you have best of the machines, it's better to take two, and if you're not sure, three readings of the same patient to know that you are in the proper repeatability and there is no technical error in that. And the real-time IL calculation is the future to go. I thank you and end my slide, sir. Thank you for patient hearing.
Thank you, Sumit, for
Wonderful
your.
talk, Dr.
Yeah,
Sumit.
correct.
Thank you, ma'am. Thank you so much.
I don't see Dr. Ellen Kumar here. Is Dr. Ellen Kumar there?
Uh,
I guess we go to the next speaker. Dr. Vinod Arora, thank you for being with us, a very senior practitioner with so much of experience, right from Uttarakhand, to tell us what we need to know about the IOL formula. Sumit, one question for you. Is it Doug Coke,
yes,
according to
sir.
Doug Coke, for the keratometry, astigmatism with rule or against the rule? Which one can you kind of avoid? And you said total keratometry. So which is a better one?
So with the total keratometry, of course, we can take care of the against the rule astigmatism. That's what the advantage of this is, because we used to miss out this 0.75 error in most of our cases where we don't take into consideration the posterior corneal curvature. So it can be very well tackled in the toric IOLs, irrespective of it is being with the rule or against the rule astigmatism.
Thank you. Yes, yes. Over to you, Dr. Vinod. Thank you.
Yeah, thank you so much. Very good morning to all of you. Cataract surgery has now emerged as refractive surgery. Patient expectations have gone sky high. The big question is that, are we prepared for this demand? Patients are asking the very best. The talk has been kept to very minimal in 6 segments: patient selection and counseling, preoperative assessment, diagnostic advances, surgical advances, IOL advances, and lastly, managing refractive surprises. The patient selection is probably most important once you're going to practice. There should be right patient selection. We have to know about the lifestyle and job profile of the patient. Consider visual needs and patient expectations. Counseling is probably the most important for a happy outcome. Always under promise and deliver more. And we have to rule out the risk factors in these patients. These are the risk factors. These are small hyperopic eye, large hyperopic eye. I mean, these are the extremes, very steep or flat case, shallow anterior chamber depth, prior history of refractive surgery. It's coming in a big way. Now, LASIK is taking so much, and we are going to get more number of patients who has gone to refractive surgery. Then the vitrectomized eye, colonelactasia, contact lens use, it has to be measured after sufficient gap. And dry eye is again very, very important. We have to look for it. It's coming in a big way with the use of screen and other things. We are getting a large number of patients with dry eye. So preoperative evaluation and preparation. We have to do proper exclusion and case selection is important. There should be proper and professional counseling. That's the most important part for a happy outcome. Then soft lenses should be discontinued 1 week before, GP lenses 4 weeks before the biometry. We have to record the vision, autoreflectochrometry, corneal topography, subjective reflection, optical biometry. IOL Master and Lens Star are great instruments now. Fundus evolution and OCT. Dry eye again should be emphasized. It has to be managed first, then go for surgery. Take measures for prevention of CME. The special consideration, now we have to get the OCT should be done routinely, whether the patient is paying or not, it doesn't matter. You have to do it in almost all patients. Endothelial cell count, if you can do it, very good. Ocular surface examination has to be specially emphasized. Then the topography is required, especially for the toric IOLs. That's again very important to get a precise outcome. The IOL power calculation has been beautifully covered by Dr. Sumit. Optical biometry has become now the standard of IOL power calculation in clinical practice, as it is highly accurate, it's non-invasive and easy to perform. Sumit has already covered it very well. So just a brief, Lens Star and IOL 7 are the latest one. With Lens Star, we have a lot of features. We can get it, axial length, corneal thickness, anterior chamber depth, aqueous depth, lens thickness. These are the various parameters we do take the readings. And what it uses the Hill RBF calculator, which represents a new approach in IOL calculation. It is based on pattern recognition, data interpolation, and a validating boundary model for improved accuracy and confidence with IOL power prediction. So basically, it's not a formula. It's the outcome of what we have achieved so far, the data, based on the data. At present, the range is +6 to 30 diopter. It has got a wonderful website, rbfcalculator.com. So all the newcomers can go there. They can fill up the form and get it. It's free. You don't have to pay anything for that. Then coming the IOL Master, it's been covered. It can measure posterior corneal surface directly using soft source OCT. It is equipped with Barrett TK formula and Barrett TK toric formula also, which are very, very accurate. This is a machine which measures the posterior corneal surface. Then it is already incorporating Barrett toric calculator, but can get it free. I think it's not free, that Sumit was telling me, but it's available online now. Then there's a refinement in the surgical procedures also. A good CCC should be central, circular, and should be overlapping the IOL. It causes better centering, better refractive stability. That's again very important. Then femto, zepto, capsular laser has helped us to achieve perfect automated continuous curvilinear capsular access. Online toric markers are now available with Varion, and Aura has refined IOL implantation and proper orientation. So this system is designed to minimize chances for error by creating a seamless link of data from clinic to the operating room. So these things are helping us a lot. iTrace is a ray tracing aberrometer, which combines both the wavefront aberrometry as well as placido-based corneal topography. The iTrace helps in determining the true optical center of the eye, along with distinguishing between corneal and lenticular astigmatism. You have to remember that we have to treat only the corneal astigmatism, not the lenticular one. The Aura system is again very advancement is there. It provides guidance and verification for cataract refractive surgery. There is a continuous assessment of the patient's eye throughout the procedure. There are overall, we get the spherical power, we get the cylindrical power, and we get the alignment suggestion by this machine. There is a dynamic variable optimization and robust reporting with analyzing OR. Then there is improvement in the IOL also. The EDF lenses provide more continuous range from distance to near. They are more tolerant to milder macular pathologies. Trifocals has taken over multifocals, or rightly called as bifocals. The trifocals are more popular. So we are using EDF and trifocals now. Mix and match is also very popular. EDF is in dominant eye and multifocal IOL in non-dominant eye, or EDF in both eyes with one diopter difference called monovision or the micro monovision. Then we have newer lenses which are developing, like the light adjusted lens. The light adjusted IOLs basically are silicon IOLs, and power is modified by UV light. The refractive adjustment can be done post-operatively. It's FDA approved as RX site and can correct up to 2 diopter spherical and cylindrical 0.75 to 2 diopter cylindrical. Long-term studies are needed and it's expensive at the moment. The second is perfect IOL. It's a femtolaser based system. The changes are made by altering the hydrophilicity of IOL. So these are in pipeline, but at present they are very expensive and not in the mainstream. Then this is another IOL which is without haptics. There's a negative spherical aberrations. And we hope newer license IOLs will come and will take care of most of the things we have got. Now, these are the some specialty lens. This is a segment bifocal, then EDOF we are using already. This is a small aperture IOL. It's very important for corneal irregularities like RK patients. And if you had scarring or something, these lenses are very, very helpful. Then we have fluid vision in the back. This is a type of agmodatic lens. This is a Dynacurve sulcus implanted IOL. And this is a Sacriot macular lens, which helps to in macular pathologies. Then coming to the surprise management, I think Dr. Rajiv will cover it in detail. But we know that the cataract surgery is a refractive surgery now, and patient expectation are sky high. So we have to be maintained in spite of the best of instruments, best of technology, best of surgeons, we get surprises. So what to do if we get surprise? Prescription for spectacles. If patient is happy with spectacle, don't do anything. Don't try to be heroic. If he's happy, then let it go. Then you can try contact lenses. Most of the elder patient can't use it, but younger patient may be happy with contact lenses also. Then corneal surgery, that may be LRI, and that may be laser vision correction. IOL exchange in option, rotation of the toric IOL, piggyback implantation, IOL or ICL can be implanted. Rajiv Chaudhary is going to cover it. Still a brief about the mini RK. This is the incisional surgery, not has lost its importance, but if you don't have any equipments, it's a very economical process, and you can reduce the amount of spherical correction. So 4 mid-peripheral incisions are made, and it can correct up to myopia of 2 diopter. Quick, economical. It's not very precise. Glare may be present in some of the patients. Then laser vision correction is a good choice in majority of the cases. The advantages are there's no need of intraocular surgery. There's quick recovery, can correct any residual error. The disadvantages are higher order aberrations are increased. IOL surgery itself causes some higher order aberrations, and it can increase it further. Dry eye, that's very common in elderly patient. We have to be careful. It's the irreversible. Once you do it, you can't change it. May not be accessible at many centers. So coming to the other options, it's about this LASIK. Something has to be kept in mind that if you see a very complicated patient where you expect that there may be complication and you want a good result, you can have pre-surgery flap. After surgery, the tip is there, don't lift the flap. That's very, very important. You make a flap, it's preferably by a femto. If not available, then you can make it if microcrotom also. Don't lift the flap, do the surgery, and whatever refractive error is there, you can correct afterwards. Femto is preferred in these cases. Advanced surface ablation for small errors. Transepithelial PRKs are preferred in elderly patients for small errors. And dry eye is more common in elderly patients. Lots of lubricants has to be used. And remember, don't use mitomycin in these cases, as these corneas are already very, very stiff. Then IOL exchange is my last choice, but it's not the least. We have to use the blunt chopper. We have to bring out the lens out of bag. Then avoid as far as possible. Verify the problem, whether it's a irregular astigmatism or it required, do it earlier, preferably 1 to 2 minutes. There should be plenty of viscoelastic used to avoid injury. The disadvantages are difficult to remove IOL in some cases. Many cases cause trauma to rhexis, bag or surrounding structure. It may cause astigmatism. The result may not be perfect. Suppose you put a lens, and again, there may be some surprises. Then for toric lenses, I'll not go into detail, but you have got a beautiful site. It's called Toric Analyzer by John and David. It helps to determine if previously placed toric IOL is ideally aligned or not. By comparing the current location of the toric IOL to a patient's correct manifest reflection, the toric results analyzer can determine if rotating the toric IOL would decrease residual astigmatism or not. Then coming to the phakic IOLs, it has got a wide range. We can correct myopia, hypermetropia. The beauty is that it retains corneal asphericity. There is no regression, but it is expensive and long-term effects are not known. However, Indian version like IPCL are normal cheaper and it can be used easily. Since there is a bag, there is a lens in the back, it can be easily put without any further requirement. Then comes the piggyback oil. The indication piggyback lenses are hyperopia. It gives better outcomes than laser vision correction. Radial keratotomy, it's better choice. For insurance, because the lens is covered by insurance company, you can choose on those patients. LASIK is not covered. Patients generally experience rapid visual rehabilitation and excellent refractive predictability after piggyback IOL. Now we have a new styles of piggyback lens oil called Sulcoflex from Rayner and Sulcofix from Care Group. The advantages are it's safe, it's reversible, there is less trauma than IOL exchange, it's biocompatibly additive implant, post-operative friction has high predictability, there's a simple calculation, reversible procedure, explantation can be done at any time, unlike laser enhancement. A specific indication, it can be used to treat dysphotopsia also. The drawbacks are it's completely new concept. There's lack of peer review publication. Rotation stability is not that high, so it may rotate in some patients. Just to conclude, so we have a variety of options. We can go for IOL exchange. We can go for LASIK vision correction. We can go for piggyback IOLs. For myopia, LASIK vision correction is the best choice. For hyperopia, piggyback IOL or exchange is preferred. For astigmatism, we can have piggyback, we can do laser vision correction, we can do LRI. So at present, having a 6x6 and n/6 vision is a true thing. It's not a myth, it's in reality, and most of us can achieve it. Thank you. Thank you very much.
Thank you, Dr. Vinod. That was a lovely presentation to tell us that it is not a myth anymore, it is a reality, and we can always try our best. Even despite putting the lens and you might have a refractive surprise, there is always hope for the patient. We can't give up. And there are multiple options for that. Thanks so much. We are running short of time. Friends, just an announcement. I've just received, Dr. Sumit just told me that Dr. Ilan Kumar has got an emergency surgery, so he may not be joining us in time, maybe in the end. So we have our best speaker today right now. We have Chitra as the next speaker who's going to talk to us on biometry in extremes of axial length. Now this is something which is the most fascinating thing, because we can all throw a googly when it comes to a 1+56 lens or a -5 diopter lens. Thank you. Dr. Chitra needs no introduction. Extremely popular, very vociferous, and has super presentations. Welcome to the show, ma'am. Over to you.
And the chairman of the ARC, very dynamic.
Oh, absolutely.
That's the most important.
You keep seeing her on your emails, and you keep seeing her webinars regularly.
Thank you so much, Dr. Himanshu and Dr. Agni, and thanks a lot for this invite to BOA and the MOS program. And I think, having said it, that to be a part of this program over so many years, we've been coming to Mumbai, and it's a feeling of nostalgia that we have to do it on a virtual platform this time. But then hats off to you all for taking it off so well by dividing to 4 Sundays. So without ado, I'll go on to my talk. Now, there has been a lot of wonderful discussions on biometry and how it can impact the visual outcome and the needs of the patient. But the challenge becomes even more when we are looking at extremes of axial length. Let us remain cognizant of the fact that how whole thing has developed, like right somewhere in 1940s, if I'm not sure, the IOLs were first discovered, and it was in 1980s where Dr. Harold Ridley himself had the lenses implanted in his eye, and that's how the history has evolved. But today we stand at a platform where in 90% of the cases we can get within ±0.5 diopter of residual error. But yes, we need to be wary of extremes of axial length and post-refractive surgery corneas. Sorry. Oh my God. Not able to, okay. So then it becomes critical that we look at the biometry in detail and the cornea health in the process of doing a critical workup. So we also need to have a very brief history about how the intraocular lens power calculation evolved. It started off with the geometric axis, the theoretical formulas. Then came the regression formulas, which were based on post-op refractive results. And then came the Vergence and so on. Now, in the Vergence formula, what happened was they calculated by object Vergence with the lens Vergence is equal to the image Vergence. basically, what was the challenge with all these formulas were getting involved was the fundamental need was to get the effective lens position. And somehow they were all transgressing and they were not able to accurately identify this exact position. So the formulas came in with two variables, like initially there was only axial length and K, then Haigis brought in the anterior chamber depth, then came the Barrett's with the 5 variables and the Holiday with 7 variables to make it so narrow a difference so that we are able to be very, very exact in our calculations. And of course, the artificial intelligence Hill RBF really gave in a lot more information, and of course, the ray tracing. So how is it that the new formulas differ from each other? They differ basically because they have added more variables and brought in a greater exactitude in our power calculation. The effective lens position is where the lens sits in the capsular bag. Now, if this intraocular lens were to sit a little forward in the capsular bag, you need a lower powered IOL. Now, if it is sitting further back and stuck to the posterior capsule, you need a higher powered IOL. So imagine, even after all your calculations, where the lens sits in the bag becomes very critical. So then, is it bad to just keeping the older formulas? Like, you would have to optimize your results to understand how they all work if you are stuck with the old formulas. Now, Warren Hill's database, how it evolved was, he took up 250,000 of cases and looked into their databases, removed all the outliers, optimized the lens constant, and found, initially had some 3,400 eyes. They found that 78% of these eyes had within 0.5 diopter of the final visual outcome. But as time went on, as more and more databases got added on, they came in a less predictive residual error. We also did a study with the same normalized long and short eyes in our setup, some in the third generation formula with the Barrett's, and you can see that the third generation formulas have done well. They are more than 93.5 within the plus minus 0.5. But if you look at the Barrett's, whether it's long eyes or narrow eyes, normal eyes or short eyes, it was above 90%, getting less than plus minus 0.5 in all the visual outcomes. So then the next question is, would you have one formula which works for every eye? Well, that is not possible. Now, why? Because the dimension matrix of the human eye, the relationship of the axial length versus the anterior chamber depth is so variable. Now, if you look, a normal anterior segment and a normal axial length, if you see 73.4% fall in this category, whereas there are 6.9 who have a normal AC depth but a shorter axial length. There are 13.5 eyes who have a normal anterior chamber depth but longer eyes. And again, there are eyes which are small AC depth and small axial length and 1.8%, and something similar in the larger segment of 1.5%. So these are the challenges which have to be kept in mind. So then what do? Do we start putting in numbers in number of formulas and keep comparing our results? Well, that option is there, but you could actually, with practice, choose a formula that's best suited for their eyes. Like, let's understand that the older formulas do pretty well in the normal axial lengths. But when you come to extremes of situation as what I'm trying to discuss, the newer generation formula should and definitely be looked at. The advantage now of Barrett Universal 2 is it not only takes into account all these 5 factors, the axial length, corneal power, AC depth, white to white, lens thickness, lens factor, which is the distance between the iris plane and the posterior plane of the IOL. But it also now takes into account the changes in the principal plane which would occur when you're moving from a very low positive meniscus lens to a negative IOL. You have to actually enter axial length K1, K2 and refraction and AC depth, but optionally you could add the lens thickness value and the white to white too. So then going further, again I'm getting stuck. So sorry. So taking you further on, now if you look at the Hills RBF, initially they were optimized for +6 to +30 diopter, which is pretty significant. But then came the beta version, wherein the database has increased 12,400 and odd. So what they did was, many of those eyes which were outbound, which were not getting accurate results, with adding on more of data, there was a greater depth of accuracy and greater final optimal results. So what happens with the short eyes? I've already told you that there are variations in the anatomy of the short eyes. your body could bring you surprise. So we are cognizant of the fact we are not able to be very sure about the ELP because the anterior chamber depths can vary in these eyes. There was this intraocular lens calculation with 7 different formulas, and what came out of it is they're actually nearly okay. Probably the Hoffer Q and the Holiday was giving you some more myopic results, and probably also was giving more myopic results. But largely, there was no great superiority difference. We could go one step further in these very small eyes, like you could use a customized IOL, wherein you could use a full large power IOL, but there could be some spherical aberration, or you could use a significant magnitude in the capsular bag and the residual piggy bag, and thus manage the situation. Finally, if you have a residual error, you could still do bioptics, or you could put a piggy bag as I had discussed with you. Like if it's a if it's a non-ophthalmic eye, what you could do is like you could place a sulcoflex lens in the sulcus, and it has undulating haptics, and there is a posterior curvature difference which sort of increases space between the primary optic and the
Internet.
I guess she's got internet problems. She should be back in a short time. Yes, Chitra, you're back. Chitra, my recommendation: if you can switch off your video, your presentation can still go on. Your bandwidth is great. Your bandwidth is great.
Yeah, just a second. I'm really at the
No,
end
no
of it.
problem.
Can
No
you see
problem.
me now?
No,
Uh,
I can
the
see
challenge
you.
that
You're
in a
back.
cephaloma, in a cephaloma, what can happen is that you could
Share
be
screen, please.
challenged.
Chitra, your slides, yes.
You can't hear?
Yes.
Can you hear me?
Yes.
Yeah. So then the Barrett's Universal and the RBFs would be an ideal. And of course, Bangkok, as I would be able to explain to you. I really don't know why I'm bored. So what happens is the incidence of cephaloma, let's keep in mind, increases as the axial length increases. So the need to be exact becomes even more critical. Now, what happens is, if you were to use your immersion biometers, you would be only measuring the anatomical axial length and not the refractive axial length. And so therein itself, you will end up measuring a longer axial length than what is actually there. And then that would be bringing on a refractive surprise. So then what happens is, supposing you do not have an optical biometer and your ultrasound is not so idyllic, you could combine a vector A and B scan. Of course, if you have the Barrett Universal formula or the Hill RBF, you're way ahead in the game. But Bangkok came in with another information is like in extremes of axial length, even your optical biometer might erroneously give you an increase in axial length. So he says that because the vitreous body occupies a large space in these very long eyes, and that could impact the refractive index and the measurement. So he says that if you incorporate this constant optimized optical biometry axial length calculations, then you are quite bang on. So what I would like to conclude saying is that yes, we have come to a point where we understand it all. But I would want all of us to keep going back to re-understanding biometry, try to understand more of the IUL power, try to understand everything so that it is not just improvising our surgical expertise, but you are trying to find out all those small nuances which get us wrong. And if we use that and that extra counseling, which was so beautifully discussed by Dr. Arora, I'm telling you, we would be way ahead and constant in achieving a target emetropia in all our cases. Thank you very much. Very sorry for those issues which happened. Thank you.
Dr. Chitra. That was wonderful presentation as usual. But let me just get a carry home message for the common man like me. If it is a high myope with 27 axial length or a high hypermetrop with 18 axial length, what formula should I be using as of today?
I would definitely stick to Barrett formula. There is no doubt about it because the consistency is so much there. Of course, Hill RBF is there. I mean, there is no doubt, but because of the ease of accessing Barrett's even online, if a person doesn't have the IUL Master 700, you could still get away with it.
Which are the top two formulas? If you're looking at two formulae to compare so that you are consistent in your answers, which are the top two you would go for high myope, top two for a high hypermetro?
Like Barrett's actually is one formula which fits in for all these situations, be it short eye, long eye, or or in post-LASIK eye. But let's understand that if you are a younger practitioner who have not got your optical biometer, if you're having your immersion biometry and you want to access the Barrett online, you should remember that there is a difference in the acoustic length measurement optical for ultrasound for optical biometer that you need to enter in your final calculation and then go on to get your measurements.
Thank you. So friends, ultimately ma'am is trying to say very simple for beginners. Don't worry if you don't have IOL 700 with you. Online calculation free of charge is available. That's the bottom line. And Barrett 2 looks to be one of the best answers as of today, consistently in high hypermetrop or a high myo. Right, ma'am? And thanks so much. We come to our next speaker, Dr. Vardhaman. Again, a very dynamic person and an extremely prolific surgeon doing anterior segment and refractive surgery with a lot of good presentation, a lot of accolades to him. He's got a lovely, I don't know whether he's in Switzerland Alps right now, but where is he? But he's having a great thing. IOL power post-refractive surgery, the problem. Now, this is the biggest thing which is going to hit us in the days to come as more and more LASIK surgery, Vardhaman does more and more. His dad was doing so much. So as more and more of these these refractive patients come to us to calculate the correct, because these patients are going to be extremely demanding. They have tasted blood not to see the world without glasses. And now the whole thing has changed, and to give them a multifocal is a different thing. To get a correct axial length is a difficult thing. And worse comes to some of these patients whom you see who had a cornea touch by RK and somebody did a LASIK on them and then somebody had a detachment together with it. Now this is how difficult it can get for you. Vardhaman, over to you.
Thank you so much, sir. I think thank you for that great prelude. Before I go to my presentation, there is a small request from Sumit that they want to play a very short presentation for Zeiss. So I'm going to just request him to play it and then I'm going to start my presentation. Over to you, Sumit.
Is the screen visible, sir?
Yes. Yes, yes.
Blank the screen.
Thank you, sir.
Thank you. Thank you, Dr. Himanshu, sir, for the kind introduction. I hope my screen is visible.
Yes. Yes.
Yeah, thank you. Thank you. So I think we have had excellent presentations about giving great overview of how to calculate power after in normalized, in extremes of eyes, how to be the best in these calculations. And what I'm going to take you through is a bit of path which can be erroneous. I mean, it can lead you to, if you just stick to normal formulae, you're going to have hyperopic surprises, myopic surprises, and stuff like that, depending on whether a patient has undergone myopic lasers before, hyperopic lasers before, etc., etc. So the thing I'm going to discuss with you is why this happens, the biometry after previous refractive surgery, what is the problem statement. And following after my talk will be Dr. Vavikar's talk. He will be giving us the solution for it. So friends, I'm going to give you a bit of background to tell you why the biometry is erroneous after corneal refractive lasers, as we discussed. If we look at this refractive surgery timeline from the early 1940s till now 2020, we have truly come a very long way. There have been so many amazing path-breaking procedures which were invented by all these geniuses. And this has really made refractive surgery a very popular entity globally. But what really made refractive surgery a global phenomenon was the invention of LASIK procedure. The first LASIK, when it was performed by Professor Palikaris, it completely revolutionized the laser refractive surgery world over. The reason being, of course, that it was a quick procedure, a painless procedure, a procedure which had a lot of wow effect and great amount of stability. So no wonder that this procedure became extremely popular and a global phenomenon. And from that time till 2020, the current estimates, they actually show that the LASIK has been performed in over 40 million times. Smile has been performed over 3 million times, and ICLs have also been performed over 1 million times. So if I look at this problem statement, is that these people who have undergone the previous refractive surgery are in the tune of about 40 to 50 millions of people. So if I just give you a glimpse of it, if you look at the population of the entire United Kingdom today, the people who have undergone laser procedures or refractive procedures are almost similar or more than what reside in the entire United Kingdom as such. Right. So what is so special about these post-refractive surgery patients when they come for cataracts? These post-LASIK patients have seen a wow effect. They have seen instant results. They have seen extremely accurate results. These are the people who have enjoyed great quality of vision all their life. So they are also the people who will have a relative intolerance or diminution of quality of vision also. In fact, even in very early cataract stage. So they demand early cataract surgery. Along with that, they are very demanding as well because they demand a LASIK-like outcomes after their cataract surgery. So they are very demanding because they feel that after the cataract surgery as well, they would like to be spectacle-free. And ironically, in these very patients who desire the most accurate post-operative refractive results after cataract, the IOL power calculations are risk predictable and most erroneous. So this is where we are going to find a solution today. So before I make you understand why this happens, let us understand some basics of it. So how do we calculate IOL power in virgin eyes that we have just seen, right? So we all know that if we have to really categorize the IOL power formulae, we know there are regression formula, which depends on which depends on the past accumulated data, and regression analysis, which was followed by theoretical formula, which depends on mathematical calculation, and there are some combined formulae. So when it comes to the regression formula, which came first, was we all know about SRK formula. So in SRK formula, the IOL power dependent on A constant, on keratometry, and also the axial length of the patient, of the eye. However, it was seen that the A constant is not going to be a static phenomenon. So it had to be improvised. Therefore, a new formula came, which was called as the SRK2 formula, which adjusted the A value according to the length of the eye. So it was seen that the A value has to be bigger for shorter eyes, and A value has to be smaller for longer eyes or myopic eyes. After that, the theoretical formulas, they came into the place. The theoretical formulas, as we discussed, they depended on mathematical calculations, and they depended on a concept, what is called as ELP. What is a ELP? ELP is an effective lens position, which is defined as the distance between the anterior refractive surface of the cornea and the principal plane of the implanted IOL. So in the beginning, again, it was seen that the ELP is constant, which was 4 millimeters. But again, it was noted that the ELP has to be adjusted according to the length of the eye. So for shorter eyes, the ELP has to be smaller. For longer eyes, the ELP has to be longer. And this prediction of the ELP or the accuracy of the prediction of ELP decided how good was the formula. So as we can see, all these formulas, we started from second generation till the fifth generation, which is the Higgs formula. The ELP was predicted depending on certain parameters, like in SRKT formula, the prediction was done according to the A constant, keratometry, and the axial length. And as we go along, more and more parameters were added to that. So if you really want to see what is happening here, you will see that the first 5 formulae, they depend to predict the ELP on keratometry. So they're all keratometry dependent formula, except for Higgs L formula. So let us say that in the virgin eyes, it is very important that you get very accurate keratometry, and it is also very important that we get very accurate ELP. So why the IL calculations are erroneous on laser eyes is basically because after the laser has been done, both the keratometry as well as the ELP gets erroneously represented. And we are going to see why. So there are three sources of errors which happen after the corneal laser procedure. The first one is the index of refraction error, which is also called as a K reading error. The second error is called as the instrument error or a measurement error, which is basically the errors in the way we calculate the keratometry. And the third one is the formula error, which is also called as the ELP error. So let's look at the first error, which is the topography or keratometry error. It is also known as the measurement error. It is also known as the radius or zone error. So friends, as we all know from our basics that the keratometers as well as the Placido-based topographers don't calculate the keratometry of the cornea in the center of the cornea. They calculate the keratometry at 3.2 millimeter zone. And then they extrapolate this keratometry to the central cornea. And we all know very well that if we want very accurate keratometric calculations, we actually need keratometry not from the periphery or the mid-periphery. We require the keratometry from the central cornea, which is exactly what is missed in this topography and keratometric measurement errors. Of course, there are solutions to that. I'm not going to dwell into this right now, but Dr. Bhavikar sir will speak to you about this in the future. So the second error is called as the K reading error. It is also called as a keratometric error or index of refraction error. Again, going to the physics of the basics, you will see that the keratometry is a formula which is calculated by an equation, which is 1.3375 minus 1 into 1000 divided by the radius in millimeter of the cornea. So this keratometry reading is very, very accurate if the ratio of the anterior corneal surface and the posterior corneal surface is fixed. It is 1.21, which is true for all virgin corneas. However, as we all know, after somebody has undergone a corneal laser procedure for myopia, the anterior refractive surface is going to become flatter. Therefore, this ratio of anterior upon the posterior radius of curvature of cornea is not going to be holding true to 1.21. So what is going to happen here is there will be an overestimation of the K reading that you will see in patients who have undergone myopic refractive correction. How much is this overestimation? For every 7 diopters of correction, you will see 1 diopter of overestimation of the keratometry. And this is exactly what leads us to under representation or under prediction of the IOL power, leading to hyperopic surprise in myopic refractive errors. Correct. When we go to the opposite side, in which somebody has undergone a hyperopic ablation, you know that the corneal refractive surface becomes more steeper in the center. Therefore, in this case, the keratometry is underestimated. Therefore, the IOL power is overestimated. And that is the reason in patients who have undergone a hyperopic treatment in the past, they typically have myopic surprise after the cataract surgery. So we have seen these two errors which were related to the corneal keratometry measurement or corneal dioptric value measurement. Now the third error is about the ELP prediction error. So friends, this is what is called as also a formula error. We have all seen that when we look at the formulae which are used for virgin eyes today, majority of this formulae, they depend on keratometry to get the prediction of ELP. And just before this slide, we have seen that the keratometry is overestimated in patients who have undergone myopic ablation and underestimated in patients who have undergone hyperopic ablation. So if we consider that fact, then you will understand that the formulae which are called as K-dependent formulae will actually give you an erroneous prediction of effective lens position. Because again, when after myopic treatment, you have an overestimation of keratometry, you have an underestimation of ELP calculations. In hyperopic treatment, when you have an underestimation of keratometry, you have overestimation of ELP calculations. And both these factors compound now addition to each other, and they give rise to very erroneous outcomes when it comes to biometry after the corneal laser procedure. So this holds true even if the patient has undergone PRK, even if the patient has undergone LASIK, femtolasic, or SMILE. However, in RK, in addition to all these errors that we have spoken about, there is one additional error which is called as a corneal instability error. This corneal instability error happens because the corneal incision in RK can sometimes open up or gape after the cataract surgery, and they take a long time for them to stabilize. Therefore, people can have lot of fluctuation in the refractive results after the post RK cataract surgery. Along with these errors, we all know that anybody who has undergone a corneal refractive procedure has dry eye, and the dry eye is one of the major reasons to have uh, a very unstable calculation of keratometric data on topography as well as after IL master. Along with that, you induce spherical aberrations after any corneal laser procedures. So your IOL, not only the power, but even the type of the IOL has to be really chosen very well, depending on whether the patient has undergone myopic refractive error or a hyperopic refractive error. And the last is that although they are uncommon now, but in the past, there have been a lot of people who have had topographic issues, such as small zone central islands, and that pose, of course, even in addition to that, a further challenge in calculations of our IL formula. So friends, what we have seen is that when the LASIK became very popular, that generation was called as baby boomer generation. So those people who were in their 30s that time, after about 30-35 years now, these are the very people who are there in 60s and 70s. So we are going to see a big wave of cataract surgery for all these people who have had refractive surgery in the past. And therefore, considering that you can have all these issues and erroneous calculations because of the basics that we have just discussed, has to be of paramount importance that we calculate the IOL power very well in these patients, and which is going to be dealt with in the next talk by Dr. Vavikar sir. So again, I thank BOA, Dr. Ragini ma'am, Dr. Sumit, and the whole team for the kind invitation. And thank you very much for your kind attention. Thank you.
Thank you, Vardhman. Thank you very much for a wonderful insight on the whole subject. We are running a little late despite everything. I invite the next speaker, Dr. Vavikar, who's a mathematician, incidentally, a very wonderful surgeon also, with great insights. He has a great understanding about physics and mathematics besides the science of ophthalmology. And it's always a pleasure to speak whenever there is calculations and how do we do that. So once having identified the problem that Vardhaman did, what is the solution? Post IOL power post refractive surgery. Over to you, Dr. Vavikar. Thank you for being there.
Good morning, everybody, and thank you, BOA, MOS team, for giving me this opportunity. Thank you, Himanshu, for those kind words, and thanks to Dr. Vardhaman also for giving an excellent presentation, paving the way for my presentation. So this is the part 2 of our presentation, that how are you going to solve it, the problem. Now, friends, our illustrious colleagues over the period of so many years have developed the formulae in a very, very detailed manner. And today our focus is not on discussing actually how these formulae work, but on how are we going to make use of this formulae. So I'm not going to go into the theory a lot, only as an introduction. So for correction of this, there are 3 approaches you can take, whatever problems which are encountered and explained by Dr. Vardhaman. You can use a Vergen's formula, or you can use some corrections to the regression formulae, or you can improve the accuracy of the measurements. Now, Vergen's formula is a very simple formula where you convert the aphakic refraction into IOL power. The prodigy of this is piggyback IOL. When you have very high hypermetropic patient, you can do surgeries in 2 sittings. And second thing is the aura, or the intraoperative aberrometry. Aura is certainly a concept of the future, but even in normal cases, the accuracy as of now is around 60 to 70%, and it is just to be firmly established. And therefore, we are not considering it for this specialized IOL power calculation issue. So how are you going to correct the errors in regression formulae? So now there are 4 methods I have written here, but there are more methods. This is not an exhaustive list, just an indication of how different approaches are taken. For example, in double K, the pre-LASIK K are taken for estimation of ELP. Then in EKR, it's a pentacam report. There is some regression formula which is used to convert corneal K readings corneal power into EKR, which can be directly used into holiday 2. IGCL uses ACD for the ELP estimation and so on. So we have gone a little ahead with this. We have made some progress, but the real progress seems to be happening with improving in the accuracy in the measurements of the corneal curvature. See, there are two areas. One is the corneal measurements, and second is the ELP. ELP is a purely a calculation. Improvements are occurring. We have to do distinct improvements in the accuracy of the measurements. So Barrett-Truque came with a much better, calculation or estimation of the posterior cornea. Similarly, surgery, ray tracing, there are more techniques which are giving us much better reading even in the center of the cornea, as we know that everything is happening around the visual axis of the patient's eye, and which is quite inside the place where care readings are taken. So with this, we have gone quite a far ahead. Now, how are we actually going to do it? Some people may have instruments which have this formula. Some people may not have. But even though I have IOL Master 700, I still go to ASCRS website every time. You choose which procedure has been done: myopic LASIK, hyperopic LASIK, or PRK. And then comes a very busy sheet. Most important is to read the lower part where all the instructions are given in detail, and fill as much data as possible. So there is a pre-LASIK data, then post-LASIK data, the current refraction, corneal thickness, your tomographer information, whether you are using Pentacam, Galilei, whatever, even topographer, but more tomo is more important, etc. And you fill this and you get an output. The output is that you get IOL power calculation by multiple methods. I will show that sheet a little while. Then when we go to toric calculation post refractive surgery, the only thing to fall back is on Barrett-Truque toric. It works very well. It is available on APS series website free of charge, and there is a formula guide. Very, very important document. One must read it every now and then, because every time you read, you pick up some new point. And this is the standard sheet using Toric-Truque, Barrett-Toric-Truque formula. Now, these two slides are perhaps the most important part of this presentation. What are the current best practices? So use as many formulae as possible. Smart averaging has to be done. Consensus is on, I'm just shift the video pane here. Consensus is on using multiple formulae, but we have to rely more on average IOL power, Barrett-Truque, and OCD-based formula. And post-op analysis, OP, I'm sorry for that. Post-op analysis is also very, very important. It makes you understand a lot of things. Then, as far as the toric is concerned, Barrett-Truque toric, as I already said, it's really excellent. Regular bow tie within the central 3 mm of the topography will give you very good results. Otherwise, the calculations can go haywire. Consistent magnitude and meridian of the astigmatism has to, or the cylinder has to be there from multiple devices, even though the boundaries are broader than normal cases. And we have to have a conservative approach. That means do not overcorrect. Now, historically, what has been the situation? So you see post-myopic results within plus or minus 0.5. Now you will see that using prior history, the results are much better than without history, no history matter. In no history matter, OCD and Barrett-Truque no history appear to be doing very well. In hyperopic LASIK, Barrett scores, whether you have history or not, Barrett and IGCL are the only ones which are reaching 70, and Barrett, no history, is actually getting 73.4, which is the highest up till now. Then if you see RK results, similarly, Barrett is the only one you see it is crossing 75%. So out of 4 patients, 3 patients will be within plus or minus 0.5. Now, let us take 2 examples to illustrate the point. One example where I did a good job, and one example where I messed up a bit. Okay. Now, 43-year-old male patient post myopic LASIK, and the IOL power shown by 3 formulae, and the average was 17.92. On IOL master, Barrett Truque showed a IOL power of 17 diopters. So we implanted Ultracert IQ, 17.5 diopters were shown on Barrett Truque, and we implanted 17.5, and patient was plano 6.9 on post-op day 3. So this is a very good result. Now, another result where I was in a catch-22 situation, 64-year-old lady with 32 cut RK. You can see that the optical zone is small because it is a arcade times, but still it is a very regular bow tie. So we decided to go ahead with the toric IOL. And these are the calculations on toric IOL. And you can see that the astigmatism is 1.63 at 4 degrees. And this is the ASCRS output. You can see that the average IOL power is 28.55. Okay. Now, when I did the calculation on IOL Master 700, Barrett Truque toric showed the calculation of 27 diopters. So we went ahead with 27. This is not what ASCRS shown. It had shown 28.55. But because somehow I thought that this is more accurate, I went ahead with this. And now look at this chart. This is the post-op refraction, day 3, 1 month, 3 months, like that, up till 8 months. The sphere has continuously reduced from 4 to 2.5 to 1.75. This is because of the edema of the RK scars, what the point Dr. Vardhaman alluded to. And the cylinder shifted from 0 to -5 and then back to 0. So over here, Barrett, the toric part was done very well by Barrett, and the spherical power prediction was done very well by the ASCRS. So if I had gone by the IOL power spherical done by ASCRS and only the toric by Barrett Truque, I would have been absolutely on target. Thank you very much.
Thank you very much for sharing your experience, Dr. Bhavikar. Friends, as I said, wonderful. We must have a full lecture by him and Vardhaman to tell us, because we are going to have lots and lots to study about that. A 3-hour lecture would be insufficient, because that will clear the fundas on the bottom line of managing post-refractive surgery patients. But we are running short of time, and I invite another great friend and a great speaker and an excellent clinician, Dr. Rajiv Chaudhary, to speak to us today on refractive surprises after cataract surgery. That's a lovely topic. This is what bothers everybody. Every time we see a post-op patient following any refractive surgery, cataract surgery done after that, there are so many surprises that we have, and we are always scared what are we headed for on the day 1 or day 2 of the surgery. Over to you, Rajiv. Thank you for being with us today. Arup, are you there with us? Arup?
Yeah, I'm here.
Okay, great. You will be next. Thanks.
Thank you, Himanshu. I am audible?
Yes.
Yes, you are.
So my topic is the refractive surprise. Now what? We have heard a nice topic on IOL power calculation and how to manage, and probably we go through all this. The need of this surprise will be very minimum. But still, we can get this unexpected when dealing with unusual eye of the cataract surgery, like extreme myopia, hyperopia, large and small eye, as discussed post-RK, PRK, or LASIK post-RK patient. The limitation, because we have discussed all that the power calculation, how accurate may be, but there is some limitation in the accuracy and difficulty in unpredictability of effective lens position, and imprecise determination of corneal power due to previous keratorefractive surgery. Variables such as capsular bag diameter, for which no precise and practical measurement still exists. There is multiple problem with SPK, PCO, tear film abnormalities, which can affect our oil power calculation. So one realize, again, if you realize there is a surprise, you should recheck and reperform all of your calculation. Make sure that right patient had, because you have had the right patient, right lens, right data were pushed. Once you have a surprise, refraction may not be stable immediately after surgery in some patients, especially in RK and crystalline. And no residual refractive error in operated eye rather than eye just don't work together. Hence, consider the binocular situation and not just the monocular situation. So we have the option. You have the option of the glasses, contact lens, corneal refractive surgery, lens exchange, piggyback lens, light adjustable lens, as discussed by Dr. Vinod. So what to do? When refractive surprise occur, stay calm, be patient, advocate, and don't let the situation become adversarial. Preoperative counseling can help in this type of RK, PRK patients. Then when should PRK or LASIK be done? Never sooner than 1 month after surgery. Preferably 3 months when the refraction is stabilized, and especially for a small amount of refractive error. It is the advantage, avoid additional intraocular surgical procedure, provide better accuracy than IOL exchange, give a higher predictability of the result. LASIK is well tolerated in eye with previous, if you have done the YAG. And once YAG performed, IOL exchange may be slightly difficult and give the more complication. Then when we should go for lens exchange, when there is a significant refractive error, problem with lens itself, multifocal or damaged diffractive surface of the optic, then you should go for the lens exchange. Oil exchange may be associated with increased risk of capsular rupture or jonular dehiscence with vitreous loss. And one cannot be confident that the replacement of oil will be implanted in exactly same plane as the original plane. It is one of the video of lens exchange. Is a post-RK patient. The oil power calculation was slightly incorrect. Use good viscoelastic behind the lens, slowly dislodge it from into the anterior chamber. You can use a special forceps also to hold this, or this simple hook and scissor will help.
Rajiv, your video is not playing. In case you got a video, the video is not playing.
Okay. Sure.
Something is wrong. You can escape it.
कैसे?
Rajiv, you can escape it.
Okay. It is coming now?
Yes.
Yes.
Yes. Lovely.
Just dislodge from the back. And you can have a special forceps to hold the lenses, but this hook and pana scissor will help. This is the RK patient. You can divide into two, or easily you can remove. Only thing you have to take care when you are dislodging from the back, that this should be gentle. And the lens has been done.
Raju, anything left, or are you through?
Yeah, no.
Okay.
Yes. Okay. Then another option is the piggyback lens. Why piggyback preferred over the IOL exchange? Reopening the capsular bag is not required. Cutting and explanting the primary IOL is not required. Oil power calculation for piggyback oil is for myopic refractive error. Power of oil is equal to the desired spherical exchange. And for refractive hyperopic, you have to multiply 1.43. Nowadays, we may have the toric piggyback also. These are the Sulcoflex lenses available. Single piece hydrophilic acrylic lines, 12.5 millimeter optics, PCO not consideration with this design, and decreased occurrence of PDS and optic capture. Spherical monofocal design, and this I will show you the video. No? This one. This is the piggyback lens, Sulcoflex lens, and it is simple. You just put in the bag and simple surgery. So we avoid any capsular problem. Sorry for the easiest surgery. Then we come to the, as we know, discuss light adjustable, not available at, allow the possibility of the correcting post-operatively. Malposition we can correct. I will just skip this video. So patient should receive multifocal or accommodating oil, appear to be more sensitive to mild amount of PCO, that should be taken into cover. Post-RK cases may take a month after cataract surgery for the eye to reach its final reflection. So you try to correct them after that period. Now I come to one interesting case of the 40-year male underwent cataract surgery, OU, OD fast, then OS, 5-month back. Both were the monofocal oil implantation. Both has the 6/6. Patient comfortable with the one eye, but not with the other eye because of the severe dystrophy. Even the vision was. Just I am going to highlight the importance of the, after multiple counseling, 3-month patient tested on eye trace, findings show that in increasing pupil size, patient vision was blurred and there was more of the visual aberration. You can see this, there is a corneal internal aberration, total eye aberration was much more. This is with the patient 6/6. Eye trace finding shows this, there is a aberration and with increasing pupil size, the aberration, total aberration increase, and the mostly it is internal. So we tested and the eye test showed that there is some toric element in this monofocal lens and that suggested 62-degree rotation. It's the monofocal, probably this because of the force capture, there is a slight tilt in the monofocal lens and that giving the toric effect. So we tried to rotate it. Based on this finding, patient IOL was rotated, back fibrous was released. And the post-reduced visual aberration, improvement in the quality of vision, and you can see that post-operative the correction. It was the monofocal which was rotated in the back. I have not shown the video because, and you can see this eye trace finding that it's all the aberration, internal aberration is reduced. So in short, attention to the preoperative anatomy and the condition and surgical history of the eye, expected and unexpected refractive surprise, control and management, less predictable cases, explain to the patient about the second procedure. In this era of cataract refractive cataract surgery, critical for a surgeon to adopt a successful enhancement strategy for the correction of residual refractive error. Piggyback IOL, LASIK play important complementary role in the pursuit of the spectacle independence for the patient. Now, there is the availability of ORA and halos, which give you an operative intraocular lens power calculation, which is probably not available at us. These are the on pipeline. So thank you, friends. And thank you, Buya, for calling me here and joining with you all. Thank you, Himanshu.
Thank you, Rajiv, for sharing your experience. We are running short of time, but that case was very interesting, wherein by just rotating your monofocal lens, you removed the aberration. We
Yeah,
should. Uh, we'll,
I can show you. I can show you the video also.
no, we are not. We are running short of time. I would want to come back to you on
I'm
that.
not. I will stop because that rotating
No,
monofocal doesn't give any good surgical. It is simple. Just rotate
so
it.
what is
Your
your logic? Was it the because it was partly in the back?
because the eye trace showed that it has some toric effect cylindrical and that causing the. So we tried because it was monofocal 6/6 vision, and patient was not happy. So just we took the chance.
No,
Any
good,
problem in
good. That's
rotating
exactly
the
how we
lens?
learn. We learn by default. So thanks so much. But we have our next star speaker, Dr. Arup Chakravarti, who is a wonderful speaker who keeps sending us lovely emails on all the current advances in various fields of ophthalmology. Always omnipresent in every conference that we've seen him over the years. It's a great pleasure to introduce him today. He's going to be speaking to us on post-vitrectomy IOL power issues. Something very important with, as he said, post-refractive surgery. And here you have somebody from the posterior segment, post-vitrectomy IOL power issues. Go ahead. Over to you, Arup.
Good morning, friends. Himanshu, am I visible? My slide is visible?
You and your slide.
Am I audible?
Yes.
Yes.
Okay, that's great. So at the outset, I'd like to thank the organizers for giving me this platform to share my thoughts on a topic that is very close to my heart, something which I have been doing for the last maybe 25 years. So as we all know, uh, the cataract surgery has become a refractive surgery today, and we are seeing never seen before results. And this concept has been extended to complex cataract scenarios, and some of which have been discussed in the previous lectures. And there is also a tendency to extend this concept to selected cases of cataracts associated with posterior segment pathology. And to be more specific, I'll be talking about post-vitrectomy cataract scenario and nothing financial in what I'm going to talk to you about today. And there are basically 4 hurdles to be crossed. Axiometry may be quite challenging in these situations, particularly when there is a silicone oil fill in the posterior segment. It may be challenging also when these patients come with a very advanced cataract or have a regmetagenous retinal detachment or have a macular edema associated with epiretinal membrane or macular holes. So I'll be coming to it in a short while from now. So once the axiometry has been done and we have obtained reliably obtained the other biometric parameters, they have to be used in an appropriate intraocular lens formulas. There have been a lot of new generation formulas that have come up, which have been doing pretty well. How do they do in this scenario? That has to be figured out. So I'll be talking about in a little while of this topic too. And the question of target refraction, target intraocular lens power is target refraction is very, very important, particularly when you're dealing with silicone oil filled eyes, and where we plan a long-term retention, and in certain other scenarios where you're not very sure about the biometric parameters. And finally, the IOL shape factor also plays a very important role. So let me take up these issues one by one. Before a patient is posted for any posterior segment surgery in our center, we routinely perform a axiometry, preferably optical biometry, and if it doesn't work, an acoustic biometry. And that is archived in the hospital, and the copy is given to the patient also for safekeeping. So these kind of bypasses the scenarios where a patient who has slipped from this protocol and has come back again in our own patient with very advanced cataract with silicone oil in the posterior segment, or a patient operated elsewhere where you really have to measure the axial length once again, and that can be pretty challenging. Again, optical biometry comes to our rescue, and it does pretty well, even in eyes which have silicone oil fill in the posterior segment. But it has certain requirements. The patient requires good fixation. It does not give good results in patients with advanced or total cataracts, thick posterior subcapsular cataracts, etc., etc. And so we do have to use ultrasound A-scan biometry in these patients, and then our real problem begins. We all know that ultrasound velocity gets attenuated in the silicone oil, whenever there's a silicone oil, and the extent to which it happens depends upon the viscosity of the silicone oil, whether you're dealing with 1,000 or 1,300 or 5,000 centistrokes of of silicone oil. Now, basically, you may not see good retinal echoes as you see here. And if the silicone oil bubble is not full, you may have shifting or reduplication of echoes. And sometimes the axial length measurement, if at all it comes in your scan biometer, it may be outside the range of the machine, so you may not get any reading. So in situations where do we get a reading and how do I get the reading? I'll come to it in the next slide. You may have to convert the apparent axial length to the true axial length. Because as I mentioned earlier, the velocity of sound comes down in silicone oil medium, and you have an apparently large axial length, the vitreous chamber depth, and so that has to be converted to the true axial length. Now, so this is what I do in my situation. I set the velocity as 1532 meters per second for all my patients where I have to do an A-scan biometry with silicone oil in the posterior segment. And if you see here, the axial length is divided into compartments. You get the anterior chamber depth, which is 2.66 millimeters here, and the lens thickness is 4.38, and the vitreous cavity depth, it is 29.24. And we know that, if it is a 1,300 centistroke silicone oil, the velocity is 980 meters per second, and they have used a velocity of 1532 meters per second. So definitely we require a correction factor for both the lens thickness as well as for the vitreous cavity depth. So this is the formula that I use. I mean, that is recommended, that the true axial length is equal to velocity of sound in the media that is in question by the velocity that has been used, that is 1532 into apparent axial length. So if you see here, the total length I had got was 36.28 millimeters, but after applying all these corrections, it comes down to 25.69 millimeters. Vitreous chamber depth, which was 29.24, is actually 19.85. And if this patient is put on the IOL master, you get a length which is again 25.70 millimeters. So this thing works out pretty well. But in certain situations where you have a very basic A-scan machine where where you don't get the compartments of the axial length, the different segments, or then sometimes even advanced machines, the silicone oil is emulsified and you may not get the proper echoes. In that case, I'd be using a velocity of 1532 meters per second, measure the entire axial length, and multiply it by a factor of 0.1 if a silicone oil of 1,300 centistrokes has been used. And that is the most commonly used silicone oil in our part of the country, where I practice. So this also gives you the axial length. Now, in certain situations when you don't get the axial length at all, there are certain last resorts, like one can do a CT scan or an MRI. MRI is more accurate, but these are more expensive. You can go by the axial length of the fellow eye, you can use a standard power, or you can do post-silicone removal biometry, find out the power of the eye, and then select the intraocular lens appropriately. Before I move to the formulas, a little bit about the lens shape factor. The refractive index of silicone oil is more than that of the vitreous. So if we are planning a long-term silicone oil retention in the posterior segment in a given patient, and the fact is also that silicone oil acts like a negative lens, inducing a hyperopic refractive error. So these patients will require to use glasses, very thick, high-power glasses, which I think is not desirable. So the quantum of this effect depends upon the posterior lens factor. The more curved the posterior lens surface is, the more biconvex it is, the error is more. If you're dealing with a meniscus lens, the postoperative error, the hyperopic refractive error can be minimized. And if you're doing it with a planar convex lens, you get something which is intermediate. So for patients where I'm performing a cataract surgery but want to retain the silicone oil in the posterior segment, and for a biconvex lens, I would add 6 diopter to the calculated intraocular lens power. And if I'm using a convex Pinot lens, and this is not available in the foldable platform, you have to go to the rigid lens for that. I'll be using adding 3 to 3.5 diopter to the calculated IOL. And we also tell the patient that once the silicone oil is removed, patient will have an induced myopia, 2 to 5 diopters, and that can be tackled by various means. That is also discussed with the patients. Now, moving to the last component of part of my discussion today about the IOL calculation formulas. We have already heard from the previous speakers that new generation formulas have come and they're doing extremely well for routine cataracts. We are getting astounding results with monofocal lenses or premium intraocular lenses. But how do they perform in the setting of vitrectomized eyes, where you have a cataract which has undergone an eye which has got a cataract after vitrectomy? So if you see most of the literature, they have been using on the SRKT or the older generation formulas. Ultrasound biometry has been performed, and literature till about maybe 5 or 6 years back was not very conducive to a proper search in this direction. But then we need to know how these new generation formulas do for the vitrectomized eyes. Then a subsection of these eyes where there is silicone oil and you have to do you have to do a phaco plus silicone oil removal, and then a category of patients where vitrectomy is performed because of macular edema due to associated with epiretinal membrane or macular holes. So let us see in the vitrectomized eyes. So this was actually a Chinese study published in the American Journal about 9 months back. 111 eyes, swept source OCT-based optical biometry was performed. So new generation formulas were compared with the traditional formulas. The new generation formula somehow did not include Hill, RBF, Olsen, and Holiday 2. And many of these eyes tend to be myopic. Almost many of the studies have shown 25 to 30% of these eyes are axial length more than 26 millimeters. So when such a situation was encountered, Hoffer Q, Holiday 1, and SRK T axial length underwent a Weinkoff adjustment, and then the IELTS calculation was performed. The results showed that the KN formula did the best in this category, and good performance was seen with the Badet Universal 2 and the EVO. And for eyes more than 26 millimeters, the new generation formulas and Bangkok axial length adjusted traditional formulas also did pretty well. Now, the subset of this vitrectomized group where there is silicone oil and phaco plus silicone oil removal has to be performed. Again, this study was just published this month in JCRS, again a Chinese study, 211 eyes, swept source OCT-based optical biometry is performed. And this shows that the newer formulas did better than the traditional formulas. So for silicone oil field, high myopia, axial more than 26 millimeter, again, the traditional formulas, the Bangkok adjustment needs to be done. And among the newer formulas, the EVA formula did well in all categories, including the eyes with axial length more than 26 millimeters. This was a Korean study published in JCRS about a year back. So this actually looked into the effects of the newer formulas on phacoemulsification in vitrectomized eyes, vitrectomy performed along with the ILM peeling for epiretinal membrane. So again, the newer generation formulas have done quite well here. In fact, the Kane formula had done extremely well, though the Badet Universal 2, Hill RBF, Holiday 2 had done extremely well. Now, before I conclude, I just would like to take you to a paper which was published 10 years back. Almost the same situation where phaco-vitrectomy is performed along with ILM peeling for epiretinal membrane. In this case, in this particular case, I mean, it was published 10 years back. The biometry was actually ultrasound, or the acoustic biometry is performed, not optical biometry. So there was a postoperative myopic shift, and most of the studies in this particular era, they show a myopic postoperative refraction in all the post-vitrectomized eyes. So it is perhaps because the A-scan biometry, it does not reveal the true axial length measurement. It sort of rather underestimates the axial length, resulting in this kind of post-operative myopic shift. So idea here is whenever you're having a patient with macular edema, it's better to find out the fellow eye's macular thickness and find out the macular thickness in the eye to be operated. And so the difference can be added to the axial length so that we now get the true axial length. And perhaps by using this adjustment, the postoperative myopic shift can be avoided. But in case you're not able to get the OCT of the fellow eye because it's a one-eyed patient or that eye also has got a macular edema, and you do not know what exactly is the baseline macular thickness. So you can use an intraocular lens which is half diopter less than the target for emmetropia. So that would definitely standardize, would give you better emmetropic results in the postoperative period, because these eyes which undergo ERM peeling or macular surgery, they have very good potential. So friends, in conclusion, despite the intrinsic challenges to full visual recovery in eyes with post-subsequent pathologies, an effort should still be made to optimize visual outcomes by resorting to latest technology and techniques, current concepts, and newer formulas. Thank you very much.
Thank you, Dr. Arup, for such a comprehensive talk. And since we are running short of time, we are sorry for the next session. We started a bit late, so we are winding it up. Thank you, Dr. Arup, Dr. Vavekar, Dr. Rajiv, Dr. Vardman, and Dr. Mehta. With this, we end our session. Thank you. Thank you very much.
Thank you, Vinod.
Okay.
Thank you, Himanshu.
Good morning, everyone. Nice to see the other session people also. We can only now see each other on Zoom. Nice to see you, sir. Dr. Rajiv Chaudhary, sir. Dr. Vinod.
Good morning, Namrata. How are you?
Good morning, sir. Good morning.
Good morning, ma'am.
Good morning, Anga.
You
How are
must be
you?
intimated to see so many women ophthalmologists because next is women's session.
Oh, that's great.
Good morning, ma'am.
Good morning. Good morning.
I think the panelists from the first session can leave now and give them to continue the
No, you're
proceedings.
most welcome to stay if you want to.
Hey, we are on the we are seeing already on from
Yeah.
the chat. Thank you.
Good morning, Rupal.
Hi, Rupal. Rupal is muted. Rupal, we can't hear you.
Hi.
Good morning.
Good
Good
to see
morning.
everyone. Good morning.
Hello, everybody. Good morning.
Good morning.
Good morning, everyone.
Morning. Good
Good morning,
morning.
everyone.
Good morning.
Dr. Suvira?
Yeah. This is session of women ophthalmology.
Yes.
Yes, sir.
Yes,
Yes.
you can make out.
So happy birthday,
And
Mohita.
power.
Where is Mohita gone? Disappeared again. It's her birthday today, so I was,
Oh, wow.
not wished her yet. So.
So let's sing together.
Yes.
Hi, Rupal.
Hi.
Hi, everybody. Hi.
How are you?
Good morning, ma'am. Hi.
Great. Hi.
Hello, everybody.
Hello.
Hi,
Hello.
Rita, happy birthday.
Happy
Happy
birthday.
birthday.
Thank you. What
Happy
could be
birthday, Mohita.
better than to be doing a WAS session on a birthday?
I know. What a way to celebrate.
And Namrata is one person whom I can meet only online. So that's what I said. We are meeting online. We've not met in person, I'm sure. We've not met in person for months now.
I think it would soon be open, don't you think?
Yeah, hopefully.
Are we starting?
Suvira, you are muted. Suvira, unmute yourself.
Start.
Suvira ma'am, you've turned off your video and you are muted both.
There I am.
Hey, Suvira.
Starting. Hi, good morning, everyone. Good morning.
Good morning.
Good morning, everyone.
Morning, everyone. Welcome to this session of Women in Ophthalmology for the BOA 2021. I extend a warm welcome to all of you, the chairperson, the conveners, the moderators, the speakers, everyone who's taken out 1.5 hours of their precious Sunday morning to join us, and hopefully, which would be a wonderful meeting. Welcome, Namrata. Welcome, Mohita. And I think since we're anyway running 11 minutes late as of now, let's start off the session with Dr. Mohita Sharma giving us her new topic. Yeah.
Yes. So, so let me introduce Dr. Mohita Sharma. Hello, everybody. Without much ado, I'd like to invite our first speaker, a very dear friend, a dynamic surgeon, and a leader who, with a sweet smile and extreme hard work, has got the WAS membership from 6 members to now more than 2,000 members. Dr. Mohita Sharma is going to enlighten us today on rare eye diseases. And let us all wish her a very, very happy birthday. Over to you, Dr. Mohita.
Thank you so much, Reshma. So first of all, I want to thank BOA for giving us this opportunity. Dr. Ragini and Dr. T.P. Lane have always been great supporters of WAS, and that has helped us grow and reach this stage where we are more than 2,000 members. And thank you, Suvira, Reshma, and Karishma for the amazing program that you designed. And whenever we compare Bombay and Delhi, it's always said Bombay is slower than Delhi, Bombay is faster than Delhi. And the way you all designed at an amazing speed, and that too such a good work, today I'm convinced about this fact, which I always oppose. So thank you for designing this program. And today I will like to introduce you to what WAS has been doing as a new program and differently. WAS is known as a society which does different kind of things. And today I'll introduce you to what we are doing this year as a different program. So this is a program which was initiated last year during COVID times, because we realized that we need to work on things which are not being worked on. And this red group was launched last year. And this year we plan to work on this on this program, which is a rare eye disease program. The red stands for rare eye diseases. So rare eye diseases is something which has been a neglected entity in our country totally. It is there, it is being worked upon in few countries, but again, all over the world, it is still something which needs to be worked upon. So by definition, rare eye diseases has got different multiple definitions. But WHO defines it as a disease which affects 6.5 to 10 people per 10,000 population. In different countries, there have been different definitions given to rare eye diseases. And still we are not very clear on what is very rare, what is rare, and what is common. But yet what we decided, we should work on diseases which are not so rare, but they need attention. So we found that across the world, there are some registries which are there related to rare eye diseases. And we thought that the first step that we need to do is create some registries as national registries, which WAS would initiate, but all ophthalmologists would be involved in it. And these registries would be, as a pilot, we would do it on 5 diseases in this year, and then we would take it forwards to more diseases. So we found that there were isolated few registries which were there all over the world. And then we also looked into this article by in ophthalmology, where we found that registries is something, because we are all digitalized now, it is easy to make registries. This is something which is where the numbers are continuously increasing. And this is something which we can work on in this digital era. So the plan is that as we pick up 5 diseases as a pilot, we would have 5 PIs, and along with that, we would have co-PIs, which would be several ophthalmologists, which can be WAS members, and if they are not members, they can become members and be a part of this program. And there will be on a cloud-based server, we would have the templates, and these templates can be filled up by everybody who's a co-PI. So finally, the plan is that once we create the national registries, after that, we can do their genetic testing and therapy, we can do counseling, we can do rehabilitation, we can have support groups, and we can work on low vision aids. So the idea is to have some means of treating as well as rehabilitating patients who have rare eye diseases and who are otherwise neglected. So for this, we are already collaborating. We are collaborating with various places. Our first collaboration is with CIPLA. We are happy to announce the CIPLA collaborated program would be started next month, and it will continue as a pilot for 6 months. We are also doing collaborative grant applications, as well as we are looking for collaborative PhD programs. So finally, I end by saying that rare eye diseases is a group which plans to do things differently, and we want everybody to get involved in this. And for this, we are also coming out with a special issue in IGO, which is related to rare eye diseases. We have already announced this issue, and this issue will come out in the first quarter of next year. Deadline for submission is 30th June, and the details are all given here. We've also sent mails and circulated on the WhatsApp also. if you have any query, you can ask. And I know that there are so many accomplished women ophthalmologists sitting here. I'm sure we'll be very happy if you participate in the RED program as well as contribute for this issue. So thank you so much, everybody, and all the best.
Thank you so much, Dr. Mohita. A very, very, very happy birthday to you.
Thank you.
And it is so good for us to celebrate on this platform.
Yeah.
Thank you so much for this Women in Ophthalmology session. And I would like to say 2 words about you. A few years back, a friend of mine called Mohita comes up to me and says, Ragini, I have this dream and I think that we should go ahead with this. And should we have a Women in Ophthalmology wing? Because, women are not given as much a chance as they deserve in the ophthalmology sessions. And I plead guilty that it is true even today. And even with me, it does happen that way. And she started with a dream. And, the first meeting was in Delhi, in Ashok, in that lunch room called Sagar Ratna. And from there, she took off and see where she reached today. She couldn't have done without all the dynamic women ophthalmologists present here today. But it is one person's dream to make this a reality, to give the women in India a platform, not only on a national level, but on an international level, Dr. Mohita. And you have achieved it. I think all the women here will not mind it if I say single-handedly, because I'm not putting them down, but it was your dream and your hard work which takes us all along, which pushes us, which drives us with your drive. And very, very happy birthday to you. And God bless you for giving you to Indian ophthalmology, for the women in ophthalmology. Thank you so much. Dr. Lahani, sir, you are there. Would you like to wish her and say something? Sir is having some problems with his connectivity. Mohita, I'm sorry to interrupt.
No. I have connected. Mohita.
Good morning, sir. Thank you, sir.
Good morning,
Mohita, Anaga, Nidhi, Karishma,
sir, Mohita's birthday today.
welcome. Parul,
Good morning, sir.
Suvita,
Good morning, sir. Good morning, sir.
Sujata, Reshma, Hijab.
Good morning, sir.
Good morning.
Sharon,
Morning, sir.
Ragini, Rupal, welcome everybody.
Sir, Mohita's birthday today.
Mohita, many happy returns of the day.
Thank you so much, sir. That's why as soon as Ragini said, I thought I should choose this day for our host session, because that's the best thing that I could have done on my birthday morning. Thank you, everybody.
Thank you so much, Mohita. Thank you and welcome everybody. Thank you. Hi, Suvi. Bless you. Ma'am, everybody. Thank you so much.
Thank you, ma'am.
Thank you, Ragini. Thank you.
So I think we can now begin with our debate session. And for the first debate,
so sorry that I went on rambling, but that needed to
not at all. That's the advantage of having a Women of Ophthalmology Society ka meeting. Na? We can do whatever we want. So we'll start with our first debate, which is on the cornea discussion, DSEC versus DMEC. And first of all, I would like to thank all of you all who have agreed to speak on such short notice. I'd like to welcome Dr. Namrata Sharma ma'am, who actually needs no introduction, and she's talking on a topic which I currently am still doing, which is DSEC. And I would also like to invite Dr. Nidhi Gupta ma'am. I would like to thank you, ma'am, for the amazing DMEC sessions that she has been conducting online, which is motivating people like me who are strongly doing DSEC and kind of motivating us to switch over to DMEC. So I thought it would be appropriate to have this debate, DSEC versus DMEC. Without wasting any more time, let's begin with Dr. Namrata Sharma, ma'am. She's going to be speaking to us about DSEC.
So thank you, Karishma, for organizing this. Thank you, Women of Ophthalmic Society. And I have a disclaimer right in the beginning, which I want to make. And that is that Nidhi is a very dear student of mine. And I'm extremely proud of her. And just like, you have your own children and you want them to do better than you, likewise, I want Nidhi to win this debate hands down. So I am not going to contest with her. I mean, it's a pleasure and it's a proud moment for me, the way she's been doing the EKLG courses. and the way she's really come up. I still remember her as a very young girl. She's young now also, but when she came to RP Center. So I am going to be talking about DSEC, and Nidhi is going to be talking about DMEC. And I think each set of indications, each set of surgery has a different indication. So I think it is more about disseminating that. DSEC and DMEC, probably if you say in broad terms, will have the same indications, that is whenever the endothelium is not functioning. But there are cases or difficult scenarios in which DMEC will become difficult, like aphakia, glaucoma shunt, presence of peripheral anterior synechia, iris abnormalities, large iris colobomas, large PI, aniridia. So possibly DSEC you can do in almost every case except when the AC is extremely shallow. But DMEC, I'm not saying has limited indications, but you have to be a little more selective, especially when you are beginning to do surgery. So a DSEC graft, like I say, is as easy as learning phacoemulsification. So almost if you're 10, 15 cases you've done, you're almost there. So the graft is loaded on the Lucent glide and it is pulled intracamerally. And because the graft is thicker, it has stroma as well as the Descemet's membrane. It is easy to manipulate the graft. The graft behaves very, very predictably as you want it and almost conforms to the curvature of the cornea. And it is an easy surgery done. I think anybody who can do a phaco needs to do a little bit of mastering and is already there. It can be done for very difficult scenarios such as like this, when you have ophthalmos, the deep anterior chamber, where you probably wouldn't want to do a DMEC because the DMEC graft actually requires will misbehave slightly if it is a deep anterior chamber, especially the DMEC roll. Then again, in cases like CHED, although there is published literature now even on this, but again, if you're a learning surgeon or if you are in the middle of your career where you're doing endothelial keratoplasty, in in CHED also it's so hazy and it's so thick that at times it becomes very difficult to see the graft intracamerally. And then it is only the DSEC which comes to your rescue. And here, if you have a DMEC graft, then it is very difficult unless, of course, you have a IOCT and you are able to see. Then ultra thin DSEC is another frontier, I think, which is close to DMEC, and the graft here is almost 75 microns, and you cannot make out that there is a graft which is ever done. Of course, the thinner is better, and that is why the advantages of DSEC. But in cases of ACIOLs or in cases of iris claw lenses, DSEC is a predictable and is a forgiving surgery. In cases of glued IOLs with malpositioned lenses, especially when you're doing glued IOLs, or in cases of aphakia or in cases of vitrectomized eyes, again, possibly DSEC is simpler to do as compared to DMEC. And even for these cases where you have totally anterior segment which is totally distorted, and then if you do a DSEC graft there, it becomes a lot easier, especially if the patient is also aphakic and the pupil is dilated and is not coming down. Then again, in cases of keratoglobus, for the same reason that these are large anterior chambers. And this is just to show that when DMEC was done in difficult scenarios like vitrectomized eyes, there were problems of total graft detachment, partial graft detachment, which needed rebubbling. And the authors in this study did recommend that DMEC may not be feasible option in eyes that are prone to collapse, particularly aphakic and vitrectomized eyes, as opposed to DSEC or PKP. And in cases of distorted anterior segment anatomy or posterior segment complications like incomplete iris diaphragm, abnormal iris, or simultaneous pars plana vitrectomy or glued IOL, as has been discussed earlier. Now, if you look at the preparation of the DSEC graft, it is pretty simple. You can do it manually or you can do it with the microkeratome. Of course, the microkeratome requires an expense, and the graft preparation is not that difficult at all. All you have to do is cut the graft 400 microns, and then you have about 100 microns left, which can be punched from endothelial side down. Whereas in a DMEC graft, you would still have to, may have tears while doing it, and it does have a learning curve. And as of now,
even now the eye banks are not preparing it. The surgeons only have to prepare it. Then, like I said, the learning curve is there, and this study again looked at the learning curve of group 1 first initial cases and the middle cases and the last few cases of a single surgeon at a tertiary eye care center, and did find that the detachment rates, although with learning, would decrease, but the detachments are there, especially in the initial cases, and it behaves differently. So you have to relearn your endothelial keratoplasty when you're actually doing DMEC. Again, primary graft failure is a lot more with DMEC as opposed to DSEC in this study, and also is our general impression. Then, of course, DMEC graft can misbehave, whether you are trying to chase it or whether you are trying to put it inside. So when you're trying to chase it, it keeps moving here and there because of the fact that it is so fragile. And when you're trying to put it, then, you know, it may just come out because of the fact that you've not injected it properly, and the wound injection has not been done correctly. So we may need to convert to DSEC, as was shown in this study, almost 4 to 8%, and the graft failure rate is there to the tune of 3 to almost 4 to 7%. Visual outcomes, of course, in various studies have shown that DMEC visual outcomes are better, but ultra-thin DMEC or ultra-thin DSEC also does well. Now, there can be both points to it. I'm sure Nidhi is going to show a lot more studies to say that DMEC contrast sensitivity is better and best corrected visual acuity is better, but the problems or learning of DMEC is a challenging situation. And I think if you've mastered that, then that you are there, but till you have not mastered that, DSEC is a good way to go. These are just 2 studies which showed that the best corrected visual acuity was better or was comparable to DMEC. Then graft detachment is significantly more with DMEC, as was also shown in this meta-analysis of 19 studies comparing DSEC and DMEC. And again, clinical outcome of first 450 studies after DMEC showed that the intervention was required in almost 17% of the cases, again from Dr. Mellis' group. Now, I think outcome of a single surgeon of the initial cases as well as DSEC versus DMEC again showed that the graft detachment requiring rebubbling was more with DMEC as compared to those cases with DSEC. Endothelial cell loss, as far as this is concerned, in the initial studies, it was shown, you know, that DMEC is more than DSEC, but I think as you learn it, you get better, but these are the studies to show that endothelial cell loss, in fact, one study showed was higher in ultra-thin DSEC, and the other study with a fellow eye comparison showed that it was more with the DMEC. Even in cases of failed DMECs, people have done ultra-thin DSEC, especially if you don't do it immediately, because there might be some amount of haze which may be there, which may develop, which may preclude another DMEC after a failed DMEC. And it's an easier surgery with less intra-op complications and less explaining to the patient that, you know, you might still have to rebubble the second graft if it is required. This is just to show a case where DMEC failed and ultra-thin DSEC was done, and the graft is only 77 microns in thickness. So to conclude, why not DMEC in every case? Because there's a restricted donor pool, because you do need counts which are higher. You do need age, which is also more, because otherwise the DMEC roll is difficult to unroll and to, especially in the anterior chamber, and to flip it open, because sometimes you can have really tight screws. Then it is difficult to successfully manipulate and attach grafts in single compartment eyes. And so DSEC may be a better choice in that. And of course, long-standing decompensation makes visualization and manipulation difficult in DMEC. There's a longer learning curve as compared to DMEC, as compared to DSEC for DMEC. And rejection rate, you can say, is almost comparable when you say with ultra-thin DSEC, but of course, when you compare it with DSEC, the rejection rate is going to be much less for DMEC, but this is coupled with the fact that the primary graft failures are more with the DMEC, and so are the iatrogenic graft failures as well. So thank you very much for your kind attention, and thank you for making me a part of this program today.
Thank you so much, ma'am. I'm still doing DSEC and I've still not switched to DMEC, so I'm in support of you. But Nidhi Gupta ma'am is really doing a good job at convincing me otherwise. So ma'am, let's begin with your talk.
Thank you, Boss, for inviting me for this session. Very good work done by Voss over so much of time, and thank you for having this group. I hope you're seeing my screen now.
Yes.
As always, teachers like Dr. Namrata herself has set the tone right. She wants science above this debate, and she has made my job easier by putting the right indications for where DSEC works and where DMEC works. It is completely my honor and privilege to be here and sharing the stage on this debate with someone who is a stalwart, not in just ophthalmology, but I would call her an iron lady in ophthalmology. I think in formative years, if I was introduced to cornea, it was because of Madam. That was my first cornea exposure in true sense, and correctly so. From there, I think I picked up some true colors of being so hardworking and never to say no and always excelling is what I think is what Namrata ma'am has held that stage so high for all of us to be encouraged. Thank you, Madam. With which I would begin by just saying that it is very important to have a true perception before you have decide on any surgical procedure in science to decide what would be the right procedure in which situation, and let us set some yardsticks to begin even the debate. For this debate, I think it is important to understand what is the disease burden and why we are even having this whole discussion on endothelial keratoplasty worldwide and DSEC versus DMEC. What are the anatomical and the functional outcomes? What are the complications of each? And when it fails, why it fails, and whether we are able to revert it back. Doing these procedures, either DSEC or DMEC, what are the resources which are involved, the learning curve, as Madam has truly shown, the instrumentation which is involved, the tissue limitations, and finally, for especially in perspective, Indian perspective, what is the cost effectiveness and why we should be moving ahead. If you would look at these statistics which have been picked up from the Indian study, that what has been the ratio of patients which today require endothelial keratoplasty like PBK, the pseudophakic bullous keratopathy, and ABK, Fuchs dystrophy, and failed grafts. What are the ratio is about 40 to 50% of the transplant which was done in a decade back. The number seems to be reduced now for a PK because they're shifting to more of endothelial keratoplasty, but that's the true disease burden. So if you have 50% of your corneal diseases, then we might as well have this discussion very carefully. So if you look at the evolution of the corneal transplant over years, the surgeons have been pursuing for a better vision, a lesser rejection, and a better long-term outcome, and that probably is being achieved with lesser amount of stroma, which scientifically would cause lesser antigenic load onto the cornea, transplanted cornea. And that's why there is a shift from PK to DSEC and now to DMEC, where in DSEC you would still have some microns of stroma left, even though it's ultra thin stroma which is left in ultra thin DSEC. And with DMEC, you're only transplanting the endothelium and the Descemet's membrane. So let us discuss what's the anatomical outcome, and let's compare DSEC versus DMEC. If you look at, as I already said, if you look at the ASOST studies and now the electronic microscopic studies, which are able to give you in microns what you're transplanting, then DSEC versus DMEC, if you look at it, you have completely a smooth surface between the Descemet's membrane and the stroma. There is hardly any fibers also seen at the central visual axis. That's what is the beauty of the DMEC. And that causes a lesser intrastromal haze and lesser irregularities between the two grafts. What this anatomical outcome results is what the patient's quality of vision is transplanted at DMEC. In DMEC, you have an early visual gain of the patient. You have an early rapid rise, plus subsequently also the vision of the patient keeps gaining over time, which is unlike in DSEC. And definitely there are lesser abrasions because there is less of stroma which is involved, or hardly any stroma which is involved in the DMEC. Yes, in graft, you could say that you're starting with a little higher visual equity in these patients than in patients of DSEC. But I believe that is also, that's where the criteria where you want to do DMEC is important, which is very beautifully highlighted by Madam. To compare even the best of the DSECs, which is the ultra thin DSEC, it is the DMEC which has a better visual gain, almost a difference of 1.5 lines to our patient, a better quality of vision as well. So seeing the functional outcome in terms of the vision, let's go on to the usual thought. The usual, the norm in our minds is that we have a mind block saying that probably the endothelial cell loss would be more because you're manipulating so much. The surgeon is preparing a DMEC tissue, as well as in the anterior chamber, you're manipulating so much. But if you look at the long-term outcomes in terms of 5 years of a single center, single surgeon, shifting from DSEC to DMEC, they found that the DMEC versus DSEC over the time has the similar curve for endothelial cell count. So probably it's not related to the DSEC versus DMEC. It is much to do with the surgeon doing the technique in the right patient. So that's the perspective which has to be clear. It is not related to your technique in both of these here. If you look at the long-term outcomes in both of these, the rejection is far, far less. Over 2 years of period, you're giving almost a 12 times lesser rejection rate in terms of the DMEC versus in DSEC. You have only 1% rejection, and you may not even pick up because the rejection is so minor. With already going on steroids of the patient, he may survive it. So that's very important. The amount of steroids and the duration of the steroids, the need for a long-term steroids is far less in DMEC as compared to DSEC. And we all know from our knowledge of PK and DSEC that the steroid-induced glaucoma is one major problem in patients of transplant. We have been still trying to sort the issue of glaucoma, and you have a transplant wherein steroids are required or less. So I think you're going on to a surgery wherein the secondary complications because of glaucoma is far less with DMEC. Going on from those outcomes of having a better anatomical, functional, lesser complications and failure rates, long-term better outcomes with DMEC. Let us see, as we have a thought that maybe the learning curve is difficult. Completely agree. I think there are 3 major challenges which the learning curve in DMEC has. It's a graft preparation at which it becomes difficult. That's a mind block. People have that maybe graft preparation in DMEC is very difficult. The graft orientation inside the eye seems to be a very, very tough time for surgeons to learn, to understand. And also, definitely, it is documented that the detachment rate is about 8% to 12% with DMEC versus the DSEC and needs a rebubble. We're going to address all 3 of these. So going on to the learning curve, let's first see what is the instrument which is required. And that's where is the first step of learning begins. So in terms of doing a DSEC, either ultra thin or a normal DSEC with a normal thickness, you would require a microkeratome. And this is much required because you do not want the irregularities in the graft with your manual dissection, or you do not want a interface haze to come in, the patient having a vision, but not having a clarity of vision because of the abrasions that come in with the irregular graft. So you would definitely require an eye bank support, which does a microkeratome dissection for you. Not available for many centers, and it does require a technical support and time to have that tissue in your hand for the technician to produce. However, in terms of the DMEC, if you see, the very simple instruments which are required, only an addition of 1 or 2 in your OR with your PK instruments, and it is the technique, it is the mastering of the technique which you require more than any other instrumentation which is required. It's a very, very less expensive technique. If let's go on to from that instrumentation to let's go on to what is the comparison of the time which is required for graft preparation. So this is a study which is compared very neutrally that what is the time required by a surgeon versus fellow. And if you see, there are about 200 seconds of a difference which is there, which hardly would mean less than 5 to 10 minutes as you move ahead in your graft preparation with time. If you would ask my own experience, I think by the 10th graft preparation, I was fine to go. The mind block had gone with about the 10th graft that I was preparing for DMEC. And that was from shifting from PK to shift to DSEC and DMEC was far faster for me than for the usual surgeon. So the graph for me went up very fast, and that has been common for other surgeons as well. I think it's that mind block has to go. It is by the 8th to 10th graft preparation. with the improvement in standardization of the technique, I think you have enough mentors in India now to give you a good technique to shift from making your own grafts. Also, behind the curtains now, what is coming up in iBanking is the preloaded, pre-stripped DMEC, with which it is going to become even much easier for you to have a DMEC graft in your hand to directly transplant like an IOL inside the eye. So the rest of the steps are very common with DSEC. It is this very step which has a learning curve. Going on to unfolding with, I think with EKLG as well, and also otherwise, if you would look onto it, these surgeons have started understanding the physics behind the unfolding. The greater you understand the physics, it isn't difficult. I think from over time of 30-40 minutes in unfolding to about 10 to 15 minutes at max, or maybe 5 minutes later, you would be able to actually unfold your graft much easily. And that's how the learning curve, the surgeon's experience keeps improving with time with DMEC. Marking the tissue and having some illumination system, for example, the light pipe from the retina helps you see and visualize the graft. Very few centers would have an ASOCT mounted, but yes, the light pipe helps really, goes a long hand for an early DMEC surgeon. So agree that there is a learning curve, but there is light at the end of the tunnel, and it is quite a good one for all of us to shift from DSEC to DMEC. So this study was very beautifully said that these surgical outcomes were quite similar if you will put one fellow for learning DSEC versus DMEC. That's not different if the learning curve is actually compared. Since DSEC was done long back, the learning curve, we've already crossed it. So it is much easier for a DSEC surgeon to cross and become a DMEC surgeon. A lot of manipulation and the similar steps are there. It is only the graft preparation and the unfolding which has to be learned. A lot of wet lab courses which are organized.
Ma'am, I'm sorry to interrupt. We're running a little late. Can we just
I'm coming to the end of my thing. Mentorship and digital platforms are available for you to learn. And I think the globe is moving towards DMEC. If you look at it, most of the countries are shifting to DMEC. With which I think I would just come on to end by saying that it is definitely wise to choose your cases as a surgeon from DSEC versus DMEC. Dr. Namrata has already crossed this part, has covered this part of where DSEC and where DMEC should be done. And I would end by saying that DMEC has a better visual and functional outcome. Lesser rejection, lesser steroids are required. It is a greater science which is understood, the technique which is becoming standard. And I think increasing platforms and mentorship, which is now helping you to shift to DMEC. With which I would thank, and I'm sorry if I've crossed my time.
Thank you very much, Dr. Namrata and Dr. Nidhi. That was a fantastic debate. We all as cornea surgeons need to move, at least getting started with DSEC and taking all the training required, getting to get good at DMEC. And if one can do it, everyone can. With that, we move to the second debate.
I'd like to welcome for the next debate, Dr. Hijab Mehta and Dr. Sujata Mohan. Now, moving on from endothelial keratoplasty, which is a complex procedure, needs a lot of surgical training, to something which we encounter every day. The debate between a monofocal and a multifocal. What would you do if you had to put one in the eye? So we have Dr. Hijab Mehta, who is an experienced cornea cataract refractive surgeon from Infinity Eye Hospital, Mumbai, who will be speaking in favor of monofocal IOLs. And we are also privileged to have Dr. Sujata Mohan, again, a very senior cornea refractive and cataract surgeon from Rajan Eye Care, Chennai. And ma'am will be talking on the merits of multifocals. So over to, I think we'll start with Dr. Hijab. Dr. Hijab.
Yeah, thank you. Thank you, BOA, MOS. Thank you, Karishma, Dr. Ragini, Dr. Lahane. Can you see my screen?
Not yet, Hijab.
Not yet?
No.
We can still see your pretty face.
Yes.
Oh, thank you. Can you see now? Thank you.
Yeah, Hijab.
Actually, mine is a simple, fun kind of a presentation. It's just a perspective. So Not every currently available intraocular lens is suitable for every eye. There is no one size fits all. It depends on the lifestyle choices of the patient, the personality dynamics, the inherent anatomy and physiology of that eye. Patient selection for the IOL is an art actually, which we learn over time. If the patient is type A, perfectionist, wants perfect vision, sharp vision for all distances, and doesn't mind wearing glasses, is a surgeon, finicky one like me, then these are patients who are good candidates for monofocals. Pre-existing irregular corneal astigmatism, central corneal scars, dry eyes, corneal dystrophies, these are again better suited for monofocals. The diffractive multifocal trifocal technology is such that there is a visual compromise with a reduction in the image contrast. It is traded for 2 or more simultaneous focal points. So if there is pre-existing higher order aberration like coma or spherical aberrations, there will be an additional loss of contrast, reduction in vision and disabling dysphotopsia. Patients who've had a previous laser refractive surgery, LASIK, PRK, RK, they have pre-existing higher order aberrations, and also there may be errors in the IL power calculation in these patients despite using the most modern formulae. So these again are not ideal candidates for multifocals. Patients who have got large pupils, atrophic iris, they'll have an increased incidence of glare and photosensitivity post-op. Very small myotic pupils will compromise the near vision post-op with multifocals. Eccentric pupils, colobomas are contraindications for multifocals. Patients who have got zonular weakness, such as progressive zonulopathies as seen in advanced pseudoexfoliation, subluxated lenses, will not be good candidates for multifocals because the success of the multifocal depends upon the centration. Any decentration or tilt will give a compromised visual outcome post-op. Diabetic retinopathy, epiretinal membrane, age-related macular degeneration, macular holes, any progressive retinal pathology will compromise the visual outcome post or multifocal. The problems here are twofold. One is impaired vision for the patient and second is impaired fundus visualization for the treating surgeon. Patients who are potentially one-eyed may not achieve the level of uncorrected visual acuity that results from a bilateral multifocality. And sometimes in some patients, the photic phenomena that you see are really disabling. The perception of halos and glare at night, which is seen following multifocal IOL surgery, occurs due to the superimposition of multiple images simultaneously on the retina. So you have certain patients who are dissatisfied despite them being 6/6 and N6 on the Snellen's acuity chart. These photic phenomena do improve over months due to neuroadaptation, but sometimes they may be permanent, and it's better not to oversell the technology. The loss of contrast is basically inherent in the design of these multifocal IOLs. It occurs due to the reduced light energy reaching the different focal points. For example, if you look at the different diffractive multifocal platforms, the light energy distribution in, for example, panoptics, which is a trifocal, 50% light goes for distance, 25% for intermediate, 25% for near. If you look at a bifocal lens like Restore, it is 70% for distance, 30% for near. And also these diffractive IOLs, there is loss of energy, light energy. Only 88% of it is utilized in the trifocal panoptics and say 84% in the bifocal. So because of this, there is a reduction in the contrast vision post-op. There are studies which are looking at the modulation transfer function, that is a measure of the contrast sensitivity, and these have shown that the MTF values are much higher, that is the contrast is much better post a monofocal compared to a bifocal, trifocal, and also the EDOF. Then these multifocals are highly sensitive to posterior capsular opacity and you may need to do a YAG earlier. Something as simple as a fold in the posterior capsule also degrades the visual quality and calls for an early YAG. The surgery needs to be spot on each time. God forbid if there is a posterior capsule rupture, we may be in a sticky situation, especially if this is the second eye and the patient already has a multifocal in the other eye. You may need to do a reverse optic capture and that will result in a post-op spherical error or convert it to a PCC, or you need to have a 3-piece multifocal standby to be placed in the sulcus. A post-op refractive surprise can occur in the best of hands using the most modern biometry and the IL power calculation formulae, and these may require enhancement in the form of laser vision correction, IOL exchange, piggybacking, which may not go down well with the patient. Patient is paying a premium price, so the expectations reach the moon. We have to be prepared for that. And many insurance companies don't reimburse the full amount for the premium IOLs, especially in these difficult times. If we target minus 1.25 in one eye and emetropia in the other eye, pseudophakic monovision provides the advantage of good distance, decent intermediate, and reduces the dependence on the glasses without having the problems of a multifocal. So to conclude, present day multifocal technology is very good, I agree, but it's not perfect. It's still not God's answer to aphakia. The goal is not to maximize the use of multifocals, but to match the IOL according to the patient's personality requirement. And at the end of the day, have a satisfied patient. Thank you.
Can I go ahead?
Yes, over to you, Dr. Sujata ma'am.
Yeah. Thank you, BOA and Women Ophthalmology for giving me this opportunity. Are you able to see my screen?
Not yet.
Not yet. Okay. Why is it not yet? 1 minute. Just 1 minute. Yeah. Yes. Are you able to see it now?
Yes.
Okay, right.
Yes, ma'am.
So I'd like to thank BOA, WOS, and also Hijab for making my job very easy, because she has already pointed out what are the pros and cons of a multifocal IOL, and also given me the indications for which are the choice of patients that you have. So the patient profile 2 decades ago was an 8-year-old male or a female with 6/36 vision, was very happy to regain vision for distance, was very much ready to wear glasses, was swearing by their surgeon, and was a happy customer. But look at today's young couple that you see about in their 50s. They come with 6/12, 6/9 vision, and they want the best in the market. They want the best intraocular lens in the market. They want the best procedure to be done. They don't mind the cost. They don't want to wear glasses. So they want to have good near, intermediate, as well as distant vision. So there's a changing profile of a cataract patient. We no longer get customers like we saw in the first slide. They are now much younger and active in life, economically independent, ready to spend on themselves, educated, hugely aware of options and new possibilities, and highly demanding and demand a lifestyle change. I've had patients coming back who had monofocal, and then the neighbor comes with a multifocal. They've come back and asked me, why have you not put a multifocal? You didn't give me the choice. So the choice has to be definitely given to the patient and discussed. So how to be a successful multifocal surgeon? Accurate biometry, keratometry, accurate IOL power calculation, topography, and consistent surgery. So what are the keys? Increase your refractive accuracy. The most important thing is look at the ocular surface, correct the ocular surface, particularly in patients with dry eye. Accurate IOL calculation. There are a lot of newer calculations available, so hone your IOL calculating skills. Use IOL Master, Lens Star, Callisto, Varion. So many equipments are available to make sure that you hit the emetropia target every time that you put a multifocal IOL. The newer IOL formulas, which are commonly used, are Holiday, Hoffer Q, Barrett's formula, and Hill RBF formula, and they all give very good results. Decrease your complications. So it's very important that you be a very good surgeon before you shift to premium IOLs and offer multifocal IOLs to your patient. So that is one of the most important things. And if you see something like a decentered IOL, or you have a capsular rhexis, a tear, or an irregular capsular rhexis, it's better to avoid putting a multifocal IOL. So it's important to decrease your complications on the table. Minimize your phaco energy, use phaco chop, use phaco power modulations, use adequate viscoelastic to protect the endothelium, and deliver clear corneas every time. So this is one of our patients on the first day post-op. And avoid post-op problems. Patients who have a high risk of developing cystoid macular edema like diabetics, use NSAIDs in the high-risk patients. Choose the IOL that gives the best quality of vision. So there are different types of multifocals. The older generation multifocals like refractive and gave excellent distant vision, but they were pupil dependent. The refractive is a combination of both. But now we have EDOFs and trifocal lenses, which have a good contrast sensitivity and good light. See, Hijab showed a slide when she said about 88% of the light goes in, which is good enough. There is a little compromise, yes, but in spite of that, the patient is glass free. That is the most important thing that the patient is looking for. So that has to be explained to the patient. So how to choose the right IOL for the right patient? This is a 55-year-old radiologist, wants intermediate vision. He has no ocular pathology, does not want to wear glasses. And this patient will do very well with an extended depth of focus IOL. There's again a female, a 70-year-old female who's a voracious reader, plays the keyboard in the church choir. She has been reading without glasses for the past 4 years, does not want to wear glasses after surgery. So this patient would do with a very well with a multifocal IOL with higher ad, because that's what she wants to do. She's not going to drive. She's not going to worry about halos and glare. So this is a 75-year-old myope, an active male golfer, drives occasionally in the night. This patient will do well with an extended depth of focus IOL or a trifocal IOL. So it's important to choose a patient, discuss the options with them. Now the newer multifocal IOLs have good far vision, intermediate vision, good contrast sensitivity, and are pupil independent. And the older generation lenses, which Hijab was talking about, yes, there were more halos and glare, which are very much reduced. Are very negligible in the newer multifocals and trifocals, and they disappear with retinal adaptation. The range of vision is excellent. The quality of vision almost matches a monofocal for distance. And depending upon what type of lenses that they want, whether they want for intermediate vision or for near vision, you can choose the different types of IOL which are available. So how to get the best out of the various options? Choose the right type of patients, choose the IOL, optimize the ocular surface, look for macular pathology, higher order aberrations, angle kappa, topography, and choosing the appropriate formula for IOL power calculation. 6/6 and 6 is not the goal. That's what you have to understand. The goal is happy patients. So the patient has a multifocal IOL and complains of ghosting and glare, look for uncorrected astigmatism. And you have to explain to the patient it's okay to wear glasses, particularly when they're sometimes occasionally they may need to do it when they are in scotopic conditions. So exceed patient expectations. So what is important is have a questionnaire. Be aware of the unrealistic expectations the patient might have. Spend more child time with the patient. So a patient from 20 who has a 20 size cannot expect to go to a 0 size. So have that realistic expectation. Explain to the patient it's not possible. Under promise and over deliver. Have a reasonable idea about how you have to tell them you will be 95% near perfection. You might need to wear glasses for reading when you're in dim light. So those are things that the patient has to be taught before taking up the patient. So increase refractive accuracy, decrease complication, choose the best IOL quality, and exceed patient expectations by spending more time with the patient and under promise and over deliver. Lastly, I want to answer the final question. Will I get a multifocal IOL for my eye? Dr. Bobby Osher is one of the greatest ophthalmologists of our time, and he underwent bilateral cataract surgery with a multifocal IOL. If Bobby Osher can, then so can I. Thank you.
Thank you. Thank you, Dr. Sujata and Dr. Hijab. That was a fantastic discussion. And I think I love the first point that Dr. Hijab said, that no size fits all, no one size fits all. And Dr. Sujata, who said that, at the end of the day, you want a happy patient. And I just feel that all of us need to know we need to not limit ourselves by our beliefs. We need to know what the options are and experience it for ourselves and then decide what is it that we want. Thank you.
Thank you.
So over to our next debate. We are going to have two very good speakers coming in. Dr. Rupal Shah, she needs no introduction, a stalwart in her field, who has performed more than 25,000 laser procedures and has many published in the peer reviews, publications. She is a gorgeous woman. She's my guru, with whom I have done my first LASIK procedure with. She will be talking on smile, with the sweetest smile that she always carries with her. And with her is Dr. Kavita Rao, who's also a brilliant surgeon, a trained cornea cataract refractive surgeon who's published various papers in peer-reviewed journals. And she will be debating and talking on LASIK. So here we have Dr. Rupal Shah talking first on smile.
Thanks, Reshma. Is my screen visible? Is my screen visible?
Yes, ma'am.
Okay. So first of all, I would like to thank the BMW, the boss, the boss, for giving me this opportunity to be here. And my dear friend Ragini, of course, Professor Lane, and the great team which is putting all this together. So thank you very much. I would like to begin by saying that smile and the world smiles with you. And so I would really want to throw some light on this revolutionary new technique. And I agree with Dr. Namrata and Dr. Suvida that it is not one which is the best cure for anything. And we should look at every possibility as one of the opportunities to add on to whatever you know and to use it to the best of your patient's interest. I have to acknowledge that I was a person who was instrumental in studying smile in the very infancy. So it's almost like my baby. So I would be a little biased to it, but at the same time, I also know inside out of this particular procedure because I've seen it grow. So please believe when I say certain things, and I would like to just throw some lights on the salient features about this great new procedure. For people who are uninitiated in it, it uses only the femtosecond laser to carve out a lenticule within the cornea. The lenticule is separated and removed through a very small incision as low as 2 millimeters. The lenticule dimensions correspond to the refractive error being treated, so no excimer laser is used. So no photoablation is carried out, and the lenticule is physically removed from the cornea. What are the advantages? The most, the clearest advantage that comes to my mind first is the accuracy of treatment and the stability of treatment. These two are really the advantages of smile procedure, which is unparalleled. Then there are also big additional advantages of having a less dry eye and better safety profile, less inductions of aberrations, better workflow, better economics, which all translate into a more smiling patient and a more smiling doctor as well. Why does it happen so? We all know that LASIK is a great procedure. It has really come a long way. Most of our patients are really happy. But an excimer laser performs photoablation, and the photoablation rate increases linearly with fluence beyond a certain threshold. So you would have different photoablative rates depending upon what your environment is, both the corneal as well as the surrounding. And therefore, there would be a scatter in the results, especially for treatment of high myopia. SMILE uses cutting instead of ablation, which is a binary process instead of a linear one. So you would always have a perfect cutting. And there are much less influence on any external factors like fumes in the environment or corneal hydration or your AC blast coming onto the eye or anything of that sort. You wearing perfume, the patient wearing perfume, nothing matters. It is reflected in the tremendous accuracy achieved even in the first eyes treated worldwide. And the results are interesting, especially for high myopia, a group in which the excimer laser doesn't do as well. And I don't want to really cite too many studies. This one study says it all. It's a numerous, it's a meta-analytic study of 11 studies which compared SMILE with LASIK and found no significant difference between the two procedures in terms of final refractive spherical equivalent, the proportion of eyes losing one or more lines of corrected vision, or the proportion of eyes achieving an uncorrected vision of 20/20 or better, and the percentage of eyes within plus or minus 1 diopter of the target value. A recent study compared the 2-year visual results of outcome with SMILE and wavefront guided LASIK. The accuracy was significantly better in SMILE group with 100% of the eyes achieving post-op spherical equivalent of plus or minus 0.5 diopters versus 73% of eyes in the LASIK group. Now, this is a significant difference. Moreover, there was a significant correlation seen between myopic regression and the changes in the keratometric reading from 3 months to 2 years after LASIK, but not after SMILE. And this one slide says it all. Why is it so? Because there is very little energy input into the cornea, and therefore there is a higher stability of the treatment, as seen by this elegant study which was run in Singapore, where it showed that whether you were treating -3 or -9 diopter, the SMILE eyes had the same inflammatory response as compared to LASIK, where it would be much more if you are treating higher myopia. And this is because there are always 2 passes of the laser with the side cuts and a small incision. So the same amount of energy is incident whether you're treating -3 or -9. No flap, meaning no flap related issue, no displacements. There are no very few chances of epithelial ingrowth because it's a very small incision. Less cutting of corneal nerves, dry eyes, less chance of dry eyes, less discomfort for the patient for a smaller period, and the possibility of better biomechanical stability, which you can't really proclaim today because we don't have enough ways to measure biomechanical stability, which is going to be the future. But I'm sure that it also makes more sense to know that you're not cutting out a lenticule. So it is going to offer a better biomechanical stability. The number of studies that shows that SMILE is superior in terms of dry eyes is now even much more than what I'm showing here today. The inductions of aberrations, as we had also studied and others had shown, is much less, and therefore you don't really need to customization. You get an optimized treatment happening, which is inducing less aberrations, and therefore it's a much better way of doing the treatment. As you can see here, we had treated 25 patients, one eye SMILE, the other eye femtolasic, and these were all high myopic group, more than -6 diopters. And you can see here the direct comparison, and it shows that the point spread function is much better in the SMILE eye as compared to femtolasic, as compared to also the image simulation in the SMILE eye, which is here the OS, shows much better as compared to the femtolasic. And the optical zone that you get is a real 6 millimeter if you have planned a 6 millimeter, as compared to a femtolasic where you would have some losses in the periphery. The workflow improvement is because there is no change of stations. You don't need to keep placing and removing the speculum, which would mean that you are saving on much more time and the patient is also much more comfortable. And this comes with not really an additional cost. You need to invest only in one laser with the capital cost, with consumable costs and maintenance costs, all for only one laser. So is there a debate? SMILE is the best. Thank you.
Hello, Rupal ma'am. Kem cho? How are you?
Hello, how are you? Good to see you again, Sunday after Sunday.
Thank you, ma'am. Yeah, this is the advantage of 4 Sundays.
Yes.
Thank you, ma'am.
Should I share my screen, Reshma?
Yes, yes, please.
Hi, Kavita. Hi, Sujata, ma'am.
Hi, ma'am. Hi,
everybody.
ma'am.
Hi, Kavita.
Hello, ma'am. Hi.
Hello, ma'am.
Hello, ma'am.
Are my slides visible?
Yes.
Yeah.
Thank you so much. So it's very tough to speak after one of the
Hi,
most
Chaitra.
senior
Reshma.
refractive surgeons in the country. So I have a tough job to follow Dr. Rupal Shah, who's been a mentor to a lot of us. I would like to say that I perform both the procedures and I really have no financial interest to disclose in any of them. And I'm going to try and put forward a rational, a discussion or a comparison between the two of them. Whenever we choose any procedure and when we declare it as a procedure of choice, I think there are certain parameters which that procedure needs to fulfill. So we need to look at the efficacy, predictability, outcomes, safety. Can we do retreatments with the procedure, and what are the economics of the procedure? So let's come to the first 3 parameters.
No comments. He's the best. All of them are the best. So no comments for any presentations. We are just learning. They are all the best. All of them, teachers. And so this is on YouTube, and we've had more than 30,000 views when we saw last time. So this continuing medical education for starting with Namrata and me, who are your first students, and then a generation of students. Nahi, sir, but teacher is always a teacher.
So you are a Can we mute other speakers?
Reshma, should I go
Yeah,
ahead?
yeah. I'll just we'll try and mute the other speakers.
Yeah, okay.
So
I think
Karishma,
Dr.
can you-
Ragini has probably is probably attending another session.
Correct, correct.
Yeah, that's
Okay,
probably.
Karishma, can you mute other speakers besides Kavita?
So I first met him when I was around 26, 27 years old, and he came as a DNB examiner. He was so ill, but he still came, and I learned how he was taking exams, and he was asking the most basic questions. And then Panna was with us, so luckily we had a chance to share some part of his life with us, and I agree with all of you. He's a great teacher and a great father to all of us, and me especially. As Namrata, I stand corrected. As especially Preetam is also here, so I think both of you
Someone
will.
needs to call Dr. Ragini Parekh, please.
All of you, Chityal sir, Shroff
Reshma,
sir,
can you?
Basak sir. I think what a lineup, and all of you are teachers. All of you are mentors, teachers. Dhane sir, do you want to say something?
You cannot mute Ragini.
Mute Dr. Ragini. Can someone mute her?
You can't mute her.
Can you ask the host to mute? I think that's possible to ask the host as well.
Yeah, I think it's okay now, right? Yeah, so looking at efficacy, if you compare the two procedures, you can see that LASIK can be performed when, there's more like myopia up to 12 diopters. Smile, I believe, is only up to 10 diopters. Astigmatism correction is also advantageous, like, LASIK appears to be more superior. Hyperopia, Smile clearly cannot address any hyperopia effectively. I know a lot of ophthalmic surgeons who have hyperopia and who've undergone LASIK. I wouldn't want to name this, prolific refractive surgeon. Now let's look at the other additional features. Can we do a topo-guided ablation with Smile? No, we cannot. Is there any torsional adjustment? Now in this day and age, when we're using virion, even when we're putting in a toric intraocular lens, in an excimer laser, the machine adjusts for any kind of torsional adjustment, but that's not what happens in Smile. So and so that's they mark the cylinder before, and then they make the patient lie down, which seems quite redundant. And also, there's no means to address presbyopia in Smile. Now let's look at Dr. Rupal showed a study. I'm going to show you another study. This is a randomized controlled trial where 44 eyes of 22 patients were taken, and in each patient, one eye Smile was done, and in the other eye, a topo-guided LASIK was done. And what they found, let's look at what they concluded. So you have to agree that there is no confounding variable because it's one eye of each patient. This is what they found. They found that the topo-guided LASIK was in fact superior in all the visual parameters which they studied. And they found that the difference was that because there was no eye tracking in Smile, there was no active centration, and there was no, and also of course the topo-guided treatment itself made it superior compared to Smile. So I think the discussion also reiterates the same point that virtually all the parameters rendered a statistically significant in favor of the topo-guided LASIK group. So I would say that in all of these parameters, LASIK definitely scores over Smile. Now let's look at the next parameter, that is retreatment possible. Now this is, let's come to that. So this is a patient where was taken up for Smile, and this is, these slides belong to a colleague, where loss of section happens and the patient was converted to femto LASIK. So now please keep in mind that you do need to have the excimer technology in your OR. So the point that it is economically more valid because you don't need to buy the excimer is completely goes out of the window. If you have a suction, you need to convert to femto LASIK. This is not, the patient, this is another patient with a suction loss, and the patient was then converted here, you can see, to femto LASIK. Both patients did do well eventually. This was after the dissection was tried. So is retreatment possible? Even if there is some residual error, I'm sure there would be some patients where retreatments are needed. Either they in Smile you need to do a PRK, or they need to lift. You need to create a flap. Whereas in LASIK, you can very well just easily lift the flap and go ahead with the retreatment, even at a later date, even not necessarily on table. Now let's look at the next parameter, which is safety. So I believe, of course, it's been saying that they're saying it's safer because, there's a smaller cut, there's no flap, less dry eye. It's a tectonically stronger cornea. So intraoperative complications, as you saw, are definitely, probably there is a learning curve. Dr. Rupal is one of the most senior person, and as she said, she's pioneered the technology. But I'm sure for the newer upcoming surgeons, there is a intraoperative complications which can happen, which is it's not like unique to LASIK. Also, flap related complications, even if there's a smaller entry, there is a flap. So there's not a flap, but there is a dissection which is happening. So that epithelial ingrowth, DLK, has also been reported first after SMILE. Now let's look at dry eyes. Now it's a myth that corneal nerves are cut only on the surface. We know that cornea is going through the entire stroma. So if you're removing a lenticule out of the cornea, you are cutting corneal nerves, whether you're ablating it with excimer or you're dissecting it out through SMILE. If you look at the comparison of regeneration at 6 months, there's absolutely no difference between SMILE and in LASIK as far as the corneal nerves regeneration is concerned. Now, Theo Sella, who's the father of biomechanics, he himself has mentioned in this study that there is nothing to prove that biomechanically the SMILE is superior to LASIK. And all of these studies are also showing that there is nothing there's no definitive. I'm sure the jury is still out on this, but there's nothing definitive that says that biomechanically SMILE results in a stronger cornea, and ectasias also have very well been reported post SMILE. Also, I think a lot of haze and quality of vision with the higher corrections has been reported post SMILE. So in terms of safety, I wouldn't say that SMILE is way below but LASIK, but I would still say that LASIK is definitely superior in terms of safety. Now, let's look at the economics. Now, when a LASIK surgeon is starting his practice, if he wants to just start with just an excimer laser, he's sorted, with just a microkeratome, and still he can set up a practice. There's so many parameters which go when you're selecting an excimer laser. There's so many options available. These are the options available to us, and they're giving us so many so many specialized ablation technologies. Like they're giving us presbyopic treatment, topo-guided ablation, wavefront guided ablation. So when you have all of this, you can just straight away start your LASIK practice. So this is the cost, which goes in looking at an excimer. Now, when you're selecting a femto, of course, all of these parameters again come, in play. These are all the available options that we have, out of which the technology, which is currently, known as SMILE and the lenticule extraction, is patented by Zeiss, and it's still a lot more expensive compared to the, other femto lasers. So I think when the other companies also start coming up with their own lenticule, and which I know they are, probably it will become more competitive in terms of costing. But as of now, because you cannot run your practice with just having your SMILE machine, you need to still keep your excimer. So I would say economics definitely it works in favor for LASIK versus SMILE. So I would say if you don't want your post-op patient reading like this, please stick to SMILE. Now I want to end. Stick to LASIK, I'm sorry, but sorry. I want to end with a disclaimer that whatever machine you have, what is more important is knowing when not to operate. If the patient has, corneas, some corneal topography abnormalities, please don't operate. Choose the right surgery for the right patient. The surgeon, your discretion is more important, and the machine is second. Thank you so much.
Thank you, Dr. Kavita and Dr. Rupal. That was a fantastic debate. I'm sorry, Dr. Kavita, you lost some advantage because of a lot of distractions, but still, I think we learned a lot through both these meetings. We are running really short on time. We've got 10 minutes to finish the session. We'll take an extra 10. So I request the other speakers to start right away. Thank you.
Suvira, I'm really sorry. I'm trying to join from 2 computers and I am the distraction. I'm so sorry. Sincere apologies.
Not at all. It's all good. It's all good. Thank you. Let's continue. Thank you. We need to introduce the next talk.
Dr. Jai.
Okay, so now we come to the next debate session, which is on dry eye, which has become a very pertinent problem nowadays. We have 2 excellent speakers, Dr. Sharon D'Souza and Dr. Anaga Herur, who will be talking about LipiFlow and IPL. and definitely are eager to hear what they have to say. Over to you, Dr. Anaga and Dr. Sharon.
Dr. Sharon is speaking first, right? Yeah.
Are my slides visible?
Yes, yes.
Good morning, everyone. And at the outset, thank you very much to Women's Ophthalmic Society and BOA for this opportunity. It's been a great session till now. I know we're short of time, so I'm going to keep this quite pertinent. I have no financial interest in it, and you must know that I have used both the therapies in question. So without further ado, let's start. So what we must remember that comparing these two technologies is sort of like comparing apples and oranges, because they work on totally different mechanisms of action, which I'm sure will be quite evident through the two talks. Even though they both are targeted towards MGD and evaporative dry eye, the indications are slightly more different because MGD itself is so broad that the presentations, the severity, the other adjuvant changes on the lid and the ocular surface are so different. So, you know, the indications for deciding which one would work may be different. And of course, the indications and contraindications for them are also slightly different. That being said, what we are here to debate today is to see whether these conditions, these technologies do work for our MGD and evaporative dry eye. Now, we all are very used to treating these patients, and we treat them with a lot of different medical managements that we have, be it the drops or the warm compress or, you know, the lid massage. But we still have patients who sometimes do not respond as we want or have some amount of improvement and then come back with a recurrence or a severity. So why would this be? So that's what we're trying to understand through all the various advances in our research. So understanding the disease and what we are treating is always very important, and that is, of course, across various pathologies that we have. But what we must remember that in severe chronic MGD, a lot hinges on the adequate expression of the meibomian glands. And once that expression happens, it gives not only an immediate relief, but also a sustained relief in these chronic conditions. So why do we need a newer therapy? Is that even though we know that conservative management does work, but not in all. There can be patients who are non-responsive. There can be patients who don't do it as we want, as well as we want, as often as we want. Some patients just want a faster result. And sometimes with patients who have any dexterity issues, it may be difficult for them to do the warm compressed lid hygiene. So I'm not going to go into how the LipiFlow works. We all know it quite well, but basically it's an expression of the glands along with the prior heating of the glands from inside out. So when we are looking at a yardstick to assess any treatment, we must know what are the prerequisites for treatment, because our outcome measures then would depend on what we kept as our yardstick for improvement. So what we must know is that for treating an MGD, we need adequate heat, which is deeper. It has to go near the meibomian glands. We need some amount of pressure for the expression of the meibomian glands, and I'll come to that. And at the end of it, we want a patient who is comfortable, and the treatment should be effective. So when we're talking about the heat, there have been various treatments which are available for heating the meibum in the glands, and there has been a study which has compared all of these as well. What we need to know is that for the change from a solid state to a liquid state, there is a phase transient temperature, and that is around 40 degrees. Now, none of the therapies which we give from an external surface actually reach that temperature adequately and for an adequate amount of time. If we take just a warm compress, which we do by hand, the towel or whatever cloth is used needs to be kept there at around a temperature of 45 degrees centigrade on the skin, and at least around 10 to 15 minutes. And then too, it does not reach the adequate temperature on the inner surface. There have been no studies on how much the temperature rises with the intense pulse light. But what we do know about it is that because of the kind of energy which is delivered, it is a very transient rise in temperature. So even though it does affect the blood vessels which are there and cause a change in the, it can cause a coagulation of the smaller vessels, it may not be adequate to change the MEBM. The lipid flow, on the other hand, the thermal pulsation system, that's the principle it works in, is that because it is heat from inside, it is closer to the mebamin glands itself, and it is the only technology which is shown to reach the adequate temperature required. Now, in addition to the heating of the MEBM so that it's liquid enough to come out, we also need to express the MEBM. And there are various methods which are available to do a therapeutic expression, be it with your buds, the finger, or various manual instruments. Now, doing the expression is not the problem, but it has been shown again that the amount of pressure required to express adequately can cause significant pain to the patient. So even if we put a topical anesthetic, the patient may not allow you to put the adequate amount of pressure because of the pain. So this becomes a limiting factor when we are trying to treat them. Now, there's enough data on both these technologies to show that they work. There's no doubt about it. But what changes is whom they work in and how long they work for. So we've done extensive work on this, and I'm not going to go into detail for lack of time, but suffice to say that there is a significant improvement, not only in the kind of secretions from the glands, the tear breakup time, which is our parameter for evaporated dry eye, the lipid layer thickness, which again measures how the tear stability is, and the patient's symptomatology. We've also looked at the inflammatory factors, which have also reduced. So there's a significant improvement across different parameters that we've looked at. So there's no doubt that this therapy, this technology does work. We can also look at it from a totally different point of view, because we know dry eye can affect how the patient sees, the visual quality, and there is a significant improvement in patients even for their visual quality after this procedure. So it shows that post-thermal pulsation, you can get an immediate and sustained effect. So why not do this treatment? Is cost a factor? Of course, it's always a factor. Economics plays a big role in how we choose a treatment for a patient. Even if we don't choose, it matters to everybody. So when we look at the two technologies, of course, the thermal pulsation system is quite expensive. But if you look at the long run, these are patients who use multiple different medications. Some of these medications, especially the preservative-frees, are quite expensive. The intense pulse light does require multiple sittings sometimes, and that also is an added cost. So if you look at the big picture, it's not such a big difference between the two. With that, I end my debate. Thank you so much.
We are running.
I'm done.
Yeah, thank you so much.
Thank you.
We can have Dr. Anaga.
Yes, yes. Can you see my slides?
Yes, we can. We can.
Yeah. Thank you so much. Yeah, I would be speaking on the IPL therapy. Thank you, Dr. Ragini ma'am, Dr. Lane sir, and boss, Dr. Mohita Sharma ma'am, for giving me an opportunity to speak here, and happy birthday to you. So speaking about IPL therapy, yes, today when we are talking about dry eye and specifically about MGD, we need to treat the cause and not just the symptoms. No financial interest here. India is on the brink of a disease, dry eye disease epidemic, said a study a few years ago. But today we see that we are already, along with the pandemic of the COVID-19, I think there's also a pandemic of dry eye today. And this prevalence is only going to increase because of the increase in the amount of exposure to digital devices today. We all know MGD is a progressive disorder and we need to diagnose early, treat early. This is a hugely underdiagnosed problem and a lack of awareness, not only in patients, but also among ophthalmologists. So patients keep moving from doctor to doctor with non-specific complaints and the diagnosis remains undiagnosed. So in one of these papers showed that the consequences on health of COVID-19 was the use of PCs and smartphones has increased by 300%, and so has the increase in the amount of dry eye. So yes, we would look at a patient of MGD with a lot of clinical findings and correlate with other tests like the knee-butt or the T-butt, along with mybography. Look for the changes in their meibomian glands. Challenges continue today with not only medical management, but we know that the effect of this medical management would be limited, not just in time, because this is a chronic progressive disorder. The patients will keep coming to us once the effect of the drops has reduced. We are only giving them temporary symptomatic relief. So that is why we need to treat the cause. And these options come with, along with LipiFlow, you have the IPL treatment. Now, let us all see, as ophthalmologists, what is it that we want to do, especially with the introduction of latest treatments. We not only want to make these treatments accessible to the masses, but also keep the costs low so that it is affordable to the masses. Now, coming to the exact mechanism of action of the IPL treatment, you have first this mask treatment, which is a patented photo biomodulation technology where you use an LED matrix light, which has an optimized wavelength. It activates the mitochondria and triggers the cell ATP production. So basically, you don't actually need an external heat. Basically, there's an endogenous heat here that penetrates the meibomian gland, liquefies the fat, and improves the expression. Because after this treatment, definitely you are going to do a meibomian gland massage and expression of the meibum. The tear lipid layer is increased and it restores the normal functioning of the gland. Now, the IPL or the optimal pulse energy treatment also is very, very simple. This takes hardly 2.5 to 3 minutes, no local anesthetic required, just bursts of light, and with a protective eye shield, you can give very good effect to the patient. So basically, this acts by closing the telangiectatic vessels. It prevents the pro-inflammatory cytokines, decreases the bacterial load, stimulates the neurotransmitters, and helps to increase the flow of the lipid. Yes, you would require 2 to 3 sittings, but in my experience, even with one sitting, a lot of patients have had very good experience and improvement in their dry eye symptoms. You need to give probably a maintenance treatment once after a year if the patient comes back to you with complaints. Now, there is an extreme ease of operation. It can be easily done by the technician and the paramedical staff. You're not touching the cornea, you're not touching the eye, no and local anesthetic required. You can treat all stages of MGD. Yes, in extreme advanced cases, it could be less effective. Also, the indications expands to other treatments like blepharoplasty, chalazion, or Demodex. It is portable and hence you can use it in other centers also. This has been our experience. This is of the first 500 patients, 90% showed improvement, more than 50% improvement in 40% of patients. There was reduced itchiness and eye pain. Eyes felt more moist. Now, this was a 37-year-old patient, but symptomatically there was a very good effect within the first week itself. And post IPL 3 months, you could see that there was an improvement in the T-butt also. There are hardly any side effects, especially with IPL. But with LipiFlow, it's totally different. Here, especially only if it's a very dark skin, probably you could have a little tenderness or a burning sensation. Whereas with LipiFlow, there are supposed to be so many side effects like itching, stinging, burning, foreign body sensation. So finally, the patient, after paying so much, would probably think whether it's better or worse. What does the literature say? Yes, at least 75% improvement and more than 60% improvement in those where LipiFlow had not shown improvement. Maintenance therapy, most importantly, is cheaper and more acceptable because the cost of the consumable is less. Even the maintenance therapy, the cost is not so high at all. A lot of studies have shown that there is a statistically significant reduced symptoms with the IPL. Also, there are changes in there's improvement in the T-butt time, improvement in the tear film. Now, this was a study which compared the efficacy of LipiFlow with IPL, and it showed that, in fact, the tear meniscus height actually worsened with a decrease of 6% post-LipiFlow treatment. This was another study which very recent in Jan 2021, which compared the pre and the post-treatment with IPL and LipiFlow, and it showed that the only difference is that IPL is cost efficient, whereas LipiFlow is time efficient. And yes, cost is an important factor today. Patients would probably pay as much as whatever you're charging for LipiFlow for a cataract surgery. So that is why it is very, very difficult for patients to accept a treatment as costly as that. Local anesthesia is required. Some patients would find that such a huge thing clipping onto their eyelids, they would be probably a little apprehensive about it. Recurrent treatment would have escalating costs. Again, it was very difficult to use LipiFlow in recent ocular surgery, very small eyes, if there are already punctal plugs or in patients, and it would work with probably only mild to moderate dry eyes. So to conclude, you need to see at efficacy results, the mode of treatment in greater technology, ease and patient comfort, which is there in IPL, and definitely economics goes in favor of IPL. So the IPL treatment today puts MGD management on the fast track and more amenable to more patients. Thank you so much for your patient hearing.
Thank you. Thank you, Dr. Anagha and Dr. Sharon. That was a fantastic overview of both the newer modalities, and I think each of us needs to consider moving towards one of them. Without further ado, we move to the next talk. I request the speakers, Reshma, please bring in the next speakers.
Yes, I'd like to invite Dr. Chaitra and Dr. Parul Deshpande, ma'am. They will be speaking about institutional practice versus private practice. We'll begin with Dr. Chaitra, please.
Hi, everybody. Pleasure to be here. I'll go straight to my talk. We're running extremely short of time. So if you're not really cut out to handle these major aspects of private practice or solo practice, which involves a lot of paperwork, a lot of regulatory compliance, financial management, I think these are some extremely important things, but you only want to focus on patient care because that's what you feel you're most comfortable in, then an institute is definitely better for you. I thank all of y'all for this opportunity. So what does an institute practice basically entail? It could be single or multi-speciality. I work in a single specialty wherein every specialist there is an ophthalmologist. Many could work for chains like Apollo, Fortis, wherein they have other specialties as well. This makes up for a majority of physician practice settings. The sharing of patient care duties, especially in the scene of Mucor now, if you have a multi-specialty, somebody could, from ENT, from ophthal, neurosurgery would be taking care. It's less volatile than solo practice. And the main advantage being it's an increased financial security because, you don't have as many overheads as a private practitioner would have. In addition, you also have access to colleagues who can help you, mentor you when you have tough diagnosis. Compensation methods, of course, widely vary. It could be higher in single specialty practices, but you do have the options of bonus and incentives depending on which institute you're in. And a special training or specialty expertise can definitely help in you getting into an institute. Now, the benefits, other than what I told you before, are predictable incomes, a steady patient database, built-in referral network via other hospitals or within your center itself. And you have a lot of freedom to plan your life. You can actually decide when you're entering the hospital, when you're going to leave the hospital, your holidays, because you have people covering up for you. So pretty much your lifestyle is predictable, unlike a solo practice where you're the whole and soul and you can't really take a break as and when you require. The next big advantage of being in an institute is that you have a lot of opportunity for academics. You have residents and medical students all around, and you typically are a mentor to them. You can also get involved in a lot of research, whether basic or clinical science. So what is right for you depends on your business acumen, how good you are at handling it, because at the end of the day, you have to run this practice or a business. The referrals that you get, very young in your practice, you may not get. It's good then to work in an institute. Whether you're capable of working with others around you, how are your people skills, how good are you at managing finances, and how do you want your daily routine to be, how predictable you want it to be. Whether you're newly qualified, whether you're an extroverted person, all of this makes a whole lot of difference. And basically, if you're a person who doesn't like being in charge of taking decisions, then an institute is the place to go. But it's not for you if you want to be your own boss. You don't want to take orders from anybody. You want to have autonomy. You want to implement your own philosophy. You have your own thoughts and ideas. And if you want to implement just those, then you need to go solo. I enjoy my work so much at NN, and I've learned so much from my colleagues. And there's a personal, satisfaction being part of a team. So hence, I'm extremely happy being where I am at the place that I work. But it does also give you a stepping stone or a preparation for your private practice. And I wouldn't, choose an ideal practice right away. You will need to take time, figure out what suits best for you, explore your options before deciding on a setting. So all this and more I could only do because I was in an institute which supported all my endeavors, all my academic endeavors, and anything else that I wanted to qualify. And it did give me a huge, huge platform where I am today. So thanks to all of y'all who've also been part of my journey somewhere or the other, and hence I'm also surely part of this webinar. Thanks to all of y'all.
Thank you, ma'am, for summing it up so nicely. I think, Dr. Parul, we can move on to you now.
Yeah. So can you hear me, Karishma?
Yes, we can.
You can see my slideshow?
Yes, we can.
1 second. Okay, so after hearing from Dr. Chaitra about the institutional practice, I would be talking about some of the pearls in the private practice that one can have in smaller ophthalmic clinics or the nursing homes. So as we all know, private practice is the cornerstone of Indian as well as the global healthcare system. This is because it's one of the first points of contact with the needful patients. And in many of the rural setups, distant places where you don't have large hospitals and large healthcare facilities, I think private clinics are the ones which look after our patients. And it can cater to all the types of treatment depending upon the size of the clinic and the practice. So one can look at the primary, secondary, tertiary care, complicated cases, okay, depending upon the size of the practice that one has. In India, a lot of patients usually land up in the clinics without appointments. And this is probably the best for the private clinics as compared to the institutions where it usually works on the appointment-based visits. And some of the specialties really do very well in private clinics, that is ophthalmic, dermatology, ENT, pathology. So one could have a solo practice, could have a group practice or a dual practice in order to have the good financial stability. So we have growing numbers of hospitals coming up. So how does private clinics they remain as the pillar of the social the community practice? So it's because you have a better doctor-patient relationship. So as the doctor is the face of the clinical practice in smaller clinics as compared to the institutional practice where it is faceless. So it basically runs on the institutes and not on the doctors. So it caters to the individual needs of the patient. So unlike the conveyor belt treatment in institutional practice, where a patient moves from one room to another without having a human touch, it's more time consume. You usually devote a lot of time to the patient because you cater to smaller number of patients, and hence you make a stronger bond and a trust with the patients. And this in turn would result into higher footfalls as well as the financial stability which is given to the practice. And last but not the least, patients who are visiting a private practice will spend far less money as well as time as compared to those who chose institutions. So how do you have a successful private practice? So you need to have more patients, and more patients means better infrastructure. So there are certain factors which you could use as a solo practice to improve the infrastructure, as well as you could acquire certain specialized skills, as already told by Dr. Chaitra, that you could have specialty training through some fellowships or observerships and improve your clinical skills as well as surgical skills. And you may have to do your own marketing, so you may need to have some awareness camps, programs, online presence, etc., to improve your private practice. So what are the individual benefits that a doctor has is that you can work on your own terms. You enjoy the independence. You have the flexible hours of working. So if you have a family life, you can balance it along with it, especially for women. And you can see the financial gain as well as the individual growth, which is direct, proportionate to the efforts that you put and are visible. It's and more than an institutional practice, which is merely a salary with bonus. So what is the factor which deters anyone from the private practice is the initial capital investment that you need. So how will you make the initial investment? So you could probably have a group of doctors who can come in together for a group practice or an LLP association, or you could take a family or a bank loan, or you could attach yourself to some of the hospitals, charitable hospitals, from where you can gain some financial stability in order to run your private clinics. It's important that you go with rental or a lease property instead of buying out at the outset. Have a staggered equipment purchase so that you can make the strong technology infrastructure in a very short period of time. So what is the fear of private practice? It's the failure. It's the low initial profits, high capital investments, seasonal fluctuations, which which definitely threatens the clinical practice. And the growing numbers of government regulatory approvals that you need, Consumer Protection Act, which is definitely a risk environment for private practice. Some of the malpractices definitely exist in this kind of practices, something like a sharing referral profits over prescription of drugs, investigation. I think one should avoid these things in order to have a good, successful practice. And definitely, as already said, that you would probably see more of an ambulatory patient than the inpatients or a complicated patients in your clinical practice. So how does a private practice differ from an institutional? That you will not have an internal movement because you are the boss, you are the top authority. So you probably will have more financial incentives as compared to the salary paychecks in case of institutions. And you will have a more competitive practice in the outside because you have the hostile world around with you. And innovations may not be that possible as in institutions. And if you have to learn new techniques, it may be slow as compared to those who are in the institutes who would learn it faster. So how would you analyze and how would you decide whether you should go for an institutional practice or solo practice? So I think something which helps us is a SWOT analysis. So what it looks at is the strength and weakness of any of the practices. So if you're looking at solo practice, you should look at what are the strengths, what are the weakness, and you look at the opportunities and threats, which are the external factors. So if you have these external factors which are too strong, I think probably it's better to go with in an institutional practice. But if you have the good internal factors, strength, weakness of your project or your practice is good, then probably you should be going for the solo practice and you would do very well. So the basic requirement for a private practice is the multitasking. So you need to manage your finances. You need to have good clinical skills, surgical skills, administrative skills, marketing skills, and academics can be done in private practice. Though it may be small case reports, case studies, and not big studies, randomized studies are not possible in clinical practice. So a private practice would have a better patient care with human touch and less cost of treatment. Good skills and infrastructure will definitely result in a successful clinical practice and ultimate financial stability. And it would better to have it. One can reduce the initial cost of investment by having a good practice or by taking bank loans. And it is possible to do clinical research in your private practice too. Thanks.
Thank you very much, Dr. Parul and Dr. Chaitra. This remains a bit of a conflict for all of us, whether we want to push for practice or we want to be in institutes. Thank you very much. And with this, I think we can conclude the session. I think it's been a brilliant session with some brilliant input from all my dear colleagues and friends. Thank you very much. And I'm sorry for the next session. We also started 10 minutes late. Thank you very much. Goodbye. Stay blessed. Love you all. Bye.
Thank you.
Thank you. Thank you, everyone.
Thank you, everybody.
And happy birthday once more, Mohita. Have a wonderful day and a wonderful year ahead. Bye all. Thank you, Ragini ma'am.
Thank you.
Thank you, Ragini ma'am, for this session. Bye-bye, everyone. Love you all. Let's end it.
Good afternoon, everyone.
Hi, Sumit.
Hi, good afternoon.
Everybody of our session is there, then we can start.
Yes, sir. Just a minute, I'll just call up sir. He's here. You're muted.
I think all the experts are seen and also the cases going to be presented. I think Sumit, who is going first?
Susha ma'am will be going with her neuroophthalmic case first.
Okay, please go ahead. Please go ahead.
Susha, are you there?
I don't think he is not there.
She's there, sir. She was just there.
Yes, yes.
Yeah.
She is seen now.
Unmute you. Unmute.
No, she is unmuted. I think there is some problem. Susha?
Hello. Hello.
Yes, yes. Yes, please go ahead. Please go ahead, Susha.
Good afternoon, sir.
Good afternoon.
I'm trying to share my screen.
And
Can you please make it shareable?
there are two devices on in the same room at your side. That's why we are getting echo. You can just use the one device.
Yeah. I'm trying to share my screen.
Yes, ma'am.
What is the problem, Susha? What is happening?
It's not allowing me to share the screen. This happened last time.
Okay. Your computer is this one.
Mac.
Apple.
Yes, sir.
In Apple, there is some problem. I think. Okay, till she joins, I really welcome all my panelists. That is Himalini is there. The Pritam, Santan, Gopal, Nikhil, Ragini Parekh, Rita Dhanamankar, Santosh Mahapatra, Santosh Honawar, Kuresh Maskati, and Manish Shah. So I welcome you all for this discussion. And here we discuss the patients, common patients. This means for the general people, how to manage these cases. So we discuss those cases in this. So I think she has some problem. So she can send her presentation to someone, and we can present from our this one. So we can go for the Karishma. Karishma is
Yes,
there?
yes, I'm here.
Yes, Karishma, go ahead.
Yes, sir. Can you all see my screen?
Yes, we can see Karishma.
Okay, sir, thank you. So I'm going to be presenting two cases. What will you do? The purpose of these two presentations is it's something that we face commonly, and we would like our expert panel to highlight for the general ophthalmologist how they can go about treating such. Okay, so the first case is a 38-year-old female who complained of redness, pain, and watering since 15 days. She had an episode of conjunctivitis 15 days back. And I'm going to be showing the clinical picture. What she arrived with was severe filamentary keratitis. And I had done a Schirmer's test for her, which was showing right eye 7 millimeters and left eye 6 millimeters. This is what her picture was. It was completely studied with SPKs, and there were a lot of filaments as well. So on probing for her history, she had been already to a lot of ophthalmologists, and on visiting different people, everyone had given a full cocktail treatment, all possible types of lubricants, steroids, cyclomune, antibiotic, both types, moxifloxacin as well as tobramycin, and one person had even given her an antifungal. So the question was over here what to do. At first, I did think that it could possibly be even a medicamentosa kind of a picture. But the question to our panelists here would be, should I just increase the frequency of the drops, put a bandage lens? Is there any role of autologous serum over here, or systemic investigations? Over to our panel. So what would you all recommend for such a case?
1 minute. Yes. I think Karishma, what you are saying is very correct, that what is to be done. And we have got the people, Nikhil.
Yeah.
So
I think young patient coming following conjunctivitis, as you said, 2 weeks with lot of filaments, and there is lot of staining on the cornea. Normally, and the patient has probably put a lot of drops. So I would rather first stop all the extra medications like antibiotics, steroids, and possibly just continue the lubricants for maybe a week and then re-evaluate the patient. If the
Nikhil,
filaments
I
are,
just joined. I
yeah.
didn't see the
So maybe you can show the picture.
Yes, sir.
Basically, it's a case of a young patient who had conjunctivitis, and then after 2 weeks came with severe filamentary keratitis, lot of staining on the eye surface.
Okay.
And the patient has put lots of drops of all varieties, including antibiotic, antifungal, lubricant,
okay.
steroid, etc. So what will you do at this stage? First stage, I think I would stop everything, just put maybe, if possible, preservative free or low preserved lubricants, and see the patient again in a week or so, you know.
Right.
Absolutely.
Kuresh?
Yes, I totally agree with Nikhil. Only thing is that I would not wait if the patient was able to travel, then I would call the patient within 48 hours of stopping all medicine and starting preservative-free lubricants, because these patients are actually prone to corneal infection because the resistance is low because they've been bombarded with all sorts of medicine. Their tears are low, so their immune status is very low. They can get a small abscess somewhere. So I would call the patient in 48 hours after the stoppage of all medicine, and only on, but I would agree with Nikhil that only preservative-free lubricants, very frequent usage.
Okay. Thank you.
Thank you, both of you. In addition, I would like to say that this particular patient, we did, so she was very keen that should we do any systemic investigation. So even though I was planning to do the same as you all said, just pause the other medication right now, because she insisted, I said, okay, fine, let's just do a systemic workup for you. And just a moment, yeah. So evaluation, her RA factor was above 350. So I did, as we planned, stopped all the antibiotic steroids, but I did refer her to a rheumatologist. And on subsequent follow-up, she responded very well over the next 3 weeks, just with systemic therapy and preservative-free lubricants. She was doing very well. So I think it was just by fluke that we did the systemic investigations for her. Otherwise, I think I would have done the same as what you all said.
No, it is very good that systemic investigation is a one take-home message in such situations. And what Kuresh and Nikhil said, that we should stop all the medicines. See what is happening nowadays. When the patient is coming to us, every time patient is going to one person to another person, because this is a chronic disease. And when he is going from one person to another person, everybody is changing the drugs. And because that they are changing the drug, patients are giving such type of, you can say, it is called as
medicamentosa.
Medicamentosa. So that is the problem which is happening. So I think we should avoid that, and you can go for the next case.
Yes, sir. So next case is a 25-year-old male who complains of blurring of vision since the past 6 months, and he has a history of using glasses since 2 years, which have been frequently changing. The clinical picture was typical of keratoconus. His west-corrected vision in the right eye with a -5.5 sphere and -4 cylinder was only 6/18, and left eye was -5 with -4 cylinder, improving to 6/9. The was as well. Which is confirmed by the K values and the pachymetry. Now, again, the question over here actually for our panel is to kind of highlight that what is the actual cutoff that the general ophthalmologist should keep in mind. Usually they have only one pachymetry reading which they get, as opposed to the newer topographers, which everyone does not have access to, where you have a point-to-point pachymetry. So you get one pachymetry of the apex in this eye is 392, and in the other eye is 421. And there is a lot of confusion in general about whether they should be using hypoosmolar or isotonic, or they should directly switch over to lenses, or not do anything and wait and then later on do surgery. So, so what would your recommendations be?
Yeah, so in this patient, particular patient, I would not go by the apex pachy, but by the thinnest pachy. So if you see the thinnest pachy in the first case, is the first eye is 372, and in the second eye is something like 390 something.
That's
so
right,
you are on the borderline. This seems to be a progressive keratoconus, because so you see the thinnest is 398 here, and in the ODI it is 372.
That's right.
So go by the thinnest pachy, not the apex pachy, because when you are doing a C3R, you're going to do a large area, including the apex, including the thinnest area. So you're going to damage endothelium if you do a conventional C3R over here. So if you want, you can do a hypotonic C3R, or you can do a contact lens assisted C3R. These are some of the tricks that you can do, because this does seem to be progressive. Karishma mentioned in the history that the refraction has been changing. So this gives you indirect evidence that it's not a stable cone, it's a progressive cone. So I would say that this is borderline. I would still do a C3R in this patient. It's a young man. And then, of course, you can go ahead with your routine management, different types of lenses to see which lens would fit. Because soon, within a few months, you will lose the opportunity to do C3R.
Is it,
So I think it's very important that we shouldn't say that we don't have global pachymetry, because there are so many refractive surgery clinics who have these type of machines, and we can always refer our patient to one of those clinics and get a pachymetry, because there will be a lot of difference in the thinnest value versus the central pachymetry or ultrasound pachymetry at some random point that we take. So always we need to be sure what is the thinnest point, because it might change the way we are doing cross-linking. So all patients of keratoconus must have a global pachymetry map so that you know what is the thinnest, the central value, and thereafter you can plan your cross-linking procedure.
Okay. Sumit, you want to add something?
Yeah, if allowed, I want to add a question to Nikhil sir and Kuret sir. The point here is at what pachy is your cutoff for hypoosmolar also? Like at what pachy you say the thinnest pachy that we cannot even go ahead with the hypoosmolar riboflavin?
Sumit, it's a good question, because I am not someone who favors hypoosmolar. I do only if it's above 400. I do a conventional Dresden approach, and I am personally not in favor of. But I would, if I was doing it, I think 375 would have been my cutoff. So this would have been a very borderline case in which to attempt this.
Yeah, I agree with sir, because normally even for me it's about 375. Though if you look at the published literature on hypotonic riboflavin, mathematically they have shown that up to 320 or 325 microns also you can go. And Dr. Rohit from NN have also shown that you can use low fluence or low energy, and therefore make it safer to do. However, I always feel that a structure which is so thin and has become weak may not be getting strengthened just by forcibly doing, trying to do and achieve a C3R technique. So if it is less than 375, I normally tell the patient that if required, you use a contact lens, and if it goes bad, we can always do a lamellar graft after some time, because there is a risk of getting endothelial burns or corneal decompensation, which has also been reported if you don't do it correctly.
Okay. And sir, just to add one more question, if such a patient, if we don't operate like it's 373, 317, we put on the scleral contact lenses, and then still we want to monitor a progression, it is happening or not happening. Like when do you tell patient to stop the scleral lenses in particular to come back for the repeat topography?
I think scleral lenses basically don't compress the corneal structure that much. So I don't think that so much of a problem. But if you're using a RGP contact lens, then definitely, technically one would say 2 to 3 weeks. Practically, it is not possible, especially if there is bilateral keratoconus. In some of these situations, I tell the patient stop using lens in one eye, function with the other eye, contact lens, and then after a week or so, maybe do the topography or pachymetry or whatever map you want. And then maybe when is possible, switch, start using the eye you have tested, and then do the other eye after another week or 10 days, so that they can discontinue the lens wear. Because you can get warpage, for example, of course not here, but there are some patients where you can get artificial flattening, and there can be patients with contact lens where a keratoconus was diagnosed. I saw the picture, looks like keratoconus, and after 1 month of stopping the lens, there is no keratoconus. This can happen even with soft contact lenses. So we have to rule out warpage before we are sure and we want to do any C3R or anything like that.
Thank you.
Thank you.
Okay. I think thank you very much. You can just stop screen sharing, and we can go for the.
Dr. Sushma ma'am, I think is ready.
Is Sushma ready?
Dr. Sushma ma'am, ready?
Yes, I am. Can you allow screen sharing? It's again popped off. The share button is again popped off. It just shows cancel and the share is not clickable.
Hema ma'am, can you share the screen for her?
I've sent the presentation to Hema ma'am and to you, Sumit. I've sent it to you as well.
So, okay, as the Sumit will go ahead with the presentation in the next this one. Till that time, I will ask Dr. Amrita Kumar to present her
Yes,
case.
sir.
Dr. Amrita.
Yes, good afternoon, sir and madam. Thank you for this opportunity. I'll just share my presentation.
Amrita, your surname is Kumar. I know first time. She is my SR.
Yes,
She is
sir.
my fellow. I know only Amrita.
So where can I go? Please?
Share. You
Yes,
are.
sir.
Yes. Slideshow. Yes, Amrita. We have learned everything. Go ahead.
So, yes, sir. Thank you, sir. So today I'm going to discuss 3 simple cases which we encounter in our day-to-day ophthalmic practice. First case is 56-year-old male patient with diminution of vision in left eye since few days. History of cataract surgery with PCIOL a month back. No history of systemic illness or trauma. On day 1, his vision was finger counting 5 meter with thin pupillary membrane. Cornea was clear, AC was formed, but there was minimal reaction. IOP was normal. So we started on oral steroids and topical antibiotic steroid midweekend drops for him. After a first week, his vision was finger counting 5 meter, which was improving with the hello, which was improving with the refraction of -2 sphere, -2 cylinder at 180. He was on mydriasis, so anterior-segment showed PCIL in sulcus, which was inferiorly decentered, and fundus was showing anterior vitreous haze. Other retina was normal. The patient was asked to continue the medications and to follow up, but he lost the follow-up and came after a month and a half with diminution of vision since 2 days, sudden onset. On this follow-up, the vision was finger counting 5 meter, which was not improving on pinhole or refraction. PCIL was again inferiorly decentered but stable. Fundus was showing few antivitreous opacities and retina was on, FR was dull. And this time we noticed the IOP was raised to about 24 mm of etching. And the fundus photo and OCT we did, which was showing cystoid macular edema, which was a pseudophakic cystoid macular edema. So in view of raised IOP, how will you proceed and treat this CME? So in view of raised IOP, I stopped all the steroids for this patient, considering he may be a steroid responder, and started him on NSAIDs. And for IOP, I started him on carbonic anhydrase inhibitors, that is either acetozolamide or dorzolamide, avoiding the beta blockers and prostaglandin analogs. So I would like to ask whether in these patients, how will we proceed further? Like just to wait with the NSAIDs and IOP control for a month? And how soon can we consider anti-VEGF or other treatment?
Okay. You can stop sharing the screen, and then we have got the very senior most retina surgeon with
Yes,
us as this one faculty. I will ask Dr. Santosh. Santosh.
Yes, sir.
Yes, please guide.
Now you have a case which is most probably pseudophakic cystoid macular edema, but
yes,
with a raised IOP.
1 minute,
Yes,
Santosh. 1 minute. Pritam, Amrita, Preeti requested to switch off your go on mute, please. And I request those who are only talking, they should unmute themselves, and baki the others should mute. Yes, Santosh, go ahead, please.
So, as the intraocular pressure is high, we need to first tackle the intraocular pressure for now and wait for at least 2 months with anti-inflammatory medications. If it is still not subsiding, we can go ahead with intravitreal injections of anti-VEGF. But before that, you need to go for a thorough systemic examination of the patient to rule out any other cause of macular edema which is possible in this kind of situation.
Sir, and to control the IOP, which are the agents we can use, the first preference for this?
You rightly said that you avoided beta blockers and
prostaglandins.
But you can also add systemic acetazolamide.
Okay.
Pritam, you want to add anything?
No, sir. I think Dr. Santosh has rightly put it. What we are dealing with is, I think, pseudophakic CME. And as we all know, when you look at a pseudophakic CME, I think you try to evaluate the etiology. Pseudophakic CME, you should, when you look at, you should look at it under 3 headings. Are there any predisposing factors preoperatively? Are there any intraoperative factors? And are there any postoperative factors which could cause the pseudophakic CME? Now, this looks like an intraoperative factor because you said your IOL is inferiorly decentered. So it looks like a tough cataract surgery where probably something has gone wrong, either a PCR, a PC-RED, the IOL is decentered. That could be the factor, etiopathological factor for the postoperative pseudophakic CME you're seeing. So you will have to treat the pseudophakic CME, in its algorithm, start with frequent topical steroids, control the IOP. If it doesn't, topical steroids don't work, you might have to go with periocular steroid injection or an intravitreal steroid injection. Again, you have to remember you have an IOP to control at the same time. So it will have to be a good balance between your anti-inflammatory and keeping the IOP under control. One has to remember that. And then eventually you might have to address the etiology here. If the IOL is decentered, probably do a UBM to see whether there is some haptic which is abutted against the inferior ciliary body, and study the peripheral haptic and probably deal with that. So this is how I would approach this case.
At the end, if
thank
Yes,
you,
sir,
Santosh. And Santosh, Santosh, you want to add something?
Last point. If
Yes.
your macular edema is still persisting beyond 3 months, you need to consider to address the primary cause like a decentered IOL or a disturbed vitreous. You need to consider surgery for that.
Yes. Thank you, sir.
True. And then I will now go to the next case. That is Susha is now going to present the case.
One more case, I suppose.
Sumit?
Amrita has one more case, I suppose. Amrita is
2 cases actually.
You can go ahead with one more case.
Okay.
She has a retina case, one more.
Okay. Amrita, go ahead with another case.
Yes, sir. I'm sharing the screen. So this is the third case is similar to the first one, sir. But here the patient is 60-year male patient with diminution of vision in the right eye since a month. History of cataract surgery with IOL, which was uneventful a month back. Patient is a known case of type 2 diabetes since 7 to 8 years on oral hyperglycemic agents. On post-op day 1, the vision was 660 with anterior segment quiet. Fundus was showing moderate NPDR with FR dull. And patient again was started on the post-cataract therapy of topical antibiotics and steroids. A month after a post-op, 1 month after post-op, there is no improvement of the vision, even with the refraction. Vision was still a 660 with anterior segment quiet. IOP was 14, and fundus was showing NPDR, FR moderate NPDR with FR dull, and fundus photo and OCT macula was showing moderate NPDR. And this time the macular edema was higher, around 860 microns, and with cystoid spaces and hard exudates. So my question is, considering the patient is diabetic, but it is a 1 month post-op, so should we consider this as a pseudophakic CME or treat it as a DME?
Okay, Santosh?
This is definitely a case of DME, as because the macular edema has drastically increased with multiple cystoid spaces, and the fundus shows all the features of diabetic retinopathy, including hard exudates, soft exudates, and retinal hemorrhages. So you should deal with this case as DME. Then again, I'll emphasize on the systemic factors to be controlled, and followed by anti-VEGF, or directly you can go for Ozurdex or depot steroid, which acts very well in this kind of pseudophakic cases.
Okay. So the first line will be first, we have to go with the anti-VEGF, and if it is not subsiding, then we go for the intravitreal steroids.
Either way, because this is pseudophakia, I have a paper on IGO where you can see that there is, you can use depot steroid as the first line of therapy also. As it is pseudophakic eye and no increase in pressure, that also can be considered as the first line of treatment. Depot steroid.
True. Yes, sir. Yes, Santosh. Yes,
Sir,
Santosh,
can
you are
I,
correct.
sir, can I please ask one question?
Yes, yes.
So my question is very simple. This patient was a known diabetic. So before we took her up for a cataract surgery, could we have also assessed her retina at that time, and could we have looked for the DME before? And if not, do we as a routine practice in all diabetics look at the macula before we go for a cataract surgery?
Ma'am, actually, this patient, the cataract was dense, so we actually could not have the clear view of the retina. And as OCT also, we could not have a proper signal strength to detect for that because of the opacity. Media opacity was very high.
What about other eye? What about other eye?
Yes.
Other eye is having moderate NPDR with.
So can you put the picture again, Amrita?
Yes.
Santosh sir, can I make a comment, or would you like to?
Yes, please.
You can make a point. Huh?
Yeah. I think Dr. Rita madam has banged the nail on the absolute central point here, that the pre-op assessment has to be very crisp. If we were looking at, if there was a NPDR in the other eye, then there should have been a high grade of suspicion that to expect post cataract surgery, a diabetic retina picture and a macular edema post cataract surgery here in this eye also. So this is important. So this essentially highlights the importance of preoperative fundus evaluation and a preoperative OCT if the media is clear in all these patients, so that you can explain to the patient, give a better prognosis. There are also options of injecting before doing the cataract surgery. You could give an intravitreal injection, control the DME, or have a better systemic control, bring the DME down, then do the cataract surgery under cover of perioperative steroids, and then handle the diabetic retinopathy post-operatively. So that would be a important take-home message here. And if you look at the picture here, as you can see, besides diabetic picture, if you see some of the blood vessels, the venous, there is a little venous tortuosity, a lot of hemorrhages, cotton wool spots. I would also keep a component of venous testis retinopathy. It's definitely a diabetic retinopathy, but I would also keep a component of venous testis retinopathy in the mind when I treat this, further on. Of course, the management of DME and would have its own algorithm. So, these were my comments.
Just 2 points.
So one question.
Go ahead.
Sir, actually, other eye was showing moderate NPDR, and this eye was having a media opacity. So pre-op, we could not assess the DME actually. So can we, considering the other eye having like moderate NPDR, like perioperatively, intraoperatively, can we consider IVTA injection at the end of the surgery?
Not IVTA, you can consider intravitreal anti-VEGF, but this was a swept source or a which type of OCT you had in your institute, which could not penetrate that much dense cataract? I just wanted to know.
So we have, essentially, we have serious OCT, sir.
Spectral domain, it's not swept source.
And you can definitely consider the intraoperative anti-VEGF along with cataract surgery. That is one point. And second, in this OCT, you can see multiple hyperreflective spots intraretinally, which are also indicative of role of inflammatory mediators. And steroid again is the indication for this kind of picture.
Yes, sir. Thank you, sir.
So thank you. So we'll go to the next case from Susha. Dr. Susha.
Very good afternoon to everyone. Sumit will be sharing the screen.
Yes, go ahead.
Yes. Sorry for that. Very thank you to BOA, MOS, Lahane sir, Ragini ma'am, Himalini ma'am
Dr. Sumit, Dr. Swapnesh for giving me this opportunity. So I would just start with a case for lack of time. I will also be presenting a squint case if time permits at the end of the session. So this case is about a 28-year-old female who came to us with severe headache, mild blurring of vision since a month. This blurring would be more in the morning and would settle throughout the day. Since the past 1 week, she has started having double vision associated with no visual loss of floaters or halos. But this double vision was constant. The images were horizontally separated and it was binocular. She was a computer user, being the IT profession, 7 to 8 hours a day. She had no history of any major systemic illness, nor COVID infection or COVID vaccination taken. No regular or long-term medications were on. On examination, she was a moderately obese lady with pigmentation around her neck. Next. Her vision in both eyes with the Snellen's chart, she was reading 6/9 parts with a little difficulty. Her contrast and color vision were normal, though the pupils were ill-sustained. There was no frank RAPD. On cover test, she had a 10 prism diopter right esotropia with abduction limitation in the right eye. The rest of the extraocular movements were fine. On slit lamp examination, the anterior segment was quiet. The fundus picture was this. So she had bilateral disc edema. Next. We went ahead and did a perimetry, and this is what we see. So on seeing the bilateral disc edema, our thought was on what do we do next. So we'll have a discussion at the end about this. So in the perimetry, we see enlarged blind spots. So the next investigation that we go ahead and do is an MRI. So at the end, we will also be discussing on what kind of investigation to order when we see cases with disc edemas. So an MRI with MR venogram showed the attenuation of both lateral ventricles, a partially empty sella, and prominence of bilateral optic nerve sheath. The MR venogram showed that the transverse sinus and the right sigmoid sinus was attenuated, and so it was suspicious for a raised intracranial hypertension. Next. So my points for discussion with the panel is what is the importance of perimetry? When do we neuroimage? And if we do neuroimage, what should be our guideline as to when to do an MRI versus with contrast versus venogram or angiogram? And what or how would we manage this patient? Thank you.
You can stop sharing the screen and we can go to Hemalini. Hema.
Thank you, sir, for giving me this opportunity. Susha, it's a very, very simple and straightforward case here, and I'd just like to, bring some points of observation. The first thing is that one of the slides you showed the look of the lady and that black pigmentation which was there around the neck. This is classical of insulin resistance. So she was moderately obese. She was probably insulin resistant and probably even a pre-diabetic. So that gave you an important clue. The fact that she had a lateral rectus palsy, and along with the lateral rectus palsy, she had a disc edema, that meant that the lateral rectus palsy in this case was a false localizing sign. And the disc edema was secondary to a raised intracranial pressure, because only when you have raised intracranial pressure will you get a false localizing sign, which is the lateral rectus palsy. So maybe in this case, if you didn't even do the perimetry, you had a diagnosis in front of you that this lady had and raised intracranial pressure, and one needs to investigate that what has caused the intracranial pressure to increase. But I would always say that all the cases, wherever possible, perimetry must be done because it narrows down your causes. The next thing, you went ahead and did the MRI, which is what I would have done as well. And if your MRI comes normal, this is the message that needs that I would like to emphasize on, that if your MRI in a setting of a bilateral disc edema comes normal, don't stop there. Go ahead and do an MRI venogram. Why do you want to do an MRI venogram? Because you want to rule out a venous sinus thrombosis. Trust me, a lot of women are on oral contraceptive pills, a lot of drugs. So venous thrombosis is not an uncommon diagnosis in this age group. Once you've done your MRI venogram and your sinus venous thrombosis is ruled out, then you know that the raised intracranial pressure is caused by probably the increased CSF pressure. So you have to do a lumbar tap. And when you're doing the lumbar tap, you have to make sure that you inform the anesthetist or the physician performing it that please record the opening pressure. Once your opening pressure is high, you know that your diagnosis was benign intracranial hypertension. Management is very straightforward. Emphasis is on weight loss. That is the first goal of the treatment. Second thing is lower the CSF pressure by giving Dimox. Role of steroids is controversial and not to be used in most cases. If your BIH persists in spite of medical treatment, you go on to the surgical treatment where you pass on the case to the neurosurgeon, who decides between a shunt and a fenestration. Most of the times a shunt works well. Fenestration itself, the procedure itself has problems. So again, controversial.
Thank you. Thank you, Hema. Gopal, Santan Gopal.
Can I make a point? She probably has polycystic ovary disease. Gynecological opinion, because it's very common to see that kind of picture she has, and also the bilateral disc edema in these polycystic ovary disease women. Age group is right, her stature is right, hyperpigmentation is there. All these things point to probably a PCOD as the cause of the raise in intracranial pressure, which is also a part of the polycystic ovary disease feature.
Yes, sir.
Thank you, Santan, and thank you, Hema. Manish, you want to add anything for the perimetry?
No, so the perimetry, there is always a doubt amongst the people's mind whether in a neurological case you need to do, like in this case, they have done a CETA, but there are a lot of people who believe that we need to do peripheral fields. But however, in this case, since your differential diagnosis is all can be ruled out with the central field, so I think she has done the right thing of doing only a CETA. But I always get references where people want peripheral fields. It's not really necessary to do a 120 point or something like that.
Okay. Thank you. So I think, thank you, Susha. We will go for the next case. That is by Preeti Kamdar. Preeti?
I'll share my screen, sir.
Yes, yes.
Good morning, everybody. And
Good morning, Preeti.
And I again thank BOA and Lane sir and Ragini for this opportunity. One moment, sir. Let me. Why is it not showing? Yeah.
Okay. Yes, yes, we can see. Now so go in the slideshow.
Yes, sir. Yes, sir. So,
yes, go ahead.
What do I do? Come to glaucoma. Now, this is a person who consulted me. He's a 29-year-old male patient who consulted me on 2nd of March 2020, that is just before lockdown last year. And from his records, this is what I have summarized. He was diagnosed to suffer from glaucoma in both eyes in 2018, and it was uncontrolled, and so he underwent left eye trabeculectomy with mitomycin C on 21st February 2019. So about a year before he came to me. And again, the post-op, the records show that the AC was very shallow with central AC formed only, and post-operative, the left eye IOP, the IOP which underwent cataract surgery, the glaucoma surgery, was always between 0 and 8. He underwent several AC reformations, UBM was done, and then with all this he was diagnosed to have malignant glaucoma, and 5 months after he underwent trabeculectomy, he underwent vitrectomy with AC reformation as a treatment for malignant glaucoma. Now, what the patient's complaint was that his vision decreased after trabeculectomy and kept on further decreasing after vitrectomy. It dropped still more. Right eye was 20/400. This is before trabeculectomy, before he was touched also. So, left eye was 6/12. That means he was operated for the better eye first. Now, this is what the records say, and this is also perimetry which was done in the course of his multiple opinions. In 1 year, he went for multiple opinions because he was in distress. So, you would say that both fields show very, very advanced defect in both the eyes. This is also, these are all his records. This is not done by me. This is before he came to me. This is an anterior segment OCT also which he underwent, and this is what when I saw him. So on 2nd of March when I saw him, vision in the right eye was 6/120 and the left eye which underwent trabeculectomy was PL-PR, good projection. The pressures in the right eye was 30, the left eye was 5, the right eye AC was shallow, left eye was very shallow. The lens in the right eye, this is the disc, and it showed a very early PSC, so was not really contributing to vision loss in the right eye. The left eye showed a mature cataract, and gonioscopy showed both eyes the angles were closed. So if I were to this is what the slit lamp picture was of the left eye, the eye in question which underwent trabeculectomy and vitrectomy. That there is a mature cataract, there are posterior synechia, and on this particular area there was extensive pigmentation. I could not see a definite bleb, there was no definite bleb, just a few cysts, and the B scan which I did showed an attached retina. So current status, if I were to summarize, that both eyes showed PACD, right eye uncontrolled with very advanced glaucomatous damage and poor vision, and left eye it is a mature cataract. There is a query functioning bleb, I am not sure, and is it querium aqueous misdirection. So now my question to the panelists is that how would you take this further?
I think Preeti, this is the scenario that we always come across when we are treating the patient.
Yes,
so I see this such type of scenario we'll have to really solve this, and I will ask Rita first. Rita ma'am.
Yes, sir. Good morning. Thank you for having me on this panel, sir. So there are multiple questions actually that come to your mind when you see a patient like this.
You can stop sharing now. Preeti.
I can? All right.
Did the patient to start with have an angle closure in the left eye as well? And if the patient's vision continued to stay so low, and if the patient had a very low pressure to start with, we need to think of why did the patient have a shallow anterior chamber with a low pressure to start with. Ideally, if you talk about an aqueous misdirection, you get a shallow anterior chamber post the surgery, normally with a high pressure. You don't have a low pressure normally. Though I can't say that if there is a low pressure, you can rule out aqueous misdirection completely. But more often than not, you get a higher pressure. Now, the first thing to do when you get such a case is to at least atropinize the eye, try and see if you can pull back the lens and the iris diaphragm, and try and see if you can form the anterior chamber. Now, having looked at this, this scenario, this patient has actually gone through everything that one needs to do for an aqueous misdirection, failing which the anterior chamber still is not formed. So which clearly goes to say that it was probably not an aqueous misdirection at all to start with. So it probably had been, we have to look for other causes of the shallow anterior chamber. So what is the commonest cause of a shallow anterior chamber post-trap? Is a overfiltering bleb or a leaking bleb. Now, sometimes it can so happen that the overfiltering bleb can be easily sort of located on a slit lamp examination, but a leaking bleb need not necessarily leak only from the inadequate closure of the conjunctiva, but there can be a leak inside which may not be easily visible. So I would think that it would be worth trying to do a forced serials to see if you can get excess aqueous leaking out of the wound to rule out leaking bleb, to see why the pressure was so low. And of course, we had to look for choroidals because that would have been another thing. I think the very fact that the vision continued to remain so low was, even to start with, was probably that there was already some amount of maculous hypotony macula, which was causing the vision to remain so low. Secondly, there must definitely have been a lens cornea touch which led to the hastening of the cataract formation. And we are seeing now that that lens is completely cataractous. So I would like to sort of highlight this point, that when you have a shallow anterior chamber post-trap, you have to think about what is the reason for the shallow anterior chamber. It's a pretty common finding, but you need to tackle this more correctly. Manish, would you like to add something?
Manish?
Yes, yes. Just adding to what Rita has said, I'm just picking up where she has left off. So as she said that the diagnosis of aqueous misdirection is not, we don't know whether it is right or wrong. However, if at the time the surgeon who did it had ruled out the leakage and was sort of seeing a suspicious aqueous misdirection in a phakic patient, if you are going to go and do a surgery for aqueous misdirection, I would prefer to do a cataract surgery as well. Because moment you do the vitrectomy, if the lens moves back, you can go ahead and remove the cataract as well. So if you don't remove the cataract, even just vitrectomy itself is going to push the patient into a cataract advancement. He already has early cataract even in the right eye. So I suppose he had some cataract in the left as well. And the vitrectomy pushed it. And besides, the lens touch also could have pushed, as Rita said. Now that is the past. Now coming to the position today, with a shallow chamber, but as Preeti has pointed out, it is not just now there is no lens touch. So as Rita pointed, at this point, I would put on steroids and atropine, and B-scan has already shown that there is no choroidals at present.
Yes.
So put on steroids and atropine, and if the pressure builds up a little bit, we can go ahead and do a cataract surgery in that eye. But the more important is the right eye today. Because
can
right
I go
eye,
ahead? I have put certain things like what I did 1 year. Can I? Yeah.
Yes, go ahead.
Yes, sir. Yeah, so this is what it was. And so as Manish has said that left eye cataract surgery, yes, under extremely guarded prognosis. And this was my, that if it was a aqueous misdirection, and in 1 year he was on atropine, he was on steroids, the surgeon had started everything that was to be, that should have been started. So this is what my dilemma was. So, and right eye, yes, trabeculectomy with risk of malignant glaucoma or wipeout. If it was indeed aqueous misdirection, then right eye also needs to be sort of looked into it. So, I will now stop sharing my screen, and then you can just go ahead with the discussion.
Yes, Manish?
so right eye needs to be taken care of also, because 30 pressure with all the treatment is not what we would like the patient to remain. So probably at this point in time, take the consent and do a trabeculectomy in the right eye, or if the cataract is a little more, do a combined surgery. That will be a little better, because at least you won't get the shallowing if it is because of the lens. Sometimes I prefer to measure the anterior chamber and the lens thickness on, even you get it on your lens star biometry also, or you can do a UBM and get the lens vault. And if the lens is big and it is vaulting in anteriorly, I would prefer to do the cataract surgery as well in that eye. And considering, I don't know, Preeti has not mentioned whether an iridotomy was done before or not. But maybe in this case where one eye is suspected, so we would like to see if an iridotomy can be put in place before we do anything for the right eye. So that would be the approach for the right eye. Coming to the left eye, I already mentioned, put on atropine and steroids and watch for some time. If pressure builds up to 8 also, I am happy to go ahead and do a cataract surgery in the left eye and see what happens. Because till we get a detailed picture of the retina and the optic nerve, we don't know what is the vision prognosis of the left eye now.
Okay. So, this is, I did a cataract surgery because the patient in the better eye, he had lost vision. And what I did is, when I operated for left eye cataract, I had to put a trypan blue. I don't, the blue to stain the capsule, and I don't have those photographs. But the moment I stained the capsule, it leaked, and this entire area was stained with it. So, with this, I thought that maybe this is not aqueous misdirection, it was overfiltration. And but now this is 1 year post-op, so maybe the bleb has flattened down, but this was overfiltration was what my diagnosis was. And hence, he improved to 6/12 N6 in the left eye. The right eye, this is 1 year because lockdown happened, he was from out of town. So he came to me 1 year later, pressure was 27, left eye pressure built up to 10, which was good. And so I realized it was an aqueous misdirection. So now I went ahead with the trabeculectomy in the right eye. And the first post-op day, AC was well formed. It started shallowing and became completely flat on the third and the post-op day, and IOP was low. So I started rethinking that maybe it was aqueous misdirection, I was mistaken, and now right eye is also going the same way. So I stepped up cycloplegics and steroids, and I kept on reform till atropine works. I said let me reform the AC with air, but AC kept on shallowing. And what one day when I was, this is how, the peripheral, no matter what I did, peripheral AC flat. So third attempt I noticed air was escaping from I had made the eye very tight with the air bubble, and that is when, you can't see the bubbles here, but I saw bubbles escaping from the edge of the conjunctiva. And so it was a bleb leak, and that is what Rita has been
We
harping
cannot
that.
hear you, ma'am.
Oh. You cannot?
Iti, ma'am, we cannot hear you.
Oh, I'm sorry. I'll just go back.
So Sumit, we can hear, madam.
Oh, okay.
I think the Manish.
Can you hear me?
Yes, we can hear you.
Yes, we can hear you.
Okay. And so that's why just one thing I wanted to show, that do a Seedles for every, Rita has already sort of spoken on it, harped on it, but look a little carefully, wait for some time, immediately in a second you will not see, but you will see that there was a leak here. So this is what I thought was a take home from this case. See, now you can see the leakage. So it does not start immediately. Wait for some time, and this was the mistake which I had made for this particular case, that I did not do a Seedles because it didn't look, that did not seem to be a bleb leak. It seemed to be proper. So my inferences now are that left eye was overfiltration and the right eye, what happened was a bleb leak. And my takeaway is that aqueous misdirection is not very common, but it's a dreaded complication. So that's the first thing we think of. When it occurs with low IOP, always rule out other causes. Overfiltration can occur without a huge bleb, and always do a Seedles. That's what I have learnt from this case. So I'll stop my screen share, and I will just go back to the
Thank you,
Dr. Lani, sir.
thank you.
One more comment I would like to add, sir, that when you have a shallow anterior chamber, instead of using air, which can get absorbed very quickly, there are two things you can do. You can either use a heavy viscoelastic, which might take like 3 or 4 or 5 days to get absorbed, or you can use C3F8 because that stays for a little longer time and the pressure also builds up a little bit. So the anterior chamber, if it's just happening out of a simple thing, cause then the anterior chamber can form very easily.
Thank you, Anita madam. And I will go to the next speaker, Sachin. Dr. Sachin Dharwarkar. Go ahead.
Yes, sir. I just share my screen.
Yes, Sachin.
Is the screen?
We can see.
Okay, at the outset, I would thank Larnesh sir, Ragini madam, Manish sir, and Pritam sir for the opportunity. So the case is similar to what the case Amruta had shown, but with a slightly different background. So this is a 56-year-old male who presented. He had no systemic comorbidity. This cataract surgery was done with IOL implantation in 2015. You can see the picture on the right side. This was a single piece hydrophobic accuracy of IOL in the sulcus, which was decentered. He had a similar but uneventful surgery in the right eye. Left eye later on developed rhegmatogenous retinal detachment in 2016, which was followed by endolaser belt buckle, C3F8 and cryo. And since then, the retina had been on. Now, the problem was he started developing intermittent high intraocular pressure blurred vision to hand movements. 3 to 4 episodes in 4 years, and at every episode, his vision would go down to hand movements. He would develop media haze and pressures would shoot up to 40 or 50. He would settle down with oral acetazolamide and conservative treatment with beta blocker brimonidine combination. And there would be 20 days per episode. So every time he used to be treated with this cocktail, after 20 days, he used to come back to normal. Vision would return to 6/9 and IOP would return to baseline. Now, the last episode episode occurred in October 2020 before we intervened. The vision was again hand movements. The intraocular pressure was 34. This was the time he presented to me. On examination, there were flares 3+, cells 3+, decentered, single piece hydrophobic iolin sulcus, vitreous hemorrhage. Media haze was grade 3. Disc was hazily seen. Cup disc ratio, left eye approximately 0.6 through the haze, and the other eye was 0.4 with a healthy rim. So we had a case here with pseudophakia with IOL in the single piece hydrophobic IOL in sulcus, status post vitrectomy with RD surgery with recurrent vitreous hemorrhage and high IOP with a disc suspect in the left eye. So the question was how to approach this case. So first, obviously, since previously investigation, he was not very well investigated. So we had gone in for the radiological investigations. Although we could see clinically what was wrong, but for documentation sake, we needed to do a UBM to document the possible cause of the recurrent vitreous hemorrhage and the blood in the anterior chamber, and a B scan to a UBM again to see the port areas, to whether he has developed any port proliferation. So with our retinal colleagues, they also wanted to rule out neovascularization at the ports. So we're suspecting a UGH majorly, and another differential was port bleeds. And the management, definitely we were considering, because of his repeated vitreous hemorrhages, we thought of IOL explant with secondary IOL in same sitting versus IOL explant with IOL in the second sitting, considering his inflamed condition of the eye and recurrent trauma. So my question to the experts is, what is the right way to proceed, and is there anything extra that needs to be done in such cases? Thank you.
I think Sachin, it's a beautiful case. So now I will request the because here we require, because the eye is pseudophakic, vitrectomized eye, and after that he has RD, and then he has got the glaucoma. So I think all the diseases are together, and so now how to approach in such situation? It will be a job of so many doctors, and normally the people who are can expert. So I will go from retina. I will ask Santosh, what is your take on this?
Only one thing I would add, that the pupil was never bigger than this size. That is the only other clinical detail. That's all.
Okay, Sachin. Santosh, what is your take of the retina side?
So he is telling retina was on throughout.
Yes.
So
retina is stable.
Yeah, nothing to be done from retina.
Okay. then I will go to Pritam. Yes, Pritam.
So, Dr. Sachin, there was no band, right? It is just.
Sorry? No, sir. Encircling band was there.
Encircling band was there.
Yeah.
Okay. No, so like you said, you did mention that one suspicion was there could be what is called as AHFVP, or anterior hyaloid fibrovascular proliferation.
Yes.
Now, this happens essentially at the sclerotomy sites, because nowadays we use sutureless vitrectomy. So it's not sutured. So essentially the way the port gets shut is by actually vitreous plugging into the port from inside. So you have a vitreous incarceration, which causes a granulation tissue, and that can proliferate, into anterior hyaloid proliferation and can bleed. So after, and UBM shows it pretty nicely. So if UBM shows that anterior hyaloid fibrovascular proliferation, then you can easily cryo that site. The treatment algorithm for AHFVP is to cryo the site, to give maybe anti-VEGFs to reduce the vitreous hemorrhage, probably do a vitreous lavage and cure it. So that would be the approach if there is anterior hyaloid fibrovascular proliferation. The other thing is to look for any retinal pathology coexisting with the status post RD. The RD is okay, it's cured. But if there has been maybe some kind of a retinal vein occlusion, in the interim period post the RD settling, that could have caused a vitreous hemorrhage. So rule out a retinal pathology. So that would be the from the retina side.
Okay, Manish or Rita.
So also I would like to ask Sachin, that there are two possibilities besides what Pritam has said. One is the UGH, where the inflammation is being caused by the lens rubbing on the iris, and that UBM you just showed while Pritam was talking, you had put on the screen, that looked very classical. But however, we also have to think of one little other possibility, which is less likely in this case, but it is still to be put on the table, and that is an infective pathology. So you have patients where you have a little infection, which we put steroids, antibiotics, it quietens down and keeps coming back. So I would like to ask Preetam and Santosh whether you would at the same time take a biopsy of the vitreous or just a tap and try to see a culture or something like that.
No, so when he mentioned about those cells, in one of your findings, you had 3+ cells and flare.
Yeah.
So you have to keep in mind probably some kind of an indolent infection, either probably a P. acne or even fungal infection, because a fungal endophthalmitis are known to cause raised intraocular pressure also. So I'll definitely keep that in the back of my mind. Thank you.
Basically, RBCs from the hemorrhage, massive hemorrhage every time, vitreous hemorrhage. So that was coming through because vitrectomized eye, it was just pouring into the anterior sheath.
No, but that was later, right? Before with him
No,
also you have...
four episodes of vitreous hemorrhage in 1 year. Sorry, in 4 years.
Yeah. Dr. Santosh, your comments on infective?
Definitely, what you told is that two things we have to definitely keep in mind. One is there must be something which is bleeding repeatedly. So a neovascular front somewhere, either in the ports or behind the ischemic retina, and it is bleeding repeatedly. Second, as pointed out, that we can always consider a vitreous biopsy if there is vitreous cells and repeated flares also are occurring. So rule out retinal ischemia, rule out any possibility of retinal neovascularization or anterior proliferation, and also infective etiology by doing a vitreous biopsy.
So we did all the workup exactly as told by Pritam sir and everybody, that we did the UBM. There was no port proliferation. Fundus was absolutely pristine. However, I could not recover the fundus photo from the hard drive yesterday. There was no problem at all. So then we discussed with the patient and we went ahead with an IOL explant. Now the question was whether to go in with an explant and a secondary implant in the same sitting, or we should wait for some time for the eye to become quiet, because I was pretty inflamed for so many times. So after discussing with the patient and the risk benefit ratio, we went ahead with the IOL explantation, which was basically just a 5-minute job. And then we waited for around 3 to 4 months to make sure that the pathological process is not repeated. So it did not repeat for 4.5, 5 months. The vision with aphakic glasses was 6/12. The pressures remained around 10 without any medications. There was no recurrence of any hemorrhage, and then we went in and did an iris claw implantation in his case, because iris was that way very healthy. And now the patient is maintaining 6-9 parts. So another question was, would there be any chance anyone would do both the things in the same sitting in this case, or it is advisable the way we did it?
No.
So Sachin, first and foremost, I think, did you look for neovascularization in the angle at the first?
Yes.
And you saw that there was a neovascularization in the angle, or no?
No, nothing. No NVs anywhere. It was just a UGH, classical. Because of a vitrectomized eye, he was getting the vitreous hemorrhages, and that blood was again also coming in. And so that's why it was the strange part about this case was the hemorrhages which were coming in every year and in such a massive quantity, and he would reverse back to absolute normal, like 6/9 and IOP of 13. So reversibility was there, and that's why we went ahead with the IOL explant. There was no other cause of NV that was noted.
Now, when you did the IOL explant, did you find there was a defect in the posterior chamber, and therefore you're thinking that should you go ahead and wait and then put in a secondary implant? And having said so, you put in an iris claw implant, you didn't go in and put in another implant in the back, because UGH is not so common presently when we are doing posterior chamber implants in the back. This was a pretty common occurrence when we were using anterior chamber implants, and it is also probably a one-piece posterior implant that was put in the sulcus, which is actually the wrong thing to do.
Yes.
So was there a PC defect?
Yeah, it was a PC rent, and there was a single-piece hydrophobic Alcon lens that was put in the sulcus that was decentered, as shown in the photograph that was attached to the first slide. So this was, and these haptics of, or the optics of the Alcon IQ, especially the material, extremely abrasive. Even if you touch them, they are like tacky as compared to the other IOLs, and they can cause absolute chafing of the iris. And that was causing vitreous hemorrhage, which was very, very, very profound.
Yeah, so I agree that probably it was the lens that was causing all your problems. And because there was a PC rent, and maybe that surgeon at that point in time was not confident enough of, changing the lens, using a 3-piece lens, and again going in and putting a lens in the bag. I mean, now that's not such a major problem at all.
Right.
So maybe at that point in time, if he had been bold enough and not insisted on using the same lens in the sulcus, the problem may not have arisen.
Absolutely,
And
that was the take-home message actually.
yeah. And maybe you could have also done an in the bag implantation, or
Sorry, sorry, madam.
You could also make but now that you are a vitrectomized
No, there
guy,
was no bag, madam. There was no bag.
Okay, yeah, I guess.
Thank you. Yes, Santosh.
You could have considered scleral fixated IOL instead of
another option.
Yeah, that was another option, but that's why I mentioned at the beginning that because the pupils were never more dilated, I don't know whether the initial vitrectomy was done with complete base dissection or not. So I didn't want to tamper with the vitreous base again, put things and then swivel it inside, and something else would happen to the retina. So I discussed with the patient. He said, go with the easier option fast. And he was basically a patient with claustrophobia. So he wanted a fast response. Jaldi karna chahiye.
Okay.
That was also, and it went off very smoothly, like 10 minutes implantation, and touchwood is doing well till now. And he had a good iris. If he didn't have a good iris, then obviously we would have.
Very good. I think what Sachin said is very true. Multiple things were there. And so I request now Sumit to present a case of oculoplastic. Because our time is now this one. Yes, Sumit, yes.
Good afternoon, everyone. So I will be going with the two cases quickly. So this is case number 1. A 60-year-old male present with the redness and pain since 4 to 5 months. He is on topical steroids on and off since 6 months, which reduce the redness, but the pain is persistent. Now, when we see him on the slit lamp, this is the picture. You can see very well that's a thinned out sclera and the conjunctiva, and also there is thinning of the cornea with superficial vascularization. Patient was diagnosed elsewhere as a necrotizing scleritis and had workup for systemic and autoimmune blood workup, which was negative for ANA, dsDNA, ANCA, and RA was also negative. Now, what do you do in such a scenario? Then it's a very simple test that we did in our OPD. This is just for everyone, that once you see such a case, ocular surface, you always stain. And once we stain, we found there is a staining with the rose bengal. And it becomes a very clear-cut diagnosis that what we are dealing with is OSSN. And we also did a ASOCT, which shows there is a hyper-reflective zone, and the anterior 1/3 of the sclera is involved in this. Now, there's this masquerade that happens. I wanted to show this, and now over to the experts for how to treat this lesion. Do steroid mask obvious presentation of the ocular surface lesions, and what could be other masquerades of the OSSM that generally comes to our OPD and we misdiagnose either as pterygium or anything.
Dr. Santosh Sonawar sir has joined. My request, Dr. Santosh. Santosh, welcome. And Santosh, thank you very much for helping us in the BOA. Thank you very much, Santosh. Thank you. Yes, Santosh, your advice.
Keep the picture on so that people understand. I think it is a nice case where ocular surface chemistry neoplasia is masquerading as scleritis. If you look at this picture clearly, there is some element of inflammation. At the same time, what is very remarkable is abnormal vascularity. There is so much of abnormal vascularity here and corneal thinning as well. So this can even masquerade as peripheral ulcerative keratitis. It can, if the scleral element was not present and if just the thinning was present, abnormal vascularity of this sort and some panesthesia, it can masquerade as peripheral ulcerative keratitis. So in a patient who has scleral invasion already and corneal stromal invasion already, one straightforward option is extended enucleation. But if you want to salvage the eye, that is possible with excision and plaque brachytherapy locally.
Okay. There is always a chance of corneal melting in the thinned out cornea, but explaining that we can go ahead with the plaque brachytherapy, correct, sir? So this is a case number 2, which is more common. A 10-year female brought by parents with the history of trauma 2 years back, and the right eye was normal, left eye was anterior cephaloma, PL negative vision, and the history was patient lost the vision post-trauma, and they wanted a cosmetic correction. Now we wanted a cosmetic correction, and we did a workup doing a B scan, which showed a organized vitreous hemorrhage and a disorganized eyeball here. And we planned patient for the evisceration. Now, when patient was planned for evisceration under general anesthesia, After removing the cornea, we noticed that there is intraoperative excess of vascularization and with the firm consistency mass, which was not easily separable from the sclera, as we do in a evisceration step. And it was suspected as a mass intraocularly. I don't have a picture for that, sorry. And then at this point in time, when patient is under anesthesia, let it be local or general, and your plan for evisceration and your workup has shown there is nothing else inside except for the staphylomas. What do you do at this stage? Do you abandon the surgery? You continue with the ongoing plan, whatever you had planned, or you shift to the enucleation?
I think, Sumit, both the options are good. Continuing with ongoing evisceration is fine, but at the same time, we should not violate the conjunctiva. If you've already done peritomy, then there is a problem because then there is seeding of the tumor, if at all it is present. If you have a facility for frozen section, you can immediately send a sample and wait for the frozen section reports, which may come in about 15 minutes. Then if it's non-malignant, you can proceed with evisceration as planned. If it turns out to be a malignant tumor, then best is to convert to enucleation.
Okay. So I will tell you, sir, what we did is with the consent from the patients and parents, enucleation was performed instead of evisceration. And it was turned out to be teratoid medulloepithelioma. And sorry. And in this case, we had to change the plan. But my question here is for everyone that once you know that this kind of a painful blind eye comes to you, and we do a workup of imaging, and this is little dicey to understand that there is any mass or not. Should we be prepared to shift to the enucleation on table, or we should, whenever in doubt, should we go ahead directly with the enucleation and don't plan evisceration at all?
Well, Sumit, one thing that could have been done is anterior imaging. Not, of course, OCT, but maybe a UBM or a immersion B scan that would have helped you detect a ciliary body tumor much easier than a routine B scan. You can see on the CT scan that the anterior part of the eye is quite, image intensive. See that it is very irregular, but you can't rule out a tumor with this kind of a CT scan. So that is one. Second is extremes of age. Children and very elderly individuals, if there is a painful blind eye of unexplained etiology, then I would really view that with suspicion. In young adults, 30, 40, 50, generally, you don't take tumors as a major consideration, but in children and elderly individuals. So in a situation where there is doubt, even if it's minimal, you would want to do enucleation because cosmesis is equal. It's just the mental satisfaction to the patient that the whole eye is not removed that makes us do evisceration more often than the enucleation. But final cosmesis, you realize, is the same, Sumit, isn't it? With myoconjunctival enucleation.
So then there is one more question. Like as a surgeon, when we plan a evisceration, and it has been taught to us in ages that there is always chance of sympathetic ophthalmitis, but we know that there are tumors also hit, and in some cases. So what is what should be more worried of? Because as per the literature, the evisceration is the numbers of the evisceration increasing much more than the enucleation because of the ease of surgery compared to enucleation.
The sympathetic ophthalmia is a theoretical risk. Just a couple of cases have been reported, but when you do evisceration with care, that is, when you make sure that the entire uveal tissue is removed and whatever little is left, generally what is left is around the optic disc, wherever there are perforating vessels and nerves, some amount of uveal tissue will be removed, or if there is a chorioretinal scar because of prior retinal procedures, uvea may remain. In that case, you have to denature that residual microscopically obvious uvea with alcohol. Alcohol denaturation actually supposed to prevent the onset of sympathetic ophthalmia.
Okay, so there is no problem going ahead with the evisceration. Just be careful that you do a proper imaging and proper workup, that you rule out that there is no intraocular mass that you are neglecting. The sympathetic ophthalmitis remains a theoretical risk, but hidden intraocular tumor in such a cases like sir said, extremes of age is a real risk in such cases. Thank you, sir.
Nice cases.
I think thank you very much, Santosh.
Thank you, sir.
Both Santosh, I think Santosh Mahapatra sir and Santosh Sonawar, I think the such type of people definitely, I think they are giving very good knowledge, teaching the student, and I appreciate both of you. See, we are there to support the new generation. Thank you very much. Thank you, Rita ma'am. Thank you very much, Rita ma'am, for sparing the time. Thank you, Santan Gopal. You can just stop sharing, Sumit, so that we can. I will see the Santana and everybody. So Santan, thank you very much, Santan Gopal. Then the Nikhil, our own Nikhil. I think the Manish. Then Hemalini, Ragini has unable to join. Kuresh has joined. So thank you, Kuresh. So all and those who have presented, I think the presentations were superb, and they have managed very properly. See what happens. This session I have started just to have a general knowledge and general consensus. Whenever you are there, then what to do, and this what to do. He is always guiding the people. And thank you very much, Pritam, for joining. I forgot your name. Otherwise, tomorrow, if there is any complication, he will not come to the my operation theater. So I should be very much. It means see the what happens. We have got separate theater because Pritam has got the theater of 3 crore, and my theater is only of 1 crore. So that is the difference. So he doesn't come from 3 crore because there the temperature is near about 12, and my temperature wood is 24. So he doesn't come there normally. So I should not forget. So thank you very much for all the presenters also. They have done very good presentations. And now I welcome the only one and the only one, that is a Karobi. That is the Karobi. And so those who are free and those can take the you can say the lunch slightly later. There is a now live concert, and that Karobi is going to present to you with Nikhil and Gitanjali, and I think Pranav. You must now hear the Pranav. Are baapre, kya, how much he is a very different kind of person, and I really salute her. अरे भाई, why you are ophthalmologist? उधर इसमें जाओ. You should go in cinema, and
Thank you,
I
sir.
think we all will get the money. Yaar, you go there. Such a nice, gentle person. See, so many artist people, and because of Karobi, they are coming forward. Really, I am very happy. Nishita, the Tanvi, all these people, and Nita. I think I must salute you, and all your brains. So many different brains in you. So now the stage is yours. Go ahead, please.
A very
And
good
Karobi
afternoon to you,
and
sir.
Nikhil.
Thank you, sir.
Yes.
Thank you so much, sir.
A very good
Thank
afternoon to you, sir. And my Nikhil is my partner in crime, and we've had a lot of encouragement from the BOA, especially from you and Ragini, and also from Pritam and Swapnesh, who have been at our side all the time. So we could make this thing together possible. So I hope everyone enjoys this. Sir, before you go off for your lunch, I would like to make the vote appeal for you. This is a sincere vote appeal which I'm putting forward to all the people who are now listening in, that Dr. T.P. Lahane is standing for Vice President All India this year. I sincerely hope and pray that you will come and vote in high numbers for him, because you will not get a better candidate or a more capable candidate than him. I will not say too much because we will in the evening tell you all his good qualities, but it's enough to say that he's the best choice for the Vice President.
Sure. Thank you, ma'am. As
Nikhil,
usual, you're echoing
Thank you,
everybody's
Karobi.
sentiments.
Karobi, thank you. Karobi is my sister, so I think she loves me too much. So I think you should go ahead, and we are there. We will hear you for, I think, enjoy this, and then we can go for the lunch, or I can have lunch here only.
Yes,
if
sir.
Ragini madam permits.
Yeah, Ragini will inform it. She is all ready. So can we start the program, Nikhil?
Yes, sir.
Yes, ma'am.
Go
Okay.
ahead.
Yes, sir. Welcome, sir, to this program. Welcome back to our final mini concert of the BOA MOS Summer Focus Virtual Symposium. So it's been an excellent month for all of us. Last 4 Sundays passed by in a flash, with all of us gainfully occupied doing what we do best and learning from our peers, our seniors, and the stalwarts in the field of ophthalmology. First of all, I extend heartiest congratulations to Team BOA and MOS for making this happen and for making it happen so beautifully, right from conceptualization to execution. It is all about the solid team and the leader of the team, Dr. Lane sir, Dr. Ragini ma'am, Preetham sir, Swapnesh. So a round of applause for all of them first. Now it is time to relax and rejuvenate with some music and some masti, because as they rightly believe, downtime is important for a fresh mind. So we start off today with a duet by Dr. Sachin and Dr. Nishita on Tere Bin. All the performances will be played from Madam's end, so we have a seamless execution.
Sachin and Nishita, they don't require any kind of introduction further, because they are the champions. They have won many laurels in the singing idols that they have been performing, and both of them have consented to do this number together for us. So let's go ahead and hear them. It can be heard, no? Yeah.
तुझ में है तेरी तस्वीर में नहीं, तस्वीर में नहीं।
Just a moment, just a moment.
जो बात
Just a moment. What has happened?
So while ma'am is searching this, I'd like to highlight that all the duet performances were shot separately and then merged together, and they have actually had sleepless nights putting it forward the way they want it to be presented. So with these talent things, the files are heavy, so there can be some technical lag, which please excuse us for that. But each and every performance is brilliant and one better than the other. They had performed at the last mini concert also, and they were very well received. So they are back now with a very nice duet of Tere Bin.
I don't know why this overlap is coming. And this is not even one of the songs which is in the program.
Would you like me to try from here?
Just one moment, one last try.
Okay.
I don't know from where that is playing.
Okay, no problem.
No. I think this.
Okay, I think
you play it from your end.
Okay, I'll play it from here. Just a second. Just a second.
I'll stop sharing. Anyway, it's a nice song. Enjoy it.
Yeah, ma'am, you'll have to stop screen share.
I'll
and
come
I
back.
Okay, I'm going to share my screen.
Sorry for
the
goof up.
Should I share it? Yeah, okay, I'm sharing it now.
Yeah.
Just tell me if you can hear it. Can we see it? Can we hear it?
We can see it.
Yes. We can hear it?
No, there's no this audio still.
Okay, just one second. Now, is there audio?
No, there's no audio.
No audio still.
Okay, one sec. Okay, just give me a second. Now?
तेरे तेरे बिना मरना नहीं, जीना नहीं तेरे बिन।
तेरे बिन, तेरे बिन, तेरे बिन, तेरे बिन, तेरे बिना मरना नहीं, जीना नहीं तेरे बिन।
तेरे बिन, तेरे बिन। बावरे पिया लागे ना जिया, देखो मेरा मन जलता दिया।
जलता दिया मुझे ना पिया, मुझे ना पिया, जलता दिया।
तेरे बिना मरना नहीं, जीना नहीं तेरे बिन। तेरे बिन, तेरे बिन।
बावरी पिया लागे ना जिया, देखो मेरा मन जलता दिया।
जलता दिया बुझे ना पिया, बुझे ना पिया, जलता दिया।
तेरे बिना मरना नहीं, जीना नहीं तेरे बिन।
तेरे बिन, तेरे बिन, तेरे बिन, तेरे बिन। तेरे बिना मरना नहीं, जीना नहीं तेरे बिन। तेरे बिन, तेरे बिन।
So that was really, really amazing. Ma'am, please unmute yourself.
That was indeed so beautifully sung. Thank you so much, Sachin and Nishita, for the wonderful rendition. Beautiful song. And without much ado, we go ahead to Gitanjali Sharma. Gitanjali Sharma, welcome to the show. You are performing for us for the first time. And what we have here is a Kathak dance by her.
There's some disturbance, no, ma'am?
She's doing a Kathak dance, and apart from being the president of the Pune Ophthalmic Society and now the joint secretary of the MOS, she writes stories also. So let's go over and see Gitanjali in action.
Good afternoon, ma'am. Nikhil.
Hello, ma'am.
Good
Hello, ma'am.
afternoon. Nice to see you.
So about Dr. Gitanjali Sharma, I would like to say that She's going to perform a classical dance on Pia Bavri. And if we look very carefully, she speaks with her eyes, with her beautiful expressions and the way she holds her hands and does the mudras. It's really mesmerizing. So we're over to her now. Brilliant. That was really amazing.
Really amazing.
I'll just stop it just a second. Yeah.
I think Gitanjali, when she's on the dais and you just say ta ta ta,
Thank you.
she'll start
Thank
dancing
you.
over there also.
Thank you, ma'am. Thank
Very,
you.
very nice.
On
Was so
behalf for
beautiful,
inviting me.
and she's a wonderful poet too.
I know,
Thank
and you
you.
write stories also. So really nice. I mean, we enjoyed your performance, Gitanjali. And
Thanks.
now we move over to our loafer from Pune, who's going to whistle to us.
So, ma'am, you know what, Dr.
Sandesh Doshi.
So Dr. Sandesh Doshi is very multi-talented and he knows everybody is going through so much of tension and stress now. He has a simple motto, by hod guma, CT vaja or CT vaja ke bol, all is well. So he's going to whistle for us. Here he comes.
Gitanjali, it was too good.
Thank you.
That was great, Sandesh. What lungs you have, man.
It was a full CT Mar performance.
Thank
I
you.
know. COVID also will get scared to come close to him.
प्रणव एक तो सीटी बजाना चाहिए सर के लिए.
I
प्रणव, you know
know.
how to?
Wow, that was too good. That
Ragini.
was too good. That was superb. और सीटी बजाने के लिए लाने सर को बुलाना चाहिए. मैं शाम को बुलाती हूँ सर के लिए.
शाम को,
नहीं
शाम
अभी
को
सीटी
बना.
बजाने को बोलो.
इट वाज वेरी गुड. आणि शाम में मैं सिट्टी बजाऊंगा. डोंट.
अभी बजाइए सर, अभी बजाइए सीटी.
So along with the song, one CT also. Okay. After we finished.
Ma'am, my wife is saying वो कुकर का सीटी बजाएगी.
Oh God. Yeah, see, you don't get your wife in front here because if she comes, all the guys will start लगावing CT for her.
नहीं, पीछे ही ठीक है. So ma'am, the next performer we have is my first ophthalmic mentor. So I am an ophthalmologist because of this lady. She is none other than Dr. Neeta Shanbag, the most bindas, the most confident, and the most always perfect person that I know. She is showing off a talent which I never knew she had. So ma'am, you would like to say something for her too?
Yes, yes. Neeta has been a very, very, very old friend of mine, and she is multi-talented. So let's hear her talent where singing is concerned. We've put
Nikhil, for me, whatever you said about Neeta, ditto, me too.
Yes, ma'am. Absolutely.
Come on, Neeta madam.
Neeta,
Thank you, all of you. I hope you like my song.
Of course,
Chalo,
we
we'll go
like you, so we
ahead.
like your song also.
All the best.
मेरे अनुरागी मन में रजनी गंधा फूल तुम्हारे महके यूं ही जीवन में. हाँ, यूं ही महके प्रीत पिया की मेरे अनुरागी मन में. अधिकार है जब से साजन का हर धड़कन पर माना मैंने. अधिकार है जब से साजन का हर धड़कन पर माना मैंने. मैं जब से उनके साथ बंधी ये भेद कभी जाना मैंने. कितना सुख है बंधन में. रजनी गंधा फूल तुम्हारे महके यूं ही जीवन में. हाँ, यूं ही महके प्रीत पिया की मेरे अनुरागी मन में. हर पल मेरी इन आँखों में बस रहते हैं सपने उनके. हर पल मेरी इन आँखों में बस रहते हैं सपने उनके. मन कहता है मैं रंगों की एक प्यार भरी बदरी बन के बरसों उनके आंगन में. रजनी गंधा फूल तुम्हारे महके यूं ही जीवन में. हाँ, यूं ही महके प्रीत पिया की मेरे अनुरागी मन में.
So So that was brilliant again. Ma'am, ये अच्छा talent है आपका. So I want to hear you live next time we meet, ma'am.
Yes,
Yes,
and I
beta.
like.
Thank you so much.
I
And
love the smile
I
which she
must
gave
thank,
at the end.
yeah, I must thank Karobi for it because of her persistence. I have sent this video.
No. That was very sweet of you.
Yeah, that was wonderful.
I know,
Wonderful.
she
Doing
agreed
COVID duties,
firsthand.
being asthmatic and singing so well. Neeta, you rock.
Hats off.
Thanks, Ragini. You're my backbone, so you know that.
Madam, that was wonderful. Beautiful singing.
Thanks, Geetanjali. Thank you so much.
Yeah. And thank you, Ragini, Karabi madam, and everyone for encouraging us. Otherwise, we wouldn't have sent our videos.
So this is all Karobi ma'am's brainchild and Nikhil's hard work, and you must give.
I know.
Thank you, ma'am. Thank you.
It's
But you know,
Nikhil.
what I really love about this is the enthusiasm everyone projects, and see the costume, so beautiful. You know, I mean, she's done a Kathak dance as though she's doing it live on stage, and all others also who come and perform, they perform it so well. You know,
So ma'am,
it's
you
really
know,
amazing.
we are the lucky ones because in the morning, the entire talent show, my entire family, we sat and we watched it. It was so amazing, you know.
मैडम लॉकडाउन में और डिप्रेसिव मूड में वही एक चांस था कि थोड़ा सा कॉस्ट्यूम वगैरह पहन के थोड़ा ज्वेलरी पहन के डांस करो so that gives you a boost.
Changed our mood also. So thank you.
Karobi ma'am, you know, I had gone some time back next to Lani sir's office and I was telling him, sir, please, you know, you finish your session on time because this session को time मिलना चाहिए.
Thank you so much, Ragini. Thank you very much. Okay, we go over to the next participant. This is none other than Pranav Kodial, son of Dr. Harish Kodial, who many of the senior ophthalmologists knew very well and loved him. And he's going to talk to us, do a funny act where he's going to talk to us about COVID products from China. So let's go ahead and hear him.
So ma'am, Pranav said that this particular segment is sponsored by a very generous sponsor from China. और इसको मजा करने के लिए चाय लेके बैठना है, लेकिन उसमें होना चाहिए चीनी कम. If you get what I'm saying.
Pranav is too good, too good.
So here we go, ma'am.
आपने हमें इस प्रोग्राम के प्रायोजक बनने का सौभाग्य दिया, इसके लिए आपको हमारे कोटि कोटि प्रणाम। हमें सुनिश्चित है आप हमारे प्रोडक्ट्स खरीदकर हमें भी कोटि कोटि कमा के देंगे। कोविड महामारी में आपके जीवन को आसान करने वाले हैं हम, कोविड आसान प्रोडक्ट्स। चाइना का नाम सुन के घबराइएगा नहीं, हम पूरे 24 घंटे का गारंटी देते हैं। दुनिया में कोई भी कंपनी को यश पाने के लिए प्रेरणा की जरूरत पड़ती है। इन सब की प्रेरणा मिलने से हमारा कंपनी साकार हो गया। अब देखेंगे हमारे क्या क्या प्रोडक्ट्स हैं। हमारे मेन प्रोडक्ट्स हैं फेस मास्क। हम आपको वादा करते हैं हमारे मास्क आप सबके मुंह बंद कर देंगे। सोचिए आप दिन भर मास्क पहन रहे हैं, शाम तक आपका क्या हाल हो जाता है। सर दर्द होने लगता है ना, चक्कर आने लगती है ना। किस वजह से? नहीं, ऑक्सीजन की कमी की वजह से नहीं। सुबह खाया हुआ वो अंडे का भुर्जी, दोपहर में वो प्याज, आपका पसीना, इन सब की बदबू से। लेकिन परेशान मत होइए, पुष्पमुखी मास्क अपनाइए। उसके एडवांस टेक्नोलॉजी से वो सब दुर्गंध बाहर फेंक देगा और आपको सिर्फ फूलों की खुशबू लाभ होगा। उसमें सिर्फ एक प्रॉब्लम है, मास्क ने बाहर फेंकी हुई बदबू दूसरों को सहन करना पड़ेगा, लेकिन आपका नाक और मन प्रसन्न रहेगा। अलग अलग फूलों की खुशबू में उपलब्ध पुष्पमुखी मास्क। दिन भर काम करके पेट में चूहे दौड़ रहे होंगे ना, चिंता मत कीजिए, अंदरमुखी मास्क हाजिर है। भूख लगने पर ये विलक्षण मास्क आप खा सकते हैं। जी हाँ, प्रोटीन, कार्बोहाइड्रेट और विटामिन से युक्त एक ही अंदरमुखी मास्क खाने से आपका पेट भर जाएगा। और हाँ, उसमें डाइट स्पेशल भी मिलता है। फिलहाल अंदरमुखी मास्क पंजाबी, चाइनीज, बंगाली और मराठी मेन्यू में उपलब्ध है। एक खा के देखिए, माँ के हाथ का खाना याद आ जाएगा। इसमें सिर्फ एक प्रॉब्लम है, मास्क खाते वक्त उसके साथ कोरोना वायरस भी पेट में जाएगा। लेकिन बेफिक्र रहिए, हमारे अंदरमुखी मास्क इतने स्वादिष्ट हैं कि आपको कोरोना वायरस भी टेस्टी लगेगा। इसलिए भाइयों और बहनों, आज के बाद ऑफिस, स्कूल या कॉलेज जाते वक्त खाने का डब्बा ले जाने की जरूरत नहीं। एक्स्ट्रा अंदरमुखी मास्क बैग में ले जाइए, काम हो जाएगा। अब इनको देखिए, अरे अरे अरे, ये तो हमारे यहाँ की, एक मिनट, हाँ, क्षमा कीजिए, ये सही स्लाइड है। हमारा एक भारतीय मित्र है जिसका नाम है राजा। उसका इन देवियों से परिचय है, ऐसे वो कहता है। खैर, अब इन देवियों को गौर से देखिए। ऐसे आपको लगता है कि उन्होंने मास्क पहना है? नहीं ना? लेकिन हाँ हुजूर, उन्होंने मास्क पहना है। नए टेक्नोलॉजी से बना हमारा दर्शनमुखी मास्क पूरा पारदर्शक यानी ट्रांसपेरेंट है। इसकी कीमत जरा ज्यादा है, लेकिन स्पेशल ओकेजन के लिए सबसे बेस्ट। बहनों, सोचिए, आपका लगाया हुआ मेकअप वेस्ट नहीं जाएगा। शादी में दुल्हन नई नवेली दुल्हन जैसे ही दिखेगी, हॉस्पिटल की नर्स जैसे नहीं। सबको आपका मुख दर्शन कराने वाला दर्शनमुखी मास्क। शादी हो गई? हनीमून की तैयारियां चल रही हैं क्या? आपका मधुर चंद्रमुखी मास्क साथ ले जाना मत भूलिए। सबको मालूम तो हो कि आपकी शादी हो गई है, तो लोगों को फिजूल की पंचायती करने मिलेगी। ध्यान में रखिए, नाम भले ही मधुर चंद्रमुखी हो, लेकिन कोई भी कपल इसका लाभ उठा सकते हैं। ये मास्क की विशेषता है कि यदि पति या पत्नी ने गुस्से में आकर गाली दी, तो उनके शब्द प्रेम कविता बनकर बाहर निकलेंगे। आपका हनीमून शहद जैसा मधुर रहेगा, सड़े हुए आम जैसे नहीं।
अंकल, ये मास्क के बीच में स्क्वायर क्या है?
अच्छा प्रश्न पूछा है बेटा। ये स्क्वायर जो है वो ढक्कन जैसे खुल जाता है। जरूरत पड़ने पर बिना मास्क निकाले वो खोल के, शर्मा क्या रही है, वो खोल के खा पी सकते हैं। आजकल के बच्चे, एक ही तरफ दिमाग चलता है। मास्क छोड़ के हमारे और भी प्रोडक्ट्स हैं। उनमें से एक है कोवी दंत मंजन। ये दंत मंजन इस्तेमाल करने से आपके दांत में अटके हुए सब कोरोना वायरस निकल जाएंगे। इतना प्रभावशाली कि कोरोना वायरस के दांत भी चमकने लगेंगे। और एक प्रोडक्ट है, वो है हमारा सैनिटाइजर, कॉनी वॉकर। बढ़िया सैनिटाइजर के अलावा इसकी और एक खूबियत है। शाम को जब सूरज ढल जाता है, तब थोड़ा सा ग्लास में लेके उसमें सोडा डाल के यदि पिएंगे, तो आप भी कोरोना वायरस जैसे हवा में उड़ने लगेंगे। हमें यकीन है कि आपको हमारे सब प्रोडक्ट्स बहुत अच्छे लगे होंगे। इसलिए हमारे चाइना में एक कहावत है, जो करे कोरोना वायरस से नफरत अपार, वो कोविड आसान से कैसे करे इनकार। इसलिए तुरंत फोन करके आपके पसंद के प्रोडक्ट्स ऑर्डर कीजिए। हमारे फोन नंबर जरूर नोट कर लीजिए। थैंक यू।
That was brilliant, Pranav. There is orders for you, you know.
Oh, thank you so much.
Atul wants many boxes of Andarmukhi masks,
Yeah.
and I want a Darshanmukhi mask.
I
But
want a Madhur talking wala ma'am.
and he's asked for discount also, you know.
Yeah, sure.
All orders
Conference
only on
special.
that number, na? Pranav, only on that number, na? The
Yeah,
Chinese number.
only on those
Which
Chinese
mask do
numbers.
you want?
And you have to use a Chinese phone, huh? Not a normal phone.
Pranav is too good, too good. Karobi ma'am, if you had not kept this program, nobody would have known what everybody is capable of. And now when I see Pranav, no, I'm just going to tell him, "Oh sir, थोड़ा कुछ नया बोल."
नहीं तू उसको बोल कौन सा मास्क चाहिए तेरे को, वो दे देगा।
Next time बैग में लेके आता हूँ मैडम।
Yeah, good. Okay, let's move over to the next one because we are running a little late. So, yeah, the next people are Vanashri and Tanvi doing a duet. We both are very familiar with them, so without much more talk, I think we ask them to sing their song.
Okay, just one line I'll say is एक
the
लता.
nightingales.
Nightingales, yes.
So I'm just saying एक लता है तो एक आशा है, दोनों मिलके करेंगे एक से भले दो. Here they go.
कजरा मोहब्बत वाला अखियों में ऐसा डाला कजरे ने ले ली मेरी जान हाय रे मैं तेरे कुर्बान दुनिया है मेरे पीछे लेकिन मैं तेरे पीछे अपना बना ले मेरी जान हाय रे मैं तेरे कुर्बान कजरा मोहब्बत वाला अखियों में ऐसा डाला कजरे ने ले ली मेरी जान हाय रे मैं तेरे कुर्बान आइयो कहाँ से गोरी आँखों में प्यार लेके आइयो कहाँ से गोरी आँखों में प्यार लेके बढ़ती जवानी की ये पहली बहार लेके बढ़ती जवानी की ये पहली बहार लेके दिल्ली शहर का सारा मीना बाजार लेके दिल्ली शहर का सारा मीना बाजार लेके झुमका बरेली वाला कानों में ऐसा डाला झुमके ने ले ली मेरी जान हाय रे मैं तेरे कुर्बान दुनिया है मेरे पीछे लेकिन मैं तेरे पीछे अपना बना ले मेरी जान हाय रे मैं तेरे कुर्बान मोटर ना बंगला मांगू झुमका ना हार मांगू मोटर ना बंगला मांगू झुमका ना हार मांगू दिल को जलाने वाले दिल का करार मांगू दिल को जलाने वाले दिल का करार मांगू सैया में कर दे मेरे थोड़ा सा प्यार मांगू सैया में दर्दी मेरे थोड़ा सा प्यार मांगू किस्मत बना दे मेरी दुनिया बसा दे मेरी कर ले सगाई मेरी जान हाय रे मैं तेरे कुर्बान कजरा मोहब्बत वाला अखियों में ऐसा डाला कजरे ने ले ली मेरी जान हाय रे मैं तेरे कुर्बान दुनिया है मेरे पीछे लेकिन मैं तेरे पीछे अपना बना ले मेरी जान हाय रे मैं तेरे कुर्बान
Wow, that was excellent, Vanashri and Tanvi.
Thank you so much.
I
Thank
feel
you so
like
much.
singing Kajrare, Kali, Kali. Not singing. Otherwise,
Superb,
everybody will run away.
superb. The Nightingales.
Really, really, very nice. Very
Thank you for the opportunity, ma'am.
Thank you. And thank you,
Always.
Gitanjali ma'am, for enjoying it so much. I was watching you all throughout the song.
Yeah, this is my favorite song.
He wanted to dance at that time.
I just hope that we start our physical activities, our conferences, और वो हल्ला गुल्ला वापस से क्यों रागिनी? We should.
Yes, yes, absolutely. We must start, and then we'll be able to see all these everybody live.
Yes, yes, yes. It will be a very,
And
very,
meet them,
very
give them hugs, and watch them singing live.
I know.
Back
But
to
एक चीज है, ये इतने अच्छे performances है, we will not be able to keep it during the scientific session because scientific में कोई नहीं बैठेगा. इतना अच्छा है.
Very true, ma'am.
Okay, we just move ahead. There are one or two.
Sorry.
Let me introduce this person. This is Dr. B.T. Shah. He's a very senior ophthalmologist. Now he's retired from ophthalmology, but he pursues his passion of dancing even at this age. He and his wife are learning the tango, and they are so interested. And they are a couple who are made for each other.
So I want to say he is the youngest senior member we have, youngest at heart. And once he was walking on the road and one child told him, "Arey chacha kidhar jate ho?" He said, "Abe chacha hoga tera baap. Ye dekh mera gujju cha cha cha." So that's his performance today. So that was really brilliant.
Really brilliant. The grace which both of them have is phenomenal, and they're so graceful and so nicely done. Moving on to the next participant, he's someone whom we've got all the way from Jamshedpur. He's none other than Dr. Bibhuti Bhushan. He's done his VR fellowship from Chennai, but he's pursuing anterior segment and medical retina, and he's going to give us his performance on the harmonica.
So the only thing I can blow is blow off steam, but he's going to blow into the harmonica and make magical tunes come out. He sings Chala Jata Hu, but we are not going anywhere. We're right here with you.
That was excellent, Dr. Vibhuti. I'm so glad that Ragini suggested that we include him in our session. It was really nice hearing you.
Thank you, Vibhuti Bhaiya. Thank you for being there. I called him up and I had to literally tell him because I've heard him. I know him well because I meet him at conferences, and when I heard him on the Facebook, and you should take the credit for this session. And thank you, Vibhuti Bhaiya, for enthralling us. And everybody is writing on the chat that it's so difficult, and I agree. And thank you so much for being with us. Thank you, Karobi ma'am, for bringing him.
And this is another one with good lung power. Okay, we move to the last this item of the day today. It will not take more than 2-3 minutes because this is none other than Manjari, who is a multi-talented person, who's going to read out one of our poems to us.
Manjari ma'am, please. Yes, welcome you to this.
Good afternoon, Manjari.
Good afternoon. How are you?
Yeah, she lovely poems. Luckily, we are in the Mulund group, so we get to read every day, and they are beautiful. Every one of them is beautiful. The poem.
Thank you, Ragini. Thank you so much.
Manjari, go ahead with your Ajani.
Which poem?
Ajani.
Which you are going to show?
You read. Ajani.
Okay, Ajani.
Yeah.
Oh, Iron of Life.
Okay, so this one we can see it, right? Go ahead, ma'am.
Yes, we can.
This poem I have written in the last year. These are my views on life before and after this coronized world. My emotional and spiritual impact. Why is enough? Iron of life. Iron of life is a cycle of life. Iron meaning Sanskrit word. The meaning is cycle. Why is enough to celebrate own me? My tiny spot existence. Is that me? Blunt reminder of my insignificance in vast creation, just happenstance. Ego vanished, feeling of nothingness, humility crowns, tranquil sweetness. Wife of misunderstandings and ill fate, not too late before turns into hate. Don't burn yourself in fear unknown. Let's deal with the warriors on our own. Never splurge on unwanted conflicts, will camouflage into enmity and deceits. Unknown weird form the greed attires, if you let loose your mammoth desires. Differential knowledge of need and want, save futile expense turning into debt. Unwanted thoughts, my head spinning, my brain lost into negativity hovering. Flame my undue pride called false ego. Enlighten life brighter, just let go. Me, too tiny in his grand kingdom, let me celebrate my renewed wisdom. Thank you so much.
Thank you, ma'am. That was really nice, especially the part where you say ego and let go. Just a few words change, your attitude changes, isn't it? Lots to learn from that.
Yeah. Do you have some time?
I think we have run out of time actually. The next session is already everyone's here. Sorry once again for delaying this a little bit, and apologies for that.
Thank you so much. It was wonderful.
Karobi ma'am, you're muted.
Thank you, everyone. I hope you all enjoyed it. And we'll be back with more at 6:30 in the evening. So please be around in large numbers. Bye.
Thank you, ma'am.
Thank you,
Ragini ma'am. Thank you, Karobi ma'am.
Thank you,
over to
Karobi
you
ma'am.
all.
Thank you, Nikhil. Thank you. A big round of applause for
all
both of you and everyone, every single one of you who performed today. Y'all are.
Yes. Ooh.
Thank you, ma'am. Okay, all yours now.
Bye-bye.
So we begin the next session, which is FACOS 7. And at the outset, I thank Lane sir and Ragini madam and Preetham and Swapnesh for organizing such a brilliant summer symposium. And I invite the chairman, Dr. Kishore Pahuja, and the co-chairman, Manish Shah, to take over. I invite the convener and the co-convener to start the meeting.
Thank you everybody. Good afternoon, Pahuja sir, Manish.
Hi, good afternoon. Good afternoon, ma'am.
Vaishal, good afternoon.
Good afternoon,
Hijab,
Good
Shirish.
afternoon.
Thank you so much. And I agree with you that Preetham is a brain, and Manish, Preetham, everybody always put such lovely programs together. And the whole team, all of you, Vaishal, everybody works so hard. Thank you so much. Thank you so much.
Good afternoon, everyone. I invite, Dr. Kenya has already introduced our co-chairman, and he is going to moderate the session. The first, we are just going to invite Dr. Janin Patel, who is my very good friend of mine and a dynamic lady, who is going to talk on basics of Pentacam. Dr. Janin, are you there?
I can't see Janin.
Yeah, because I also can't see her. So
probably she might join late. So maybe you can go to the next talk and then include her later.
yeah, so the next is Dr. Vaishal. So I think Dr. Vaishal, you can just start your talk first.
Fine.
Then Lucidus I will.
Yeah. Yes.
Good afternoon. Telang sir has also joined us.
So can you see my screen?
Yes.
Yeah. Okay. So today I'm going to talk about a Lucidus EDOF IOL, and this is very close to my heart, and I have no financial interest in this product. So with advancement in lifestyles, demand for uncorrected visual acuity at all distances is required. We are in search of an ideal IOL, and I feel the extended depth of focus IOL provide better quality of vision, better contrast, and better nighttime vision. So they offer even better intermediate performance and with less scatter of light. So there we have an array of EDOF lenses, which are pure EDOFs and hybrid EDOFs. So pure EDOF IOLs basically give more distance and intermediate vision, whereas an hybrid EDOF give an extended continuous range of vision from distance to near. So EDOFs can also be classified as EDOFs with diffractive rings and EDOFs without diffractive rings. So hybrid EDOFs are EDOFs which supplement and enhance the near vision also. And today we have hybrid EDOFs with rings and without rings. So we are going to talk about a lens which is a hybrid refractive EDOF lens, which is Lucidus, and it is also available in a toric design. It has an overall optic size of 6 millimeters and a hydrophilic platform with closed loop design, and got a central lenticule, a refractive lenticule for near and intermediate of 1 millimeter. So it has a novel non-diffractive design of using the pseudo non-diffractive beam. Now, to understand a diffractive beam means you require diffractive rings, and because of diffraction, you can then see a separate focal points. But in a pseudo non-diffractive beam, they use an axicon. I'll come to what is an axicon. An axicon basically is nothing but a conical lens. It stretches a point source of light into a line. So because of this stretching or elongated focal points, your depth of focus increases. So this is the convex or a conical lens which is there in the central lenticule of this lens, and which gives the extended depth of focus. And this extended depth of focus with an hybrid bifocality of +3 gives you a continuous range of vision from distance, intermediate to near vision. So because of this unique patented design of instant focus and pseudo non-diffractive beam, you can see this continuous range of vision. We did a small study from January 2020 to March 2020, including 48 eyes. And we did a comprehensive pre-op assessment. A comprehensive surgical planning was done with the IOL Master 700 and Virion. These were the inclusion and exclusion criteria. And I was the sole surgeon doing a clear corneal temporal incision with a Virion assisted visual axis centered rhexis. An immediate post-op following vision, slit lamp and non-contact tonometry was done. This was the post-op regime. And we saw the outcome variables at 1 month for the distance, intermediate and near vision. And we also saw in detail the higher order aberrations at 6 millimeter fixed pupils. So out of these 48 eyes, 5 eyes had to be excluded because of missing data. This was a pre-op data. But the most important thing was in 87.76%, we got an unaided vision of 6/6, intermediate vision of N10, and again 87.76% got an N6 unaided vision. It had also got a summating effect. So with binocular vision, we got in 100% 6/6 vision, N10 vision, and N6 vision with this lens. So if you see the post-operative refractive error, the key to any presbyopic lens is to hit near emetropia. So unless you hit that, you don't get a very good result. So hitting near emetropia is very key, and to err slightly on a myopic side is important. So interesting part about the higher order aberration was the total higher order aberration was around induced was around 0.54. Important was the negative spherical aberration. It was near neutral and not contributing much to the extended depth of focus. The modulation transfer function in the photopic condition was found to be around 0.6, which is as equivalent to a monofocal lens. And this was a defocus curve. And if you see the defocus curve, it is comparable to a panoptic or an acrylisa, and it gives good distant, intermediate as well as near vision. So with the Lucidus IOL, most of the patients achieve excellent visual acuity, and the design blend of distance, near and intermediate is so good that hardly any patient has any glare halos. In fact, I had none of our patients complaining of that. And the angle alpha, this lens is tolerant to that, probably because of absence of rings and a central lenticule which is of 1 millimeter. It doesn't interfere with a even high angle alpha more than 0.5. We observed binocular summation effect in few cases who were implanted bilaterally, and neuroadaptation. There is no neuroadaptation required because these lenses are non-diffractive rings. So instantly the patient adapts to it. So I conclude that the Lucidus IOL has an ability to see clearly continuously at all distances, causes no photopsia, tolerant to high angle alpha, angle kappa, and ability to work in low light as good contrast sensitivity and light distribution. I'll just share a small video. I mark the axis with the edge of the keratome. And this lens is a closed design and can be implanted under irrigation. Thank you so much. Sir, you're muted, sir. Yeah.
Thank you.
Yeah.
Thank you, Dr. Vishal, for your elaborate talk on lucidus. I think probably the days are going to come where as the bifocals have been obsolete, and now we're talking about trifocals, and then probably just because of photopic phenomena, and we are just going to move to an EDOF lenses, and probably this is going to be a feature. Dr. Manish, will you invite the next speaker, or I'll just continue with the next speaker? Dr. Janin has joined. Oh,
no, I'll just call her up.
No. Yeah. Okay. So then we have next my very good friend of mine, Dr. Sean Chinchode from Lana. He is going to talk within a small pupil in cataract surgery. Dr. Sean?
Yes, sir.
Will you just share your, yeah. And we just request everyone to stick to time because we are already late by 15 minutes. So then we have a good time to have a discussion on what we are going to talk.
Is it okay, sir? Can you see my slides? Hello? Hello?
I think it's loading.
Yeah.
Because you have started, we can see it started screen sharing.
Heavy rains are going on here, sir, in Buldana. So maybe because of that. Hello?
I mean, you have started screen sharing.
Yeah. Now it's visible, sir?
Yeah.
Hello?
Yes.
Very good afternoon, everyone.
Yes.
And,
Sir, it is working. Yeah. Please.
Thank you very much, respected Pauja sir. It's been a great honor to be with you. My today's topic is dealing with small pupil in cataract surgeries. Common causes of small pupil in cataract surgery are advanced age, post-uveitis cataract surgery, pseudo-exclusion syndrome, diabetic patient, floppy iris syndromes, high hypermetropia, prolonged myotic therapy, and neurological conditions. Problems that occurs during capsular axis is difficulty in visualization of rhexis margin, leading to ill judgment of size, shape, and if any extension to periphery. Hydro procedures are also difficult, inability to judge the correct decision plane, and leading to difficulty in rotation of the nucleus. Phacoemulsification is also difficult. Smaller the pupil, poor the red reflex, which can lead to difficulty in judging the depth and trench, and that leads to PCR risk. Risk of catching pupillary margin again and again, that leads to small the pupil, and again there will be a problem in PCR risk, chopper and posterior extension of tear, and again it leads to PCR. It leads to difficulty in cortical aspiration and in the back to implant the IOL also. High risk of iris damage that leads to iris bleeding, iris prolapse from the wounds, smaller the axis, then incomplete evacuation of cortical matter, problems in ensuring the IOL bag implantation. And it will be difficult to align the toric IOLs also. Posterior synechia that cause the small pupil because of long-term use of myotics, pseudo-exclusion syndrome, neurological disorders, uveitis, and trauma, and any previous history of surgery. This can be managed by mydriatic subconjunctival injections of mitricane if patient is using myotics, asked to discontinue 3 weeks prior to surgery. It depends on the patient and depends on surgical skill. Smaller the pupil, that depends on surgeon skill and technique, intraoperative situations, and iris tissue properties. How to manage? That depends on surgeon technique. Pupil expansion techniques depends on pupil size and biomechanical properties of iris. Pharmacological management is preoperative atropine eye drops 3 days prior to surgery. If posterior synechia, then with the viscoelastic agent, we can stretch the pupil, deepening of the AC, and pupil dilatation will be there. Stepwise approach to pupil expansion is intraoperative procedures that 1:1000 preservative free epinephrine intracameral injection, viscodimetries with cohesive Hilon GV we can use that leads to posterior synochilosis and stretch pupilloplasty technique. This can lead to pupil expansion. You will get at least minimum 3 to 4 millimeter of pupil after using this. Surgeon skill and technique that if you use viscoadaptive OVD Vidon, then decrease fluidics parameters, utilize vertical chopping techniques, manipulate in the anterior chambers, and use bimanual irrigation and aspiration cannula. Sinusolysis you can do with side port or with the Werner's scissor. Small incisions at the border of pupillary margin, which can help you after putting the OAD. It will stretch the pupillary margin and you will get more than 3 millimeters to 4 millimeters pupillary margin and you can start your surgeries. Stretch pupilloplasty, it's tricky because if the pupil is quite small and there are posterior synechia, with the help of iris retractor, you can just go behind the pupil margin and you can stretch the pupil, and with the Y shape, you can stretch horizontal and vertical, which can give you, and it can break the small adhesions and will definitely give you pupillary, it's not that much satisfied, but at least 3 to 4 millimeters of pupillary margin you will get. Pupil expansion devices, these are all pupillary devices in the market available. We are using iris hooks. Actually, you need 4 to 5 paracentesis incision, need 4 to 5 side ports incision, should be placed near to the limbus and maintain adequate AC depth. You need good skill as this may cause shallow anterior chamber and will be difficult sometimes. Usually we use 4, but if you are more comfortable, you can go ahead with the surgery or with the help of 5th iris hook at the main side port, at the main incision, so that it can catch the iris when you are introducing the phaco probe inside. I am using BS pupil expander. It is injector. It's a preloaded one. With the help of forceps also and with the help of Sinski hook also you can introduce through the side port. More easy with 26 gauge forceps. Advantage is it will give you good hexagonal shape and it's easy to insert and to remove also. With the help of forceps you can just go pull and push technique. You can just bring it out. But nowadays, without Sinski hook also, with side port 26 gauge forceps, you can just pull it out and you can introduce also. And it's very easy. Only you need 2 instruments, one to hold the eyeball properly. The expander is also a good device, but it needs injector and cartridge. It gives you square shaped pupil margin. Just you have to be cautious because when you are introducing, you have to just keep it above the iris. Then one by one, you can introduce behind the pupil and you will get square shape edge. It's a good device also. Management of intraoperative meiosis. Nowadays, it's very helpful. Commercially, it is available with some pharmaceutical company. Use of tropicamide, phenylephrine and lignocaine injection. When you everything in a proper way, but sometimes with the pupillary injury or with the iris tissue injury that causes construction of pupil and suddenly pupil get constricted. But introduction of this injection, you can see here, you can manage it very well, at least 4 to 5 millimeters. You can insert very nice lens also, and you can continue your phaco also. Advantage of hooks for pupil expander is technically much easier to insert and remove. Pupil expander is difficult to insert after capsular axis. Iris hooks much more reliable in such cases. Because next talk is of Dr. Shirish Thoras, so definitely he is going to introduce this thing. Advantage of pupil expander over iris hook is no need for extra paracentesis, easy fixation points, smooth edges, and less trauma to iris tissues and flexibility. Thank you very much. IPL for VP 2021. Thank you.
So that was a great talk on small pupil. Yeah, definitely doing small pupil is very skillful job. Dr. Sean, what would you talk about? How would you manage differently a fibrotic pupil and a non-fibrotic pupil?
Sir, for the fibrotic pupil, I use iris hook only because it is difficult for me to put BX pupil expander or this thing. But sometimes, as I said, if it is not only the fibroid, if it is a posterior synechia with the iris hook also, or with the not iris hook, it is with the iris repositor, you can just break the pupillary margin and synechia, and you will get, surprisingly, you will get very good pupil extension. At least minimum 3 to 4 millimeters, and you can go ahead. If it is not that much hard case, you can just do simple without
So
any.
whereas Dr. Osher has also described an entity in inflammatory, this thing, peripupillary membrane. So sometimes near the pupil margin, there are peripupillary membrane. If you peel it, the pupil expands. Nevertheless, because of short of time, we move on. I would ask Dr. Manish to introduce the next speaker. Manish, you're muted.
Okay, Dr. Vishal. I'm Dr. Girish.
Yeah, please welcome, sir.
So, management of zonular dehiscence should be known by, just a minute. Is it visible now?
Yes, sir. Yes, sir. Go ahead, sir.
So, my topic is management of zonular dehiscences. Every phacosurgeon must know how to deal with it. Without going into theoretical details, we move on to the videos directly. This is a small pupil case. I thought of taking it without any dilating devices, but wrinkling of the capsule. This is the sign that zonules are weak. And to deal with this, we need some support either intraoperatively or postoperatively. Now, with the rexis of medium side, go slowly. And this is a CTR which is going inside under the anterior capsule. The tenting indicates that it is in the back, and this second hand is very helpful. Take all the forces on the synthesis hook before guiding it. Slow motion phaco is desirable. The only thing is that difficulty in removal of the cortex. But see, the tangential movement of the eye probe take care of this. And once this is done, I have a habit of putting it in the sulcus with the optic capture, just for the long-term safety. Different types of CTR are available for normalized, for myopid eyes, and for high myopid eyes. Long-term data shows there are dislocation of whole complex as CTR, bag, and IOL in the vitreous. So we modified our technique of optic capture, that is haptic in the sulcus and optic into the bag. Now going to the next case, this is a moderate subluxation, around 90 to 120 degrees. The staining in this case is very important. With the routine side port, staining is done. So rhexis is the most important factor in such cases. Always start the rhexis away from the area of dialysis, rather 180-degree away from it. Go slowly, and in the area of zonal dehiscence, make it very small rhexis, and then with the help of forceps, enlarge the rhexis, rather slightly decentered it onto the area of the strong zonules, so that when you pull it, it will come into the center. Here, I thought of using capsular hooks. These are very flexible and atraumatic hooks, and this is the most wanted instrument in such cases. After applying the capsular hook, slow motion phaco was being done. Don't allow any piece to fall into the vitreous, and watch the movement of eye probe again. It is going toward the area of zonal dialysis. That is to avoid the damage of further zonules. And once it is clear of with the cortex, the bag is ready for accommodate IOLs and the fixating device. Here I thought of using a CTR first and then to decide. So while injecting the CTR, always go toward the area of the dialysis. Left hand support is very important. Take out all the forces on the Sinski's hook and gently guide it into the back. And in this case, the hook is providing, this CTR is providing much support. The vitreous fibers are identified by the help of tripod and deals with the vitrectomy. I feel the rhexis was small, so extension of rhexis is being done. Go through side pores very slowly. Now watch, it is going, but now watch the movement of my hand. I'm literally pulling it on the opposite side, and rhexis is going in the other direction to complete it. So you must know all forces acting on the anterior capsule. And again, 3-piece IOL is injected. Friends, for severe zonal dialysis, these are very different devices to anchor the sclera. Ashi anchor is one of them, and this is a, I mean, I love this instrument very much. After rhexis, with the help of reloading technique, take the suture out, either wrap it around the limb of short limb, or there is a hole in the limb and whole assembly to be taken inside the anterior chamber. The shorter limb to be raised on the anterior capsule and longer limb into the bag, and thus fixing the sclera. That was animation. This was a case of pediatric subluxated cataract. Principle is the same. Rhexis is very important in such cases. Always start 180-degree away from the area of the dialysis. Go slowly in the area of the dialysis and purposefully decenter it in the area of the strong zonules. This is most important. Rhexis is most important in such cases. You can take help of capsular hook also for performing the rhexis. Again, the preparation of the scleral bed exactly in the center of the subluxation, around 2 millimeter away from the limbus, and with the help of rail loading technique again, the same device, that is Ashi anchor. It is uniplanar instrument, uniplanar device, which can insert through the 3.3 millimeter corneal incision also. With the help of rail rolling technique, take out 9 polypropylene sutures one by one, approximately 1 to 2 millimeter apart. Take out whole assembly inside the anterior chamber, upper limb on the anterior capsule, and large limb into the back, tuck it into the back. Once it got tucked in, pull whole the assembly. You can see how nicely the bag is getting pulled, and it ultimately stabilizes the back. And the rest of the surgery is like routine one. The bag is getting fixated very nicely. So this is a case of another case of Marfan syndrome. Here I used sionizine. So I just fast forward the video. So after the rexis, Sione has got a limb and eyelid. Always go toward the area of dialysis. Rotate the Sione ring. Keep the eyelid and the hook exactly at the center. And again, with the help of reloading technique, take the sutures out of the sclera one by one and fix it to the sclera. My last case is, this is a case of slow exfoliation. There is no subluxation, but overall progressive zonulopathy is there. So after rexis being done, again capsular hooks were applied. Slow motion phaco is done. Cortex is removed and watch the insertion of the CTR. Your second hand should take all the forces of the CTR or the pressure of CTR and don't allow it to fall onto the anticapsule. Now gently guiding into the bag and optic capsule is being done. So for mild degree of zonal dialysis, you can use 3-piece IOL or CTR. For moderate degree, IOL plus CTR, preferably 3-piece. And for severe degree, that is more than 120 degree, you must fix the bag to the sclera. So my pearls are always start the rexis away from the area of luxation. Leading edge of the CTR should go toward the area of dialysis. Use CTR as late as you can, but as early as you must. Scleral groove to be taken at the center of subluxation. Always keep all necessary devices ready in your OT and use right device at right time. Thank you.
Sir, excellent videos, really very good. And I think it was a really good points, pearls, which you said. And I would ask Dr. Pahuja to introduce the next speaker.
Yeah, I mean, before I introduce, I just wanted to add in one point. What Dr. Thorat said is that when you put on a CTR and after that, if you want to extend a capsular access, you have to be very, very careful because there is an stretch because of the CTR. So there is very, very high chances of getting it pulled. You have to be very, very careful. I mean, all forces has to be exactly opposite to the capsule. So I mean, you have to be very, very careful for that. My next speaker, I'm just going to introduce Dr. Shritika, my colleague from Pune, from Asian Eye Hospital. She's a director there. I mean, she's a medical retina specialist, and she's going to talk to us on a retina evaluation before a multifocal IOL. Welcome, Dr. Shritika.
Thank you for the kind introduction, Dr. Pahuja, sir. Can you see my video?
Yes. Okay. Yes. Go ahead, please.
Yes. So at the offset, let me thank Dr. Ragini Madam and team BOA for having given me this opportunity to share my views on retinal evaluation before multifocal eye implantation. Is it moving forward?
No, you have to click on this and then move forward and then press on a down button.
All right.
Yeah.
So we had a 70-year-old female cardiologist who visited us after undergoing multifocal eye implantation elsewhere, and she was completely devastated with her new vision following multifocal eye implantation. So let's see, why was she so miserable? So pre-operative, her vision status was pretty good. She was a myopic and pretty happy and comfortable, enjoying a contact lens assisted monovision and enjoying a binocular vision of 6/9 N6. So very obvious question which would pop up is, why did she undergo the surgery? Because she was tempted to get rid of her contact lenses and was dreaming of a perfect vision without spectacles or contact lenses. But ironically, her post-operative vision was 6/12 N10 in the right eye, 6/18 N10 in the left eye. And even after spectacle correction, the vision did improve to 6/9 N6, but she was completely unhappy with the quality of vision. So here she was in a complete lose-lose situation where she neither got rid of contact lenses or spectacles, and nor was she happy with the quality of vision. So in further evaluation, we saw that the patient had a perfect looking, well-centered MFIL which was implanted, and the retina did show some RP alterations at the macula and a mild glistening reflex in the left eye. Autofluorescent fundus picture did reveal some RP degenerative changes at the macula, seen as areas of hypoautofluorescence in the macula, also getting reflected in the OCT as RP irregularity, and you also see a thin epiretinal membrane in the left eye. So here we had an unhealthy macula and an MFIOL, which together led to compounded reduction of contrast sensitivity and dissatisfactory vision outcome in this patient. So the lessons we learned here were that patient was not very symptomatic, hence the surgery could have been delayed. And also an IL consideration, depending upon the preoperative vision adaptation, should be given importance, because this patient would have been very comfortable with monofocal IL implantation aiming at monovision. So whenever we are considering a multifocal IOL, we need to ask one question, that am I missing something in the retina? Because many macular degenerative lesions in the early stages may be mistaken as normal looking retina, and I'm going to give you some examples here. The top on the list is an early epiretinal membrane which may go undiagnosed, as in this picture, but would be seen on OCT as loss of foveal dip and an hyperreflective membrane on the inner retina. Another clue is misdirection of central macular vessels, which could also be suggestive of an epiretinal membrane. Other lesions are vitreomacular traction, especially when it is this small as seen in this picture, or a macular microhole, especially when it is in the outer retina as seen in the last picture. And in such situation, it would be almost impossible to pick such tiny lesions on a routine indirect ophthalmoscope, even by a retina specialist. And an OCT comes to rescue here, which would depict it very effectively. Other age-related retinal conditions like early dry AMD, which would go undiagnosed, especially in the setting of hazy view due to cataract, and would be seen as bumpy RP on OCT. Another subtle lesions are RP alterations that are occurring at the macula. They may seem to be insignificant, but in the setting of multifocal IOL, this would lead to unhappy vision outcomes in patients. So, and moreover, these conditions which are age-related are progressive. So even if not in a post-operative period, but later on, patient may not be very happy with multifocal IOL in such settings. Other lesions which are not very common are idiopathic macular telangiectasia. Yes, of course, a full-blown idiopathic macular telangiectasia would be seen as pigmentary changes and crystal depositions at the fovea, but in early stages may be received for a normal retina and could be seen as perifoveal whitening reflex. And OCT would also be not very peculiar of IMT in early stages and could just reveal some minor thinning of macula along with very tiny areas of hypoautofluorescence and well demarcated loss of outer retinal cells. An old central serous retinopathy, which has resolved long ago, may also go undiagnosed and again would leave not many clues, but thinning of macula on OCT or a gap between RP and subretina, an irregular looking RP, and autofluorescent picture which would depict an irregular stippling of hyper and hypoautofluorescent patches. So we need to be aware of such conditions. Now, this was a 65-year-old patient who had cataract, and who 90% of us would diagnose this as a normal looking retina, but this patient had full bone CME as seen here. So idiopathic inflammatory CME could be seen at later ages also, and the only symptom would be blurring of vision, and which could be mistaken as a symptom of cataract. Also, all retinal vein occlusions would be seen, the only sign that would be left behind would be CME after all the hemorrhages have been resolved. So these were the few examples of retinal conditions where the retina would seemingly look normal but would have a macular pathology, and an OCT comes to rescue in all these conditions. Another very relevant topic is considering MFIL in a diabetic patient who doesn't have a diabetic retinopathy. There are ample studies and research which suggest that vascular damage and structural changes do occur in neuroretina way before the diabetic retinopathy sets in. Similar study was done which evaluated MFERG in patients having diabetes but no diabetic retinopathy, and which showed reduced MFERG N1P1 amplitude and a delayed implicit time in diabetic patients without retinopathy compared to normal control. So functional neurodegenerative changes also occur in patients with diabetes but without diabetic retinopathy. OCT was also evaluated in such patients having diabetes but no diabetic retinopathy, and a thinner photoreceptor layer was found in such patients, which also showed positive correlation with the duration of diabetes. So longer the duration of diabetes, thinner was the photoreceptor layer. So in a real scenario, what do we do when we have a multifocal, we have a diabetic patient sitting in our clinic who is hooked on to multifocal IOL. So here are a few points that we consider in our clinic. When patient do have a diabetic retinopathy, maybe very, very mild grade or just microaneurysm, but still this is considered as a contraindication for multifocal IOLs. Duration of diabetes more than 10 years, HbA1c more than 7%, history of diabetic retinopathy in parents or sibling, and age less than 65 years, because there may be more chances of developing diabetic retinopathy in future, are relative contraindication when considering an MF-IOL. On the other hand, recently diagnosed diabetic mellitus with no significant family history, age more than 65, highly motivated to get rid of presbyopic glasses and fixed on to multifocal IOL, and in addition promises to have a lifelong control of diabetes and understand the possible side effects or cons of having multifocal IOL could be considered for multifocal IOLs, although my personal preference here is monovision with the help of monofocal IOLs, which seems to be a more balanced option. So I would like to conclude the talk, and the take-home message would be a meticulous retinal checkup with preoperative OCT macula, autofluorescent picture of the fundus, and a corneal topography should be preferred practice pattern before considering cataract surgery in any patient, especially when considering multifocal IOL. Similar study, which was published in JCRS in 2016, concluded that preoperative macular STOCT scanning was useful in identifying patients at risk for compromised visual outcome after advanced technology IOL surgery. So thank you for patient listening. Thank you very much again for having me on this forum.
So that was very good, Dr. Shrutika, and it really is it's very important for premium IOLs that we do a very extensive preoperative evaluation, like even specular microscopy, OCT, all these things are very, very important. So now I would ask Dr. Manish Shah to introduce Dr. Pankaj. Dr. Shrutika, if you could stop sharing your screen, please.
Yes, sure, sir.
Yeah. Dr. Manish, if you can hear me. Shrutika, madam, you'll have to stop sharing. Yeah, that's right. Dr. Manish, can you hear me? I think there is some glitch with him. We can't hear you. Yeah. No. Dr. Kishore, please introduce Dr. Pankaj.
Yeah. I welcome Dr. Pankaj Lande, who is our next speaker. He is going to talk on contact lens assisted phacoemulsification for phacoemulsification training. And he has a very huge experience of training, and then also he's into teaching now. Dr. Pankaj, please.
Yes, sir. Thank you for those nice words, sir. I'm sharing my screen now. Every one of us is like having an issue with phacoemulsification and saving the endothelial cells also at the same time. So all of us has to save the endothelial cells. So I had an idea, why not to save the endothelial cells with mechanically preventing it from damage by putting a contact lens from inside the eye to prevent the endothelial cell damage. I'm just sharing a video. Once the main port and side port is done, I'm using 2.6 millimeter main port, and a contact lens is cut with 7.5 millimeter trephine. A corneal trephine is used, and that is introduced with a DSEC microforceps. Usually we use the DSEC microforceps for insertion of a graft. The same microforceps I have used for introduction of this contact lens. I'm just fast forwarding it. I don't want to show too much of a surgery, just the main part. See, here the contact lens is coming, and once the contact lens is gone in the anterior chamber, you can flatten it. I myself are doing multiple D6, so I don't find it difficult to open this contact lens and manipulate it in the AC. With few cases practice of some 4-5 cases, you can very well manage this. And this contact lens, whether with the concavity is maintained or not of a contact lens as per the cornea, it is okay, because this contact lens is a soft contact lens. So mechanically we have now protected our cornea, and you can see I don't have any hindrance while introduction of my instruments, and I can very well introduce my instruments as usual. There is no hindrance to my visibility. Visibility is not affected at all. And once I have taken the cortical material, I'm going for first job. The case here I'm showing is not something which need actually this type of procedure, but this is a case where I was doing it. This was a case who had optic atrophy, and I wanted to start it on a case who I don't want it to damage. So once I seen this case, then I have tried this particular procedure on nearly 12 eyes till now, and the results are awesome. The bad part of the story is I don't have a specular, so I don't have a scientific data to publish it right now in hand, but my post-op results are quite promising, and I'm practicing it quite frequently now, and there is no much of a damage because of contact lens insertion or removal. You can see, you can do in cases where you have a shallow AC, you have a very hard cataract, you have zonular dialysis chances where you want to do the phacoemulsification in the anterior chamber. And specifically in cases where students are learning, the phaco trainees are learning, and some senior surgeon can go in, put the contact lens in, and give the case in a hand of a trainee. He can comfortably do his phaco, learn his steps without causing much of a damage to the patient, without compromising his vision. That way it will serve a lot of purpose. And I have seen that removal of this contact lens is not a big deal, which everybody is like worried about. You can remove it along with your IA. Now once the introduction of, you can see, sorry, I have cut short that particular step. In that particular case, I have taken the contact lens with the help of irrigation aspiration cannula. The second method which I tried here is I have introduced the contact lens with the help of an ICL injector, and that was also an easy job. Once the introduction of contact lens is done, you can see the small air bubble is there in between in the interface, and that don't cause much of a hindrance for your procedure or for your introduction of your instruments. This is definitely to be considered. I have cut short the video here. This was a very hard cataract, grade 4 cataract. I have finished off and you can see that there is no visual disturbance. I can finish off my case in the anterior chamber very well. Why I am saying anterior chamber is because I want this technique to be handed over to the phaco trainees, which will not cause any damage to the endothelium, and thereby we can teach them very comfortably without much of a worried about post-operative pseudophakic bullous keratopathy and striate keratopathies. You can see I'm not, just to show this case, I'm not very careful in protecting the endothelium at this moment, and still I have seen that the cornea is quite protected, and you can note how I have taken my contact lens out. You can just go in there. Sorry for that. You cannot emulsify this contact lens. So even though you have a phaco pedal position 2 in IA position of phaco, you can take the contact lens just by tilting your tip towards the corneal endothelium. And that way you can remove this contact lens very easily. It is a job of few seconds hardly. Yeah. And this is the same eye where I just have shown. This is the day 2 post-operative picture of the same patient after 48 hours. Okay, so it is extraordinary procedure and can be used for training purposes. I know with the advancement of the machines and advancement of the technology and the expertise, we don't need these type of procedures for everyone, for every case, but definitely these type of procedures are useful for training purposes, for the cases where you have extraordinary hard cataracts, where it is mandatory that you should go for phaco. I am not a type of person who will always say that you should always go for phaco. It is not necessary. But in such scenarios where you want to go for phaco and want endothelial protection, this is one method where you can use a contact lens as an endoprotector. I am in evaluation of few more cases for this, and I hope you have enjoyed this. Thank you very much.
Really, definitely, Dr. Pankaj, is a very useful technique, and I would encourage you to publish this data. And once it is published, it will be of more value. And definitely, if you can do a specular count study, would also be encouraging.
Sure.
Dr. Pankaj, I want to ask that so much of turbulence because of the phaco fluid. Doesn't the contact lens keep moving and disturb you?
In the initial few cases, I had the issue with this. But once I realized that if I put the interface should not have too much of a visco. You should put a drop of dispersive viscoelastic in the anterior.
So you're putting a methyl cellulose?
Yes, HPMs. Okay. Simple methyl cellulose. No, means what I'm doing is a dispersive viscoelastic first in the anterior chamber with slightly shallow anterior chamber. Introduce your contact lens, and below that you put a higher density viscoelastic so that it will push the contact lens up and it will nicely sit tightly, comfortably there, and it won't move much. It don't cause any damage. I had an issue that whether these edges will cause much of a damage in the periphery of a cornea, exactly. But nothing has happened like that, because this contact lens is very pliable. It is not a very harsh material, we can say, and definitely
okay, agreed.
Agreed, but I think you should do the endothelial cell count before and after and publish the data, so it will be more scientific.
Dr. Parul, because of paucity of time, I may have to cut short.
Yes.
Yeah. I'll ask Dr. Shyam Telang to introduce Dr. Hijab Mehta.
Which lens you are using for this?
Sir, I'm using a Boston Lom disposable contact lenses, which are sterile. All the contact lenses are sterile.
Dr. Pankaj, you'll have to stop sharing your screen, please.
Yes, sir. Yes, sir.
Yeah, because I think what Dr. Parul is asking is that probably the material of contact lens will also make a difference, because I mean, what material you're using of a contact lens, because when Dr. Keki had presented, he also used a contact lens when there is a PCR, and he puts in a contact lens to lift the lens up and then do a phacoemulsification over the lens.
Sorry,
it's
Dr.
a material
KK
grains also
had
that-
used a HEMA. Basically, contact lenses are HEMA material.
Yeah.
Dr. Pankaj, you'll have to stop sharing so that Dr. Hijab can put on our presentation. Yeah.
I had done it? Yes. Okay.
Yeah. Dr. Sham Telang, sir, please introduce Dr. Hijab Mehta.
So now the next speaker is Dr. Hijab Mehta, madam. She is a cataract and refractive surgeon from Mumbai. Now, whatever the best of cataract surgery we have done, with the best of our knowledge and skill, the post-operative management and problems are there. And for that management, now
Thank you, sir.
Dr. Hijab Mehta will talk about this therapeutic care after cataract surgery.
Thank you,
Please,
sir,
ma'am.
for the thank you, sir, for the kind introduction. Thank you, BOA, MOS, and also Novartis. This presentation is courtesy Novartis. More than 5 million patients undergo cataract surgery annually in India alone, and we're all familiar with all the post-cataract surgery complications that we see. Today's talk is going to focus on the infections, inflammation, and cystoid macular edema, which are treatable and preventable complications of cataract surgery. Endophthalmitis is a rare, potentially devastating complication, results in significant loss of vision. According to the endophthalmitis vitrectomy study, 34% of the eyes recover to only 2200 or worse vision, and the patient's own ocular surface flora is the most common source of infection. The incidence of endophthalmitis from all around the world is about 0.03 to 0.2%, and the common organisms are gram-positive cocci followed by gram-negative and fungi. For acute endoph, and for chronic endoph, it is Propionibacterium, Corynebacterium, Staph epidermidis, and fungi. In India also, we see a similar pattern. The management strategies for infection and inflammation control are pre-operative, intra, post-operative, using antibiotics, corticosteroids, and NSAIDs. Povidone iodine is used universally by all of us. It achieves a 97% bacterial kill within 1 minute of irrigation using concentrations of 5 to 10%. It is associated with a 3 to 5-fold reduction in the risk of endoph. It is recommended to use 5% povidone iodine for 3 minutes for the skin and conjunctival asepsis. Topical antibiotic use, there is no clear answer whether they should be started preoperatively, although it is a common practice among all of us. And pre-op use does obtain a high level of antibiotic on the corneal surface and the anterior chamber prior to surgery. And ASCRS survey showed that 85% of the surgeons started topical antibiotics pre-op, 48% started 3 days prior, 32% 1 day prior, and 20% on the day of surgery. It has been shown that combination of topical antibiotics and povidone iodine has greater efficacy in eliminating the bacteria than either agent alone. All of us use topical antibiotics post-op to prevent infection. However, it is important not to taper the antibiotics as this may raise the chance of antibiotic resistance. Another ASCRS survey showed that 97% members used topical antibiotics and 72% of them stopped after 1 week of surgery. There is growing resistance to the second generation fluoroquinolones. However, now we have 4th generation fluoroquinolones available, and their use is widespread to prevent endophthalmitis. What do studies say about the fluoroquinolones? Moxifloxacin has got wide acceptance. It has got an advantage over the others. It has got a broad spectrum of activity. It covers both gram-positive, gram-negative bacteria, the anaerobic bacteria, and also Pseudomonas aeruginosa. It has got excellent penetration into the eye. The aqueous concentration of moxifloxacin following topical administration was higher than that following ganifloxacin. To control inflammation, all of us are using steroids and NSAIDs. Steroids by far are the most potent anti-inflammatory and they suppress all the arms of inflammation, whereas the NSAIDs, they suppress only cyclooxygenase. If we compare the different steroids with hydrocortisone, which has got the anti-inflammatory activity of 1, predacetate is 4 times more potent, whereas dexamethasone is 30 times more potent compared to hydrocort. That's why it can be used in a 0.1% concentration. It penetrates the cornea readily. It has got a long half-life in the ocular tissues, and it reaches the deeper ocular tissues. NSAIDs have their own role to play. They help in maintaining intraop mydriasis, suppress post-op inflammation, they reduce pain, they prevent and treat cystoid macular edema, can be used along with steroids in all patients post-op, or can be reserved for high-risk cases. Advantage of NSAIDs is that there is no risk of IOP elevation. We now have fixed dose combination medicines that have the potential to offer safe and effective treatment. It is simpler than administering 2 separate solutions. That is moxifloxacin along with dexamethasone combination. The moxifloxacin prevents the infection, the dexa prevents the inflammation. The combination reduces the complexity of dosing, improves the patient compliance. Moxifloxacin being a 4th generation quinolone, it inhibits DNA gyrase and bacterial topoisomerase 4. That's why resistance to 4th generation quinolones is not so commonly seen. Clinical evidence also shows that the combination medicine of Moxi and Deca is effective in relieving pain, controls infection, reduces signs of inflammation. There is no effect on IOP elevation, at least up to 2 weeks post-op, has got no burning sensation, no itching sensation following administration. It has got the efficacy of the 4th generation moxifloxacin, anti-inflammatory benefit of dexamethasone. It is therapeutically equivalent to the conventional separate dosing of antibiotic dexamethasone combination. These are self-preserved, so you don't have preservative going on the eye. They're well tolerated, comfortable to use. They reduce the medication cost. They definitely have better outcomes, and there is no washout effect because you don't have to wait for 15 minutes, 5 minutes between 2 drops. Topical NSAIDs and corticosteroids are often used together to control post-op inflammation. The combination of nepafenac and dexamethasone in the post-op regimen definitely brings down the inflammation and the risk of macular edema. Nepafenac penetrates the cornea well. It is converted to amphenac by the tissue hydrolases, and amphenac is the active drug which inhibits both COX-1 and COX-2 enzymes. COX-2 is the one which is predominantly present in the retina, and amphenac has got a good strong efficacy for COX-2. It blocks the inflammation-mediated barrier, blood-retinal barrier, and thus inhibits the occurrence of cystoid macular edema. It compares well to ketorolac and bromfenac. We now have the advantage of nepafenac in 0.3% concentration. The reduced particle size compared with nepafenac 0.1, it increases the surface area for dissolution. There is an added guar component, which is a retention agent, which enhances the bioavailability of nepafenac in the eye, and there is this convenience once a day dosage. There is clinical evidence to support that it does suppress ocular inflammation, pain, CME, and it is well tolerated compared to the predecessor nepafenac 0.1. There are increasing reports of intracameral antibiotic use during cataract surgery, and there are reports saying that they bring down the risk of end-off almost 3.5-fold. However, it is still not a universally accepted practice because of fears of dilution error, toxic anterior segment syndrome, hypersensitivity reactions. This report by American Academy of Ophthalmology showed that though we all use NSAIDs post-surgery, they do work in the immediate post-op period, but we're not very certain that they help in the long term. To conclude, the fixed dose combinations are therapeutically equivalent to the conventional separate dosing with moxifloxacin and dexamethasone. NSAIDs do help in the immediate post-operative period, and they can be used as long as 2 months post-surgery in patients who are at high risk, especially diabetes, and whenever there's been an intraop complication. The final answer regarding the optimum antibiotic prophylaxis is elusive. It will depend on the changing bacterial sensitivity patterns, the emergence of new pathogens, the advances in antimicrobial therapy, modes of delivery. We all need to be vigilant and to keep pace with the newer developments happening. Thank you.
So that was a presentation, but Dr. Hijab, what do you think about dropless cataract surgery, would it be the future of cataract surgery, or we still may have to require eye drops like these fixed combinations? And the second thing is the fixed dose regime of antibiotic for so long post-operatively really required? Or
what these people recommend is actually they tell you that you use 4 times a day for 2 weeks. Thereafter, you stop and you just continue the NSAID for 4 weeks. So they don't recommend that you continue or taper the antibiotic combination for over a month. And because their formulation is effective, it works. Maybe in our context, we may need to, if we see a breakout inflammation after 2 weeks or 3 weeks, we may need to give something like a standalone prednisolone acetate, if the inflammation does break out. And at least in my practice and in the Indian practice, dropless cataract surgery, little difficult for me to accept. I think it's better to be safe than sorry, because, if there is endophthalmitis, I would rather put the drops than, lose the eye.
so I'll ask Dr. Sean Chinchole to introduce the last speaker of today, Dr. Parul Shah.
Yeah, we welcome Dr. Lahane sir in our course. I can see Dr. Lahane here. Welcome, Dr. Lahane sir. And
welcome, sir.
All the best.
Yeah.
Welcome, sir, respected Lahane sir. And it's been great honor to introduce Parul Shah. She is a national and international faculty and a best teacher. It's great to be with her as a faculty. And today's topic is unusual complication in phacoemulsification surgery.
Thank you, Dr. Sean, for such kind words. At the outset, I would like to thank Professor Lane, Professor Ragini, MOS and BOA, all the committee members for having such a fiesta of scientific material for four Sundays with tireless work. Now, not taking before much time, I'll start with my video. You all can see in the screen that this doesn't look very difficult cataract surgery at all. Of course, there is a nebulomacular opacity in the center. And if you see from here, around from this at the periphery, there is a corneal opacity, but there was no thinning and there was no active inflammation or anything. Patient had a past history of redness of eyes around 15 years back. So I thought of going ahead with cataract, and I thought this was the right place here to start with the main incision and see what happens. Can everybody see the video? Yeah. Is my sound clear?
Yeah.
Okay. So this was a routine phaco. It was a hard cataract, but it went very smoothly. And there was no problem at all. I was concentrating more on a nucleus part rather than my incision. And you can see what has happened. You can see here the cornea has given away and it started leaking because it was a little degenerative cornea. So I started doing IA, but then the chamber was collapsing. So I didn't want it to have a PC tear. So I thought I'll take a suture, and you just see it was such a fragile cornea that the moment I started taking suture, it started giving away more and more. And then I had taken 2-3 vertical stitch. Then there was a tear, bigger tear. So I took horizontal stitch also. I just somehow wanted to stop the leakage from a main wound so that I can do an IA. And you can see I'm taking a horizontal stitch also. And you can see that how friable the cornea is. It is given away. It was not that I'd used much phaco power or something, because if you see, even the side port has enlarged. So then I closed it, I could manage it. And then I thought not to open the main wound, and I injected IOL from the side port. And you can see that even side port is given away. So I sutured both the side ports because both the side ports were leaking a lot. I could not do close by hydro. And I thought I'll put an air and see how it is. And you can see that it was the main wound was leaking. So I decided now what to do next. Now, being a cataract surgeon, I didn't had an amniotic membrane in the OT ready. So then but I could not leave it like that also. And more suturing meaning more friability of cornea and it will gape. So I thought and decided to do a conjunctivoplasty. So you can see a cataract surgery landed up in a conjunctivoplasty at the end. So I just did the peritomy in that near the area of a main wound with 2 millimeter both extra on both the sides, and then gave the vertical cuts and then pulled it over the incision little bit more on the cornea side and took an horizontal stitches and anchored it to the healthy cornea, which was in the around 3 to 4 millimeter inside the limbus. So after that, I started injecting and saw that there was no leakage. And of course, whatever the side cuts were taken, I took an incision here also. And here also I taken a side cut of peritomy to pull the cornea, conjunctiva on the cornea. So finally, I could close the wound. And this conjunctivoplasty worked like a bleb of a trabeculectomy. So I was happy that at the end there was no leakage. So, you know, one thing I've learned from this is that whenever you have a corneal opacity or some history of infection, instead of taking a corneal incision, it is better to take a sclerocorneal incision in the phaco or do an SICS. But you should never take a limbal or a corneal incision. This is the second case. It was a hard cataract, nucleus grade 4 brown cataract. I was doing a direct chop with high power of phaco. And it was going very smoothly. I could have a first crack immediately. I was doing a direct chop technique. And I was using my other hand with the chopper to chop it so that I use less phaco power. I was fitting in all the small lens particles, which were very hard. Everything was going very smoothly, and just see what happens now when I'm fitting it with my chopper, which must have touched the phaco tip, and just see here what happened. The chopper started breaking off. So I thought it was still hanging on. So I just thought, you can see that how it has become the exactly the opposite way. So I thought I will remove the chopper slowly and see what happens. It was just removing it, it just gave off. So luckily it was near the wound. So I put a viscoelastic and removed it with the McPherson. But one has to be very careful because this can happen when you are removing your last piece of hard cataract also, and it can disappear through the zonule posteriorly also, or you can have a PC rent also. Now here, nowadays we all are using preloaded IOLs, and we don't check, our assistant loads it because it's a preloaded, they have to just put a visco or a saline. I injected it, and of course it didn't open it properly. So, and I normally do a hydro injection of IOL, but then with the other instrument, I rotated it and it became straight. But you could see that there was a chip. The optic had chipped off. Only thing to take care is that whenever you have this, there's no need to exchange the IOL because it was only the optic which was chipped. But then put the chipped area into the superiorly. So it gets covered with your lid and you don't have photopsia. So one more thing we have to take care in this cases of preloaded IOLs, that we must check, even if it's a preloaded, we must check it before closing the cartridge under the microscope that it is not moved, because then you can prevent such complications. This is another case where you can see I was doing an IA and the whole post capsular bag came in my IA port. So before removing the irrigation port, you should put an AC maintainer so that the zonular dialysis does not increase, because it was a small zonular dialysis here. And instead of putting a foldable, you can, if you have a 3-piece foldable, you can put, but I didn't have. So it is better to put a PMMA instead of putting an ECR ring and then putting a foldable IOL. I decided to put enlarge the incision, put a PMMA lens, which I had ready, and rotate the loop such a way that the loop remains in the area of the zonular dialysis. So then there is no need of putting an ECR ring if the zonular dialysis is small. And preferably put an IOL under saline so that you don't have to go behind the bag to remove the visco and increase the zonular dialysis. Thank you for how do I stop sharing now? It's not happening.
Just click on the top.
Yeah, sorry, yeah. Stop share, yeah.
Yeah.
Sorry. Yeah.
So Dr. Parul, it was great, and really some learning points we got from your videos. And overall, I thank each and every speaker. The presentations were above average, and definitely everyone had some take-home messages from each presentation. Pahuja sir, concluding remarks from you, and Dr. Manish Shah.
Yeah, I mean, Dr. Parul Shah very nicely presented all the complications, and as it is said that, you know, I mean, if you operate on a cataract and if you don't land up within a complications, that means you have not operated the cataract. It's very well take-home message is given, and Dr. Hijab, your presentation was very nice, and I think what you really insisted on, that the post-op CME which you use an NSAIDs and stop an antibiotic, and very well point which has to be taken home is that please don't taper the dose of an antibiotic. This is the only way where we just, you know, get a resistance to all the drugs. So either you given a full dose of an antibiotic and then stop it, because then you are not worried about an infection. And I mean, Dr. Manish, can you can we hear you now?
Am I heard now?
Yeah.
Okay. Sorry, at the end of the
Manish,
session, my mic started working now. So excellent presentations, and Parul, I really enjoyed all your scary things happening to you in the OT, and your case where you had the incision just opening up. It looked, you know, we have similar experiences sometimes in patients who have undergone RK. But this patient, there was no indication that this thing can open like that. And unless because you showed, we believed, otherwise it is really very difficult to believe. So thank you for sharing such an excellent case. And Dr. Pankaj Lande's technique is extremely interesting. And I think that it should be carried forward. And I think it can really change the whole scenario of how we protect the endothelium. It really works. It will be great. I'm looking forward to that. On the whole, everything was very interesting. Thank you very much.
Thank you, everybody.
Thank you, everyone.
Thank you, everyone. Thank you.
Thank you.
I hope to see you soon. Take care and stay safe.
Hello. Hello.
Good afternoon, Maniyar sir.
Good afternoon, Maniyar sir. Good afternoon, Dr. Pahuja.
Hi. Parikshit, hi. Pahuja sir. Vaishal,
Hi, sir. Hi, Preetam. Good afternoon.
Hi, Dr. Preetam.
Can't complain.
Good
Life is
afternoon.
good.
Wonderful session. I was seeing all the lovely videos. Fantastic. Vaishal and gang.
Good afternoon, Parikshit sir. Good afternoon, Preetam sir.
Good afternoon.
Next one, we are now in the free papers.
Hi, Dr. Sumit.
Is it the free papers?
Yes, sir. Yes, Ranjit Maya sir,
Sumit?
yes.
Yes, sir.
This is the free
Great.
paper, yes.
Yes, sir.
The free paper awardees.
Should we start, Parikshit sir?
Yes, I think
Should
we
we
should
start?
start.
Please go ahead. I think I can see Sir Lahane sir, but Ragini madam is not yet joined.
They are in the ARC webinar.
Okay.
So, good afternoon, everyone. And today we are here for a special ceremony. For last 3 Sundays, we have been doing free paper sessions, and almost 17 free paper sessions have been done. This time we got more than 200 abstracts. We selected around 157 to 160 abstracts, and out of them, from each session, one winner was chosen, and all of the 17 yesterday they participated. And judging was done by Dr. Ranjit Mania sir, Karandikar sir, Pangarkar sir, and Nikhil Gokhale sir. And from those 17, we have chosen the best of the best 3, and they will be presenting today here in the main conference. So, with the permission of the chairman, can we start the presentation, sir?
Yes, please do.
So the first is Dr. Zain Khatib. He is the winner of Dr. T.P. Lahane Award of BOMOS Focus. Very congratulations, Dr. Jain.
Thank you.
Zain, hats off to you.
Thank you, sir.
Lovely.
Thank
Keep up the good work.
Congrats, Dr. Zain.
Thank you, sir.
He does the standalone practice and in a single specialty, and he did a very good study, and he presented also very well. So all the judges gave him the maximum marks, and he is the topper of us.
Dr. Zain also has been consistently winning awards at the MOS conference. Because last 2 years when I was scientific chairman, I know giving him many awards. Congrats.
Sawant,
Thank you, sir.
Pritam, if it was like that, पहला बोलना था ना, so we would have given another one a chance here.
So neutrality.
अच्छा.
MOS का award sir अभी तक मिला नहीं है because of the delay in the conference. Hopefully this year.
Yes.
Ravi Jiti. Then over to you. You can make it full screen.
Okay. At the outset, I would like to thank BOA wholeheartedly for recognizing my study and awarding it to all the judges, to the organizing committee, everyone. So this is the 3rd time I'll be presenting this. And since, it's not going to be a competition anymore, I may, be presenting it slightly differently. So my study was basically another study, just like a structure function correlation between an OCT machine and a perimetry device, which has already been studied extensively for glaucoma diagnosis and progression before. But what we did is we used the octopus perimetry this time. And although octopus perimeters are standard perimeters, but their use has been underreported due to the widespread monopoly of the Zeiss Humphrey, which is most often used for research purpose. What makes the octopus so special is that it's got a G strategy, which doesn't just randomly test the points, but it tests these points along the RNFL bundles. And it gives double the points in the macula, which are more susceptible to glaucomatous damage. When you talk about the OCT devices for glaucoma analysis, the OptoView and the Zeiss Cirrus have been time tested for glaucoma, but there's not much literature on using other OCT machines for glaucoma. So in our study, we aim to compare the structure function relationship of corresponding RNFL thickness by a new SD OCT machine versus the octopus perimeter, a software called as cluster analysis in normal and glaucomatous eyes. So the machines tested are the octopus 600 perimeter versus the Octopol Revos 60 OCT, which is by My Healthscape. So in the octopus perimeter, we took a specific software called the cluster analysis. Now, this cluster analysis probably may not be familiar with everyone. What cluster analysis does is it categorizes all these points into 10 RNFL sectors, into 10 RNFL clusters, and the mean deviation in each of these RNFL clusters is averaged out and you get a single value. So you basically get 10 mean deviations for 10 RNFL clusters. And if you look at the Revo OCT machine, it also gives you 10 OCT RNFL sectors. So what we did in this study is we tried to spatially correlate the RNFL sectors on OCT versus the clusters on perimetry. And we tried to see if these match. So we, try to identify which each one which fibers each one supplies, and this is what we did. And so what we did is we numbered all the sectors and clusters sequentially, starting from the nasal side. And just to give you an example, so if you take sector 8 and cluster 8, so in this example, you can see the OCT is telling us that the RNFL thickness of sector 8 is 97 microns, whereas the cluster analysis is showing 4.5 diopter mean deviation in cluster 8. So this was the correlation, and this is what we tried to test. So we took patients aged between 18 to 70 years prospectively who needed perimetry and OCT testing. The patients were divided into cases which were glaucoma eyes and the normals, which were the controls, which were the normal eyes. And any patient with non-reliable perimetry, poor OCT quality scan, and other coexisting pathologies besides glaucoma were excluded. And all patients underwent detailed clinical and glaucoma evaluation, and the glaucoma was defined as per the previous literature. So the primary outcome measure was to test the correlation between each OCT sector and the corresponding perimetry cluster. And this was given by Pearson's correlation coefficient. More than 0.6 correlation was considered strong, 0.3 to 0.6 was considered moderate, and less than 0.3 was considered weak. We also wanted to compare the strength of association between each OCT sector and corresponding perimetry cluster. And this was given by linear regression analysis and presented as beta coefficients. The secondary outcome was to see the predictive value of each OCT sector. So what is its probability of getting a significant field effect in the corresponding cluster, and what is its ability to predict the occurrence of glaucoma? And this was done by logistic regression analysis and receiver operating curves. So when we look at the results, we had 100 eyes, out of which 52 were glaucoma and 48 were normal. Now these eyes were matched in every way except the age. So age, there was a significant difference between the two, where the normal eyes were younger as compared to the glaucomatous eyes. And this is a table showing my primary outcome measures. So on the left side, we can see the correlation analysis. On the right side, we can see the linear regression analysis. So we can see that sector 2, 3, 4, 7, and 8, they all showed significant correlations, out of which 3, 4, and 7 showed strong correlation, whereas sector 2 and 8 showed moderate correlation. And if we look at the association along with these 5 sectors, even sector 9 showed a strong association. The strongest association given by linear regression was in sector 3, which tells us a 2.71 micron reduction in RNFL thickness is seen with a 1 mean deviation increase in the corresponding cluster. Now, the secondary outcomes, the receiver operating curves, they tell us, a cutoff value for each sector, how sensitive and specific it is to pick up a significant visual field effect and to predict glaucoma. So again, these 6 sectors, 2, 3, 4, 7, 8, 9, these all showed significance, out of which sector 7 and 8 showed the strongest sensitivity and specificity to pick up glaucoma and also to pick up a significant field effect. So basically what our study showed is the sectors 3, 4, 7, 8. These actually constitute the arcuate fibers. These showed strongly significant results in terms of correlation, association, and predictive value for glaucoma. The sectors 1 and 10 are the nasal radiating fibers. They showed no correlation, while as sector 5 and 6 constitute the papillomacular bundle. These also showed no correlation. So out of the 4 sectors I spoke about, the inferior arcuate fibers, that is sector 3 and 4, they showed the strongest correlation and association with the corresponding field effects, while the superior sectors 7 and 8, they showed the strongest predictive value for glaucoma. So almost 80% sensitive. So what we could say is that a sector 7 value of less than 106 microns and a sector 8 value of less than 130 microns was highly suggestive of glaucoma as per this study. So to conclude, RNFL thickness on the Revo 60 correlates well with visual field analysis on octopus perimetry, and the machine is capable of independently and accurately predicting glaucomatous visual field effects and glaucoma diagnosis. So I thank you, and I would really like to acknowledge Sengupta Research Academy and Dr. Sunny Sengupta for helping me with this study. So as Dr. Sumit Lane mentioned, that I am into private practice and have my own solo practice. So, research is something that doesn't come naturally to us, but because of SRA, I really, managed to get all this data and analysis. And for all private practitioners out there who want to do research, and, it's not impossible to do a proper good study with good methodology, because we have, Sengupta's Research Academy, and, it really helps. So thank you.
Great. It was a nice paper, Zed.
Thank
I
you,
think,
sir.
in today's times where, where time is so precious and important, to get these kind of studies correlating perimetry, which is such a laborious investigation versus an OCT, and have this kind of a scientific correlation to show that you can pick up glaucoma and treat it even based on OCT. I think this is definitely a good study. Yeah, Dr. Parikshit.
So if somebody doesn't have both the machines, if they have only one machine, is that good enough to pick it up?
As per the study we have done, it's kind of saying that it can be used to pick up. So what we did is we wanted to test the OCT because it's untested versus perimetry, which is tested. So our study kind of says that you can use the OCT individually also to pick up, even if you don't have the perimetry, based on the results.
So those with OCT can rest, be assured that it will give almost equally accurate results.
I just have a question, Zain. Why were the patients not matched for age?
Sir, the matching of the patients for age is really difficult because most of the glaucoma patients are bound to be older as compared to normals, because it's not like we selected normals randomly. They were patients who needed perimetry and were found to be normal also. So it's not like we specifically selected. We prospectively selected normal and glaucoma, and those who turned out to be normal were actually included, and they turned out to be younger.
It's basically glaucoma versus glaucoma suspect.
Right, exactly.
Sunny wants to make a point. Please unmute yourself.
Yes, hi everyone. So I think to answer Dr. Parikshit's question is a great question. And if somebody has a thickness of less than 105 microns in that sector 7 and less than 130 in sector 8, then there is 80% chances that he has glaucoma. So that is pretty much sort of the one line take home if somebody is only using this machine for detection of glaucoma.
Right.
Thank you.
Thank you, Doctor.
Thank you, Sen Gupta, sir. That was really can say that your academy has benefited all. Like we are one of them, and we keep attending your lecture. And thank you for being there for us and keep motivating through your emails and your lectures.
Yes, please keep up the good work.
Thank you.
Move on to the second, first runner-up. Basically, the first runner-up is Dr. Saili Garge, and she will be talking about her next generation cross-linking calculator for titration of ultraviolet energy in keratoconus. Dr. Saili, can you introduce yourself in one line and then start?
Yes, sir. I am Dr. Saili Garge. I am a cataract and refractive fellow in Narayan Netralaya, Bangalore. So today I'll be presenting a new application which we have devised for energy titration for the cross-linking of thinner corneas. So first of all, good afternoon, everyone. I would really like to thank all the judges for appreciating my presentation. And I would like to start. In the current time of COVID-19 pandemic, there is a paucity of corneal tissue. Thus, there is an increased need for cross-linking to save the thin corneas from progressing further. So what are the treatment options available to us? The current treatment modalities have been previously well established. A simplified 5-point management algorithm for keratoconus is used in current practice. A 18-year-old male patient with chief complaints of frequent change of glasses and diminution of vision in both eyes. His best corrected visual acuity was 6/24 in the right eye. On slit lamp examination, ectasia and both stria were present. No scarring was noted. His retinoscopy showed scissoring reflex and high cylinders in both eyes. His topography showed advanced disease with thinnest corneal thickness of 390 microns. So how do we proceed in this case? Do we go ahead with standard cross-linking in this patient, or do we post him for keratoplasty? So this led to an idea floating in our minds. Is there a simpler way to titrate the energy and time? Our team of researchers have proved an algorithm which predicts the biomechanical effect of cross-linking by customizing the UVA fluence to the corneal thickness after taking various parameters into account, like the UVA intensity, the riboflavin concentration, and the time, and concluded that cross-linking is more dependent on the duration of the UVA light than the overall applied UVA fluence. Thus, we developed an application known as the NXT UVA calculator, which gave us the fluence time for different corneal thickness, which can be easily used by the clinicians. This application gives us the fluence time according to the epithelial of corneal thickness and to its corresponding UVA fluence time at 3 milliwatt per centimeter square and 9 milliwatt per centimeter square. So how did we manage our patient with advanced keratoconus having thinnest corneal thickness at 390 microns and epithelial of thickness at 340 microns? These values were entered in the application, which gave us the UVA fluence time of 21.95 seconds at 3 milliwatt per centimeter square and 7 minutes 30 seconds at 9 milliwatt per centimeter square. 0.1% riboflavin drops were instilled every 2 minutes for 20 minutes, followed by UVA light for 7 minutes and 30 seconds at 9 milliwatt per centimeter square. Thus, the UVA fluence time was customized according to the need of the patient. We studied 50 eyes of 45 patients of progressive keratoconus with documented progression, total corneal thickness of less than 400 microns, and no scarring. Patients having active ocular surface allergy, corneal scarring, previous history of collagen cross-linking, and pregnant patients were excluded. All the patients were assessed pre- and post-operatively for the surgical outcome. Pre-operatively, the corneal topography, epithelial mapping, and specular microscopy were done. NXT UVA algorithm was applied and cross-linking was performed accordingly. At 1 month, 3 months, and 6 months of follow-up, the best corrected visual acuity, corneal topography, specular microscopy, and anterior segment OCT were repeated. Demarcation line was documented in 65% of our patients at the end of 1 month. There was no significant haze noted on pentacam densitometry and clinically as well at the end of 6 months. There was no statistically significant change in the endothelial cell count pre and post procedure. None of the patients had loss of lines on the Snellen's chart. The efficacy was established by a stable keratometry at 6 months. Polarization sensitive OCT, which helps us to study the collagen orientation and density in cornea, showed either the collagen orientation was better or there was no change post-procedure. 65% post-op patients had no biomechanical weakening and 35% patients showed stiffer biomechanical response. So what we saw was there were good clinical outcomes and with stable topography, presence of a demarcation line, and no clinically significant haze. To conclude, what was known earlier was that standard cross-linking is not possible in treating the keratoconus patients with thinner cornea. Various alternative treatment options are available, but they have their own limitations. Our innovative app removes this barrier of 400 microns while still respecting the safety restrictions. Our calculator is a simple and freely downloadable application for everyone's use. This application will be an invaluable tool for delaying the need for a transplant in thin cornea. Long-term follow-up and patient cohort are some of its limitations. This application can be downloaded by scanning the barcode. Thank you so much. Thank you, sir.
Great, very nicely presented, Dr. Saili.
Thank you.
You did mention in your last slide that a lot of long-term follow-up will be required. So
Yes.
what is the mean follow-up you have on all patients? Probably you can give us a range also.
So right now the study is still an ongoing study. So we are actually doing the study since 1.5 years, but we have lost few patients in between due to COVID. So right now we have done the statistical data analysis of 6 months as of now.
Okay.
And it's still an ongoing study. We are about to publish a paper maybe in couple of months.
All right. No, very, very well done.
Thank you.
Congratulations.
Thank
Very
you.
good study.
You can stop sharing your screen, Dr. Saini.
Yes, yes, yes.
And we have a second runner-up here now. Is Dr. Monisha Apte.
Good evening, everyone.
And hers is unusual case of metallic intraorbital foreign body. You can start sharing your screen.
Yes.
So, sir, we had a lot of case series, case reports, original studies, and even case reports also. So this is one of the case report which has superseded the rest of the case series and other. So we can imagine how great it is, and it was done here in the Sion Hospital. Now,
Yes.
Dr. Monisha presently is in Delhi, correct, Dr. Monisha?
Yes, sir.
Please start your presentation.
Good evening, everyone. I'm Dr. Monisha Apte, and thank you, BOA, for giving me this opportunity to present this case. Also, greetings from our department to all the respected judges. So I had done this case with my mentor, Dr. Nena Poddar, and Dr. Shinde ma'am. So I'll be presenting an unusual case of metallic intraorbital foreign body removal and integrated approach. So a 16-year-old male had been referred from a primary health center to our casualty with an accidental trauma to his right eye with his own kada, which was a metallic wrist brace while playing volleyball. So while ducking the volleyball, he accidentally hit his eye with his own hand. And then patient came to our hospital with an intact brace, which was stuck firmly below his right eye since 12 hours, causing pain and swelling. So as we can see on external examination that the end of the kada was seen entering through the lower lid, causing a linear 3 cm by 1 cm entry wound with surrounding soft tissue swelling. The other end of the brace was seen resting over the skin temporarily. So the vision of the patient was 6/6 with a near vision of N6. There was no apparent globe rupture on examination. The pupils were normal sized, reacting to light. Ocular motility was painful in the inferior gaze. However, it was full and free in all other gazes. Fundus examination was within normal limits. There was no infraorbital nerve anesthesia, and palpation of the bony orbit was painful because of the kada. So an X-ray orbit was done for screening along with a CT orbit and a 3D reconstruction of the midface, which showed a linear undisplaced fracture in the lateral wall of right orbit. As you can see that the foreign body was about 15,000 Hounsfield units, which was lying along the floor of the orbit, and the end of the brace was impacted at the junction of the floor and the lateral wall of the orbit. So the 3D reconstruction of the midface showed the orientation of the foreign body with respect to the surrounding structures. So we braced ourselves to remove this metallic brace under general anesthesia with plastic surgeon and ENT surgeon on standby. So what we had done initially was we extended the entry wound like a subciliary incision for a better exposure. With blunt dissection, we dissected the shaft of the foreign body from the floor of the orbit and periorbita. The difficulty faced in this case was to remove the foreign body in toto, which was not possible because the knob was impinging at the junction of the lateral wall and the floor of the orbit inside the bone. Also, the foreign body could not be pulled out by any force because of the restriction of the movement by the zygomatic bone outside. Thus, removing it would have caused damage to other structures. Hence, we decided to cut the foreign body into two halves using an H-rod cutter. An H-rod cutter is an instrument used in orthopedic surgeries for cutting K-wires and Shan's pins. So by cutting the foreign body into two halves, the stuck fragment could then be easily pulled out from the orbit as we got a vector to pull it so. So this was the part which was lying inside the orbit, and this was the knob which was stuck inside the bone. So the knob was measuring roughly around 5 millimeters. On inspecting the cavity after removal, we found a circular defect in the lateral wall of the orbit. Also, there was a unicortical fracture in the inferior margin extending up to the infraorbital foramen. So we took a plastic surgery consultation on table where we decided to manage the fracture conservatively. The infraorbital nerve was intact. Force reduction test was normal for all muscles, especially the inferior rectus muscle. The wound was thoroughly cleaned, and the periorbita and orbicularis was closed with 6-0 vicryl with the skin closure done with 6-0 ethylone. Post-operatively, the patient had a best corrected visual acuity of 6.6 with a near vision of N6. The sutures were intact. The wound was clean with no oozing or bleeding from the wound. The ocular motility was full, free and painless. Hence, we put the patient on an oral antibiotic cover and non-steroidal anti-inflammatory drugs. So we can see that ocular injury is a major cause of treatable visual impairment and blindness. Sports and recreation itself account for about 37 to 52% of ocular injuries. These injuries mainly affect young children in 58 to 70% of cases. So in literature, there is a table which shows sports classified as high risk, moderate risk, and low risk of injuries, where in our case, volleyball comes under moderate risk of ocular injuries. These are certain signs and symptoms requiring immediate ophthalmic referral, where in our case, an embedded foreign body was the reason which prompted emergency removal. How to manage such cases? Using protective gear during playing is mandatory because 90% of injuries is preventable by doing that itself. However, in our case, this would not have been possible because such injury was rarest of the rare case, and the impact by which the patient was hit was very hard, because of which the entire kada got stuck into his eye. However, while playing, if we don't use ornaments, then definitely such injuries can be prevented. Also, we have to use multiple specialties of expertise in tertiary referral center because each case is rare in presentation, and for every individual, such approach has to be tailor-made. Also, prompt and effective management with removal of the foreign body at the earliest is mandatory because this will prevent complications such as blindness, intraorbital and intracranial infections. What was unique in our case? Despite the foreign body being so close to such important structures around it, there was no damage to vital structures. The patient possessed good postoperative vision because the optic nerve was intact. Also, there was no globe rupture. We adopted a multidisciplinary approach for removal of the brace. Also, removal of this brace in this case was challenging because of its peculiar shape, lodgement of the tip deep within the bone, the proximity of the kada to the globe and surrounding structures and sinuses. Thus, the take-home message in my case is the effectiveness of timely intervention using multidisciplinary approach in a tertiary care center, which will help aiding better postoperative cosmesis and visual outcome. These were some other examples which were managed in our case, where in this case, during Diwali, the patient got hit by an acrylic foreign body by bursting cracker in a soda bottle, and thus the eyeball got displaced in the maxillary sinus. Thus, with the help of ENT, we put a Foley's catheter and brought the inferior wall of the orbit up by inflating it so that the floor remains intact. So this is how ENT and plastic surgery played a role in this case. Similarly, in the other case, the patient got stabbed by a knife, which caused this knife traverse till the other orbit and cutting the optic nerve of the other eye. So we used an endoscopic approach for removing the knife, and thus the vision could not be salvaged. However, the knife was safely brought out of the orbit by not damaging other structures. So thank you.
A wonderful case presentation.
You can stop sharing the screen now.
Very nice penetrating ocular trauma and ocular, traumatic emergencies is always a very interesting branch of ophthalmology. It can, it can spring a lot of surprises and can bring out the surgeon in you. So nice case, very nice, well done.
Thank you.
Monisha, this was a very good case. Very good case. Appreciate it. Very good case.
So, since all the office bearers are here, with the president, secretary, and Lane sir, we can virtually at least present the certificates to all our winners. So, Sai sir, ready?
I'm showing up.
Yeah.
Sai is like a magician who conjures up things.
Amar is there?
Yeah,
Dr. Amar?
Yes, we can see him. He's there.
Dr. Amar is there?
Dr. Amar sir is there, sir.
So this is the second runner-up award of Dr. T.P. Lane, presented to Dr. Monisha Apte by Dr. Parikshit Gupte sir, Pritam Samant sir, Lane sir, and Swapnil Samant sir. Congratulations, Dr. Monisha.
Thank you, sir.
Great presentation. Keep going.
It was not possible without my department, without guidance of my mentors. So, yeah, thank you.
Then next certificate, sir. So the first runner-up of Dr. T.P. Lane Award is Dr. Saili Garge for her innovative study on keratoconus and cross-linking, and her virtual certificate is presented to her by the MOS and the BOA President Dr. Parikshit Gupta sir and the Preetham Samant sir. Congratulations, Dr. Saili. Very well done. Keep it up.
Thank you, sir.
Congratulations, Dr. Saili. Congratulations.
Thank you, sir.
And the winner, please. And the Dr. T.P. Lane Award for BOA 2021 goes to Dr. Zain Khatib for his innovative paper on the study of OCT and perimetry, and this certificate has been presented to him, all our office bearer and Dr. Lane sir. Congratulations, Dr. Zain. Very good study. Congratulations. Very well done.
मैं पेमेंट में जाता हूँ. पेमेंट में जाता हूँ. पेमेंट में मैं
had all India participation here. We had got more than 200 papers, 160 presented. Out of that, 17 were chosen best paper, and 3 best of the best have been selected after 3 weeks and multiple rounds. So congratulations to all the winners.
Congratulations, Dr. Khatib, Dr. Zain Khatib. Congratulations, congratulations for all the winners.
Congratulations, everybody.
Sir, and one person we have to thank and congratulate for all this. Sapnesh, you do the honors of congratulating and thanking.
On behalf of the President of BOA and the President of MOS, we thank Dr. Sumit Lane for being the backbone of this free paper session from day one. And not only the free paper session, but also the entire conference. He has been the man behind the curtains, working day and night.
Mohan Rajan.
Thank you, sir. Thank you for all the
Fact hai, but it is a fact that Sumit has worked tirelessly, and all the judges. I must salute all the judges. And Mohan, thank you very much for joining.
Sir, how can the genes
and
go
really,
wrong?
I'm happy that the Ragini, then the Swapnesh, Sumit, Pratham, Parikshit, they are really done wonderful work. Wonderful. I salute you all. And Ranjit, thank you very much for all this free paper session that you did it. Thank you and congratulations to each and every.
Pleasure. Sir, genes cannot go wrong, sir.
Thank you.
Amar, yes, Amar. I was just saying that Amar is not there, so Amar has come. See what happens. Few people are my inspiration. In that, Amar is there. He is my inspiration.
Sir, the work you are doing is something phenomenal, not only for BOA, MOS, but for India as a whole through this Corona war, which you are fighting single-handedly with the government is fantastic. Every time I see you on national television with all these ministers and all, I'm so worried about you. I tell Ragini every time, please be careful because there is so much of COVID all around there.
You're worried for Lane, sir. We are worried for the ministers.
Preetham,
Nothing will happen to
spot
Lane,
on.
sir.
Preetham, spot on.
Hi, Preetham.
Amar, बहुत अच्छा लगा. I am very happy that I saw you. I am very happy. बहुत अच्छा लगा. Kumar, thank you. Thank you very much. I think
Our best wishes for you, sir. We are all with you.
You will have to work, Mohan. You will have to work.
Absolutely, sir. Absolutely.
Thank you. Thank you. Okay. So I think session.
वेळ आहे ना अजून थोडा वेळ आहे की नाही
Mohan,
10 minutes.
Mohan, your team will go first, okay?
Yeah, fine.
After entertainment, there will be science.
Lovely. And what about Prashant Baunkule is there?
Hi, sir. Good evening.
Prashant
Good
is your second team. And Namrata's team will go third. And Kumar, you'll go fourth. Okay, is it okay?
Yeah, it's okay.
Yes, sir.
Done. So let
Saving
me know
the
when we
best
can
for
start.
the last, huh, Amar?
Huh?
Saving the best for the last, right?
Yeah, Kumar's is always the best.
Kumar is always the last.
How are you, Mohan? Amar, all
Fine,
good?
Fine, nice.
All okay.
Amar, have you sold your aircraft yet or you still kept it with you?
What time do we start?
10 minutes.
Okay.
I think 4:30 it is.
Yeah, 4:30. My team members have come. Ashwin, Shail.
Yes, sir. All set.
Kudlu. COVID Warriors team.
Harshul is there.
Shail.
Hi, sir. All set.
The order is exactly the same as
Okay, sir. As
what's there in the booklet.
Okay, sir. Okay, sir.
So I'll go first and followed by Kudlu, then Ashwin, and then you.
Sure, sir. Sure.
I think, can I share my screen once and be sure we are...
Yeah, please do that.
Yes, sir.
Prashant, check kar lena.
Thank you, sir.
Hi, Prashant.
Hi, sir.
एक बार check कर लो, Prashant.
जी, sir. 2 minutes.
We really miss the weekly meetings.
Shit. No. Yeah.
This is a tale of not.
Yeah, is my screen visible now?
Yeah.
Yes.
Okay, great.
Good old Charlie.
Hi, good evening, everybody. Amar sir, good evening.
Hi, Achul.
Hi.
Hi, Achul bhai.
Yeah.
Hi, dear Harshul.
Hi, Dr. Preetham. Hi, Dr. Prashant.
Hi, boss. How are you?
It's been years we didn't meet, no?
Seriously?
Yeah. Missing everything.
It seems like decades now.
Yeah. Every week we were meeting.
Yeah.
Myself, Prashant, Achul, everybody.
Yeah, every
Almost
weekend.
every week we are meeting somewhere or other, no?
Yeah.
Good evening.
Good evening,
Everybody. Good evening. Good evening. Good evening.
Agini.
Good evening.
Good evening.
Hi. Good evening, Amar sir. Good evening, Mohan sir. Good evening, Mania sir.
ખાટલા નો કલર જરા બેકગ્રાઉન્ડ ને મેચ કરીને પેઇન્ટ કરી નાખજો.
Sir, that khatla ka color cannot be matched because I'm staying in the hospital. I'm staying in my office.
I know that. એટલે જ એને બ્રાઉન કલર લગાડી દે. Brown color.
Give me when I give it back.
I'll just check once.
Hi, Harshul.
Hi, ma'am.
Everybody, Harshul has a big program. After the OPL, there is one more big program coming up.
I know. कुछ गाना गाना है वाला. He's threatening to sing.
Hi, Ellen. Hi, Kumar. Kumar, everybody is looking for you, Kumar.
I know. Because at same time, the other hall had the same talk at the same time.
What's new, yeah?
Hi, everyone. Hi, Rupal. Hi, Rupal.
Hi, Rupal.
Kumar boss, can you see my screen?
Yes.
Yeah. Oh, क्या कर क्या रहा है तू?
सर पहले किया करते थे, आजकल सब बंद है.
In today's day, even if you show a normal cataract, that would be like something amazing.
Hi, Shail. अरे कुमार अलग टॉक थे रे, दोनों वीडियो अलग थे. Demystifying short and small. क्या तू सब ढूंढ रहे थे? So everyone, this idea of 4 Sundays, was Preetham and Sapnesh. And this was Preetham's idea because he said then you cannot do justice if you have just one weekend and you cannot have, each session properly. And luckily, because of that, I learned retina.
Ragini, one full week, give them an off for one full week. 1 week holiday for all of them.
How do you know that I am there? They have to give me off for 1 week.
No, you're the boss. Yeah. Hey, Ragini. Give them
Where is
1 week
Kuresh
off.
sir? And you all have given me one big work which I have to start again from tomorrow. Hello, Partha sir. So Swapnesh has been working, and Preetham day, night, and with Sumit and this whole team that Swapnesh has built up, and it's their hard work which is seen here today.
Very nice.
Wonderful, wonderful.
Very nice, Dr. Sapni.
A very good concept, a very good, brilliant idea to have 4 Sundays.
Preetham one morning, he just came and I was doing something, and he talked me into it and I said, yes, I didn't realize what was happening. And Preetham, like, whatever Preetham says, Lane sir says yes. But I think it is a brilliant idea. It's a brilliant idea.
As the 4 Sundays went by, so our sponsorship also went up exponentially. Yeah. So it was all well planned.
Ranjit Babu.
So that is a lot of learning.
Himanshu sir, good evening.
Good evening.
Hi, Himanshu, sir, good evening. Kuresh sir.
Hi.
Kuresh sir, everybody is saying कि कल से ना प्रीतम और स्वप्नेश को छुट्टी दे दो. I said मैं
Sumit also and team JJ also.
But you know what? मेरे को छुट्टी नहीं मिल सकती. आप लोगों ने अमर सर इन्होंने मुझे बहुत काम पे लगा दिया है कि नहीं कल से मुझे मेरा काम चालू हो रहा है कल से.
अरे वाह. Anyway, you can't take rest. You don't take rest anyway.
Please understand one thing, that the logo of the conference will continue till the AIOS conference. So nobody takes leave.
Great idea.
See, my boss has spoken. My actual and real boss has spoken.
Nobody takes
now
leave
everybody knows.
No, not a single day's leave is being sanctioned to anybody.
Hi, Kuresh.
Hi.
Kuresh, adjust your camera. Take it a little up.
Everybody knows now who's the real boss. He has actually
Yes, the real boss. The real boss. Brilliant idea. Preetham, fantastic. Really, hats off to you guys.
Some of these guys are really J, कि साला हमने कैसा नहीं सोचा.
Good evening, Talaivar.
Hi, Srinivas.
Hi, sir. Good evening.
Saliva, yaar, it's saliva.
How are you, Srinivas?
Fine, sir. Thank you.
But I just caught that conversation about the sponsorships going up. So that's going to be a lot of learning. That's going to be a lot of learning.
Preetham Sawant is now becoming Mehta, Preetham Mehta. That is why he started thinking money.
Sir, is he getting married again?
Yeah.
First marriage was in Mehta, no?
Hema is very much here. Don't say it. So this Ruchik, Swapnesh and Preetham, so this Swapnesh and Preetham like they can bring people.
Now Preetham sir is going to operate on Abhishek Bachchan. Now Himanshu sir has already operated on Amitabh Bachchan. Time for Preetham sir for Abhishek Bachchan sir now.
Who's going to operate on Aishwarya Rai?
Nati.
One minute. See, Aishwarya Rai is reserved for Nati. No other person should operate her. That is only Nati can operate.
Preetham has already operated on Aishwarya Rai's brother.
Yes.
Really? Okay.
Nice.
Then I will take care of
coming
Aishwarya.
into the family.
Buckle for RD.
Partha, welcome Partha. Hi Partha.
Hi.
Lovely program.
Vanakkam.
If you're doing it for Aishwarya, it must be a Gucci buckle.
It's 4:30. I think you can set the thing going.
Okay, fine. So first of all, welcome everyone to this Ophthalmic Premier League, which is the BOA MOS Summer Focus Virtual Symposium. And this whole conference, I tell you what, Preetham, Swapnesh, Professor Lahane, and Ragini, and others of BOA and MOS have done so much of work to make this such a grand success. It's ending with the OPL, and finally, Harshal will be doing the great show of his with the singing and everything in virtually. I think the best part about this pandemic is that we are all together, and people who have suffered from COVID or have relatives suffering from COVID can understand the actual feeling of this disease, because this is a really bad disease. And with all this, you can see the fight going on. Saying that, I'd like to introduce, first of all, our judges who are there with us. And we have with us Professor Lahane, Preetham, Parikshit, Shashi Kapoor, Dr. Natarajan, Partha is there, Ranjit Manyar, Rohit Om Prakash, Kuresh, and Rupal. A few words, Ranjit. Few words from you?
Kuresh will accept on my behalf.
Kuresh
will accept on my behalf. That's it. There's nothing more to say.
No, but Kuresh, I thought we'll be talking something about his logo.
For the team captains, just that Kuresh will be doing the accepting.
So this is virtual, no?
Yes.
This is virtual.
Kuresh, anything for your TPL?
Only Bitcoins, huh? Kuresh?
Virtual currency, cryptocurrency.
Virtual currency.
Bitcoins, only Bitcoins.
So basically, what I want to tell everyone here is you are going to have 4 teams. Each team is given 4 minutes. Please stick to the 4 minutes. So you get total 16 plus we'll give another 18 minutes per team. And then we'll ask the judges to decide the best team, the best entertainer, and the best scientific video. Okay, saying that, let's start with the first session and with the first team, which is the COVID Warriors. Before I bring in the COVID Warriors led by Mohan Rajan with Krishna Prasad Kudlu, Ashwin, and Shail, I just want to tell you about Mohan. I mean, he's something different. I think the amount of OPL which he has won is something phenomenal. And he makes all of us laugh. More than anything else, what I see in Mohan is a great human being from heart. And that is his greatest quality, you know. He's a great surgeon, great clinician with many centers, but the heart of his is the best part of Mohan. Mohan, all over to you.
Amar,
COVID Warriors.
Amar,
Take it from here.
Amar, do you know
Yes.
why Mohan is so good? Mohan, you have to tell that, Mohan. Because I supervise his cataract surgery.
Oh, so nice. So Mohan.
Despite that, I'm doing well.
Mohan, all yours, Mohan. Go ahead.
Anyway, let me thank Amar, Lahane sir, Ragini, Preetham, Swapnesh, and the entire BOA, MOS for the wonderful opportunity. And if I win this OPL, this will be my 56th OPL victory. Okay, let's hope for the best. We have got a fantastic team, and we are the COVID Warriors team. And I'm going to show you the introduction video. Give a big hand for all of us. So I'm going to take you through 3 simple points, but which are going to be very, very useful for you guys in your practice. So as you all know, this is a posterior polar cataract. Everybody knows what are the protocols to be followed in a posterior polar cataract. You can see here, there is a pre-existing rent. I'm doing tricot. It's all routine, whether you do limbal or pars plana, but you remove the vitreous first and then remove the cortex first. At the end of it, you need to put a lens, a multi-piece lens. So you can see here, I'm putting a multi-piece lens into the sulcus. But you don't leave it in the sulcus because you don't want long-term UGH syndrome. I don't want the lens to decenter. So I'm just putting that lens in the sulcus, and then I'm capturing this lens into the optic, that is the optic into the capsular rhexis margin. This is called the optic capture. A very, very simple technique, but worth doing it, especially when you're putting a lens, because that will maintain the centration, long-term centration, and prevent the UGH syndrome as well. So put the haptic into the sulcus, and then use a Sinskey hook or a, what do you call a Kelman, I'm sorry, the Lester hook. And you can see here, I'm trying to push that optic back and lock that optic into the capsular rhexis margin. The end point is the ovalization of the anterior capsule. And that is the end point, which means that this lens will not move a micron at all. You can see here, there's a perfect thing, which you can see here. You can see here 2 months, 4 months, 2 years. This patient has maintained very good visual acuity, and the lens has not moved a single well-centered lens as well. There's another patient I've done, a young patient, a girl, about 18-year-old, posterior polar cataract. I always do femto for these patients. And this is all routine. See the femto, the advantage is that you can see here, there is a dense plaque on the posterior capsule. Very difficult to yak these plaques because it requires a lot of energy and very difficult to make an opening as well. So I'm giving you a simple technique of what is called a plaquectomy. You can see here, this is a plaque. I'm using a bimanual. I'm going to use a bimanual technique. You can see here, you can just remove this plaque very beautifully. And this is called plaquectomy. You can remove the plaque without damaging the underlying posterior capsule and goes in a symphony lens. And this patient had 6/6 vision. So this is the patient, you can see here, this is a Envista lens which has got caught in the cartridge. These are the blue cartridges or the yellow card, the green cartridges, the injectors, which I think if you try to pull this lens, the cartridge or the haptic out of the cartridge, it will break. So this which has happened, you can see here, this happened here. I'm trying to pull it out. It has broken. Obviously, I had to extend the lens, extend the incision, take this lens and put in another lens. To avoid this, you can see here another patient with a supraphobe lens. And as I'm putting this, very, very common with the green injectors, the medicinal injectors. You can see here, I'm trying to put the haptic gets caught in the, because there is a very little space between the silicone, this thing. What I'm doing is a ocular episiotomy. I'm just taking a 11 blade and opening up the space between the cartridge and the silicone plug there, or the silicone thing there, and then slowly releasing the haptic outside. So this is very, very important. And this lens can be easily implanted without any fracture, any deformation. And this again is a very, very simple technique, but great results as well. So this is the 4-minute thing, and we have the, what is this? This is the Corona kick. Okay, thank you very much, ladies and gentlemen. Over to our Vice Captain, Krishna Prasad Kudlu, the King of Udupi.
Thank you very much, sir. I'll be sharing the screen right now.
Kudlu, over to you.
Yes, sir.
Yes, sir. Please share the screen.
Yes, sir.
My tie allowed me here.
So virtually you have to, don't see the time, sir.
No, tie allowed me. OPL my tie allowed me.
Sir,
please share the screen, boss.
Like Kudlu, what is the problem, Kudlu?
Sir, just I'm sharing the screen.
Ah,
Sir.
Yeah, you're able to see the screen.
Sir, I think you can tell our next presenter. By that time, I'll share this thing.
No, you already shared. इसको ये वहाँ क्रॉस को मारो, क्रॉस तुम्हारे पास क्रॉस दिख रहा है, उसको ये करो.
Sir, can you able to see the screen?
Yes. आप वो क्रॉस से उसको बंद करो पहले.
No.
Cross it. Close the
to the cross. Go to the cross. Right side. तुम्हारा जहाँ ये है ना, वहाँ से right side जाओ. Cross को.
1 second, sir. Because of the video, I'm just a little bit.
No, Kudlu, you're not understanding what he's saying. He's saying, close.
Stop sharing your screen.
Close this one.
Launch meeting बंद करो.
You can come a little later. We will have Ashwin.
Kudlu, this launch meeting, you will have to close it. Go to this one. Cross.
Close it. Launch meeting, Zoom, cross it. Just press the cross there. This will close down and your desktop will open.
He's not able to.
Desktop is just behind this.
Okay, sir. Next presenter.
Ashwin, can you explain to him, Ashwin?
Yeah, but you'll have to stop sharing your screen.
Yeah, he has to stop sharing. Kudlu.
No, Mohan, listen.
The host can stop sharing Dr. Kudlu's screen. Yeah.
Yes. Ashwin, are you ready?
Ready, sir.
Yeah, please go ahead, Ashwin. Ashwin.
Yes.
Congrats for your wonderful WWCR.
So,
today.
OPL. Thank you, sir, for having me. Okay. So my topic today, which I'm going to talk about, is a traumatic cataract. And you can see this traumatic cataract, a young patient over here who's got a PCR, but we can't see it so clearly right now. But I know that there's a PCR, there's a small opening. More importantly, the young patient. So I'm trying to first remove all the cortical matter that is there. But over here, I can see that all the matter from below, from the nucleus, has gone inside the posterior cavity here. Now I'm making my pars plana entry so I can make sure that I disconnect or compartmentalize both anterior and posterior segment. Now the trick really is very, very important. What Dr. Mohan showed in the first case was so important. You know, one of the first few cases. was to open up this. So what you're seeing here is, even though it looks like it's opened, it's not really opened. It's only an expansion because of the vitrectomy, because of the vitreous prolapsing out. But what I'm trying to do here is the posterior CCC. The posterior CCC is basically to
Can you mute everyone else?
Yes.
Oh, wait.
Some extraneous sounds are coming, please.
थोडासा कमी कर ना हे त्याला इकडे घे तुझे जे 2 कॉलम केलायस ना ते कॉलम इकडे घे त्या कॉलम मुळे प्रॉब्लेम पुढे घेतलं अरे एक मिनिट
Dr. Lane, please mute yourself.
Sorry, sir, sorry.
No problem, sir. Go ahead, Ashwin.
And here what I've done basically is a posterior CCC, because I don't want to place in a young patient a intraocular lens in the sulcus, and I have placed this now because my posterior capsule opening is round and viable. More importantly, the centration of the Purkinje image is right in the middle now, and it's transparent and clear. That was the most important point. And another important take-home message over here is to use a pars plana method rather than using a limbal method for doing your vitrectomy, because doing a limbal method will only increase the size of that posterior opening and you will not be able to do the posterior CCC opening. This is a very simple and easy maneuver to have an in-bag placement of a intraocular lens. Now going on to the next case, which I wanted to show you guys. This is the post-op picture of the same. And here's the next case of a subluxated, traumatic subluxated cataract. And you can see that there is a very small amount of subluxation, but when you go inside, that subluxation starts to disturb you when you're doing your rexis, when you're doing every small maneuver over there. So my trick nowadays has been, and I know it comes from hometown, but not glued IOL. It is actually to start using 4 capsular hooks, not iris hooks, but capsular hooks, to stabilize the bag while I do my phacoemulsification, especially if it is a softer nucleus like this one. I wouldn't say very soft, but this is grade 2, grade 2.5. And once my phacoemulsification is done, while my capsular bag is in place, I'm trying to disconnect or dissociate the cortex using viscoelastic, and I'm now emulsifying and I'm now irrigating all my cortical matter. Once my cortical matter, I like to push my endocapsular ring all the way till when I really, really require it. Do not put in endocapsular ring too early. It does not help. In fact, it only disturbs you more and more. Here, when I have my proper placement of all the 4 haptics, or all the 4 capsular hooks in place, now I place my capsule tension ring, and I like to use this drop method where I'm actually going under the anterior margin and then dropping it in, so that I'm ensuring that all both sides of that endocapsular ring are inside the bag. Now what I'm doing is placing my intraocular lens in the bag. Again, I like to use the drop maneuver. And once it's dialed into place, now I'm very, very confident that this is going to stay. Now I know that my capsule is very weak on the right side over here. And that's why I'm removing all the other 3 sides first to ensure that this displacement does not take place once I remove my this thing. Now I'm first removing the all the viscoelastic matter inside the anterior chamber. This allows me to now, last but not the least, remove my capsular hook on the weak side and ensure that this is completely in place. This is how the case looks at the end of it, and this is what we are made of. And thank you so much, guys.
Thank you very much, Ashwin. Is Kudlu ready, or we go to Shail? Wonderful, Ashwin. Lovely.
Sir, ready?
Kudlu.
Yes, sir.
Yes, boss.
This? Oh, this. Sir, could you able to see?
Yes.
Yes, sir. Thank you, sir. So I think I just need to explain about how exactly we COVID warriors are already making us so much of help.
Volume, please.
All we should thankful to all our friends who have done a wonderful job. Without COVID warriors, I think nothing would have been happened. See, so much of work I think thankful to all our friends, doctors, really struggling.
अलग जज्बा है इनका, समय को रोक रखा है, ताल को मोड़ रखा है, भूखे प्यासे कब से जागे, अपनों से दूर मन को बांधे। न धर्म की दीवारें हैं, न समाज के ताने हैं, बस लक्ष्य है सेवा का, और ये रिश्ते अनजाने हैं। आंखें होती हैं नम, पर हौसले नहीं है कम, इनमें से कोई थकता नहीं।
So this is a case of subluxated lens had come to me with a patient with albinism. So I just gone ahead with the procedure, and with the help of iris repositor, I had opened up the pupil. Then I started with the rexis. Then you could be able to see there is some amount of subluxation. I still continued because the subluxation is 1/4 of the subluxation. So meanwhile, what I did, I stabilized the capsule with the capsule hooks, then gone ahead with the phaco. Just on the safer side, I had put the CTR, then I had gone ahead with the putting the 3-piece lens inside the bag. So we are the COVID warriors. In spite of that, treating the COVID patients, still we are not forgetting about the ophthalmology. This is a case with Marfan syndrome. You could able to see the flap has been already done, thinking that cannot able to successfully done the phaco. So once the rexis has been done, CTR insertion has been done, then could able to, you can see here, the CTR is after doing the capsular rexis, CTR is almost going down. So immediately the CTR has been taken out, then gone ahead with the remaining procedure. So how to, once again, after the phacoconjugation over, because of the nucleus is so soft, then we had continued with the sort of a glued IOL, but haptic also have been sutured with the 80-proline. So why I am showing you this, don't lose your confidence. If at all, if you are thinking that, okay, you are out of your this thing, still be always prepared with the side-by-side options. That is what the COVID warriors always think. Now you can see well-centered IOL. Since we are also a refractive surgeon, I would like to show you some of the cataract surgeon, how can he manage the refractive complication. I've been training a lot of students in and around the world. You could able to see that after the half the dissection is over, the lenticule has been folded here. Nothing to worry. Take the forceps, then try to hold the lenticule. After the proper dissection, you could able to see here lenticule fold. How you do the reverse rexis? You can take out the lenticule, and the procedure is very simple. Come out with a successful smile. Why I'm showing you, it's very easy for a cataract surgeon to do the smile. This is a one more case. One of my trainee, the treatment was done perfectly by the machine. Then he started identifying the layer. He could be able to see that he has done a lovely dissection. Now he is trying to search for the other plane. He could not able to find the plane, posterior plane. That means he has done the primary dissection in the posterior plane. Then I took over. I could able to scratch underneath the cap, then do something sort of a reverse rexis, and lenticule is out. In the end, this is my favorite technique of no dissection technique. Once again, the cataract surgeons always feel to do this without any dissection. After the treatment, go with the micro forceps, try to peel both from the cap and from the bed. It's little difficult. If you do it next day, patient will have a 6/6 vision. So my dear friends, we are the COVID warriors. We can do it. Thank you, one and all.
Thank you, Kudlu, for the wonderful
Also call you the gentle giant there in Udupi.
Yeah. Over to the final presenter in the COVID Warriors team, Shail.
Thank you. Thank you very much. So this was a very, very simple case compared to all the cases that have been shown. 53-year-old male, left eye cataract done in 2017, normal grade 2 cataract, and planned for femto cataract with the toric IOL in the other eye. And there was nothing inside the eye which was examined previously or intraoperatively which would have led to any surprise. So this was the placement axis to be done, 168 degrees, a good capsulorhexis, main incision, and the fragmentation has been done by the femtosecond laser. And we prefer to make sure that the phaco probe remains pretty much in the center. So whatever maneuvers that you want to do it with your left hand, so that the fluidics work best in the center, and that helps in maintaining the iris and the pupil all throughout the procedure. So everything has gone off smoothly, nothing very unusual. A posterior capsule PSC cataract is also part of this cataract, but no plaque or nothing untoward is happening. And cortical removal has been done, nice, perfectly centered capsulorhexis, and it's now for time for the IOL implantation, a T3 diopter thing. And sometimes what happens is that if the IOL is too stiff, or if you notice here, the jerk with which it has been injected, because the actual plate was sitting on top of the optic instead of at the optic haptic junction. And notice what this has created. So now we are in a tricky situation. We have an IOL which is in the back, a toric IOL, all of the procedure is done, and the forceful injection or release of the IOL has led to a posterior capsule rupture extending up to the equator. So there's no possibility of converting this into a posterior capsule rhexis as well. So having taken inspiration from our captain, Dr. Mohan Rajan, we thought, let's think out of the box. And we decided to let the haptics be inside the capsular bag and pop out the optic outside the anterior capsulorhexis, because it was a centered capsulorhexis. So what is known as the reverse optic capture. Here I'm dialing the, making sure that the toric marks are at the aligned axis. While doing that, this part of the capture came out, so recapturing it. So notice here, what you'll notice apart, different from the other capture is that the optic haptic junction will have a broad edge. Always make sure that no vitreous has been disturbed, and for that the best way to identify is to use triamcinolone acetonide. And there was no vitreous disturbance. Notice the broad capture margin at the optic haptic junction. And make sure that the chamber doesn't collapse until the last minute. So with the irrigation inside, hydrate all the wounds. And this is how the patient looked at the end of a surgery, a very stable, centered toric IOL at the desired placement axis. There will, of course, be residual viscoelastic, so mannitol and more anti-inflammatory will be required. Post-operatively at 3 months, the patient is doing very well. He doesn't have any difficulty, and this is the patient post-operatively with a centered, stable toric IOL. So reverse optic capture is a viable option, even for a single piece IOL, in certain special situations like this, when there is a toric and when you've already injected the IOL and you encounter a complication. So thank you so much for the patient.
Really awesome stuff, Shail. Really wonderful. Lovely videos. Thank you very much. And Amar, that is the COVID warriors for you guys.
Thank you very much, Mohan. We have with us, I think, Rohit Om Prakash is there.
Yes,
Rohit,
sir.
Rohit,
Yeah.
we're discussing this point. He's brought up very good about reverse optic captures. Few points from you on it. Any comments on it?
I think it is not as simple as the other optic capture. Here, the size of the rhexis is something which is very important. And at times you are not able to achieve the reverse capture. And you have to bear in mind at times, you know, the myopic shift, slight myopic shift, which he had, is at times more profound also in these patients.
And Partha is there. Partha, what about optic capture? How often do you do optic capture if you have a good rhexis? Or would you shift to an intrascleral haptic fixation or sutured IOL? Partha? Partha is there? Ranjit?
Actually, Kumar I'm sure would like to say something about this.
Partha is not there?
He's there, sir. He's there.
Yes.
He's not talking. That's why I'm asking you.
Talking, sir. Talking.
Partha is there.
Mamta has captured Partha, I think.
Okay. Anyway, so, I don't.
Real reverse capture.
I don't hear. Quresh, any comments from you, Quresh, for this team?
No. This the whole business of capture and all sorts of things is best from Bengal.
Okay, so we'll move on to the next team, which is going to be Kumar Doctor's team, which is the Black Fungus Fighters. So we have there the captain, Kumar Doctor. Then we have with him Harshal Tak, the vice captain, Shreyas Ramurthy, and Sheetal Mahukar. So Kumar, are you ready with your team?
Yes.
Go ahead.
I'm going in first, and it's the right name because black fungus is in, but we are the best fighters. And I'm so glad that this time, there was no entertainment from Rajan. So let's have good entertainment from my end. So I'm going to show you cases which you have never dreamt of that can be done.
Next eye surgery is cast to do. Let's see how the ace them in much our do. Your guts and wits will get you out of the docks. When the going gets tough, think out of the box. System pupillary membrane thick and tenacious. Uncomplicated cataract can be ferocious. Solutions for 8 of us. I was wondering just how bad I messed up.
Measure the corneal diameter. Micro scissors cut off the persistent pupillary membrane. Check for zonular dialysis of 8 o'clock hours. Perform a femtorexis. Create a Hoffman's pocket. Enlarge the rexis. Then perform a bimanual irrigation aspiration. Capsular hooks in place. This is followed by placement of a Sioni ring, the classic railroad technique to ensure fixation of the bag, followed by IOL in the bag, securing the Sioni's ring. Bimanual IA. Let us see the post-op day 2.
My doctor was can give anyone some jitters when the corneal diameter measures barely 6 millimeters. Must encourage. I removed the cataract with a swag, but how on earth I place an IOL in this bag?
The caliper, measure the vertical and horizontal diameter of the cornea, which is 6 millimeters. 2 side ports for better exposure, placement of iris hooks, a microrexis forceps to perform the rexis, and a bimanual IA for cortical aspiration. But to place the lens, now what? So we decided to do away with the haptics. Place only the optical disc in the bag. The tricky part was how to inject the disc into the eye. Only one injector and cartridge really worked. What worked was the sensor injector. This is the loading of the optical disc in the cartridge. The sensor injector pushing the disc ahead and placing the disc inside the bag. This is obviously followed by bimanual IA. Then one can actually notice the disc rotating around in the bag. In this case too, let us look at the day 1 post-op. Notice the disc sitting in the bag.
Again, complex eye surgeries are a roller coaster ride. Boom again, to ace them, you gotta swim against the tide. So muster on your mind to bring back someone's sight. Don't fall, stand tall, come on once again, let's say, Machale.
So friends, that was me, and now we have the next best 3 speakers with unusual cases you would have never seen in your life. Harshul, you go second. Harshul Tuck.
Okay, boss. So, thank you so much, Lahane sir, Ragini ma'am, Dr. Swapnesh, Dr. Preetham, for inviting all of us. So, I'll be showing a case. So, can you see my screen?
Yes.
Yes.
Okay. So, this is a case which is a white subluxated cataract. You can see subluxation is more than 120 degrees, it's almost 180 degrees subluxation. So after making the temporal limited peritomy, stain the anterior capsule, and you can appreciate that the capsule is also fibrosed. So it's difficult to initiate the capsular axis. So I make a nick with cystitome and cut with the micro scissors. I'm going from paracentesis. I initiate capsulorhexis, and once I start from one side, I need to use bimanual method, holding with one forceps and cutting with the scissors. So I use different incisions to, and also we need a good anterior capsule margin so that to use the capsule to stabilize the capsular bag, I need to use capsular hooks. So I need to be very careful that the size of the capsular axis is not too large. So once I finish this capsular axis, I go ahead and put 3 capsular hooks to stabilize the capsular bag. So once we have these capsular hooks in place, our capsular bag is well stabilized to give anterior-posterior stabilization. And after stabilizing it, I start phacoemulsification. So this is 1.8 millimeter phaco incision. Do the vertical chop. Take off this nucleus. This is a white cataract. So once you have this entire nucleus out, and before taking out your phaco probe, you need to be sure that you maintain the capsular bag. So you inject viscoelastic from side port before taking out all the instruments. So these are the last pieces of the nucleus which comes out. I put viscoelastic and come out. So after this, we need to stabilize the capsular bag. So I go ahead and put a CTR ring here. Take off these capsular hooks, and from side port I start inserting the capsular ring. I use a freehand method to insert CTR ring, and also use the Kugelin hook to stabilize it. So, and this is the distal end which goes inside. So once it goes inside, the capsular bag is stable now. Take off this cortical matter which is there, clean up the capsular bag, and now what we need to do is, for long-term stability, you need to put either this, so here I am using a CTS, capsular tension segment, with 90 proline. So I put it in the capsular bag and use the needle to railroad both the ends of the suture. So here goes the first end, and then goes the second end, and once both the ends are out and you tie them, you have a perfectly centered capsular bag which is going to be stable over the years. And nowadays we have started using Gore-Tex also to give longer stability. And after that, I put the IOL in the capsular bag. So here goes the IOL in the capsular bag. Take off all the OVD, close the peritomy, and it finishes the case. So thank you very much for giving this wonderful opportunity. Thank you, Amar sir, for conducting this OPL. Thank you.
Thanks, Arshul. That was fantastic. A crumpled anterior capsule, more than 120 degree of subluxation, and you still could save the bag and yet put a lens in the bag. So that was fantastic. I invite Dr. Sheetal and then Dr. Shreyas Ramamurthy, the star 2 here.
Sheetal, unmute.
Visible?
Yes.
Yeah.
Am I audible?
Yes.
Yes.
Yeah. Okay. Good afternoon. Very good afternoon to everyone, and thank you, BOA and MOS team for having me here.
Not able to hear you.
Is it okay now?
Yeah, better.
Okay, okay. Thank you, MS team, for having me over here. So today I'm going to present a case of DMAC. So we have seen that all the warriors out here are doing a lot of complications, and one of them have sent me this case. And being a black fungus fighter, we decided to do go ahead with this case. So this is a case which you can see that there is a corneal edema. So obviously there is the endothelial decompensation. And as you can see, the case, it looks like an eventful cataract surgery where there's the IOL which is slightly decentered, and we can clearly see a PCR. So this case came to us, and uh, we decided to go ahead with the DMAC, which is the new kid in the endothelial keratoplasty. So the first thing to do is remove the epithelium for better visualization, and then do the Desmet scoring. Now the difference in DMAC and DSEC, a lot of us do it, is the Desmet scoring in DMAC has to be larger than your graft size, because if it is a smaller size, the graft detachment can happen later on. Unlike DSEC, where we generally prefer to do the graft size slightly smaller or equal to the lenticule size. So here we go ahead with our DMAC Desmet scoring, and I like to mark it over here. Once you do the Desmet scoring, you have to make sure that you're not, while doing the Desmet scoring, you have to make sure that you're not damaging stroma, because again, a rough stroma or remnants of Desmet remaining over the stroma can cause the detachment of the graft later on, or having a problem with the attachment. Once you do that, you have to make sure that the whole DM has come out. And the most important step after that is to do the PBI. Now, we don't really need a big PBI with a vitrector, what we generally do sometimes. It's just a small PBI which will remain open for a day or two, because we do the air fill, which remains for a day or so, and we want to avoid the pupillary block. Once we are done with that, I generally remove the visco if I have used, that is the cohesive visco. Then we go to the most exciting part, that is the Desmet stripping. Now, this is very exciting for any cornea surgeon, as well as a very a procedure where the palpitations are pretty high. So I generally take the 9mm or 9.5mm punch just to kind of make a soft cut, and we score it with a blunt Sinskey hook so that we don't tear the edge of the Desmet. After doing that, we start stripping off the Desmet with a tangential force with the Macpherson, and very gently we strip off the Desmet 2/3. Then with the skin punch, or the punch which we get it with the keratoprosthesis, we punch the stroma. This is again very important step which will do a lot of help later on, is to mark the letter. You can mark anything. You can mark L, you can mark S, you can mark F. And you can see from top the L looks proper. From the endothelial side, L looks upside down. After doing this, you you strip off the remaining one, and you stain the Desmet properly for 3 to 4 minutes, because it is very important. Otherwise, you kind of really lose it in the AC while doing the maneuver. Once you take the scroll in your instrument, that is again very important to make sure that your double scroll is up. You inject the scroll inside. Again, this is very different from DSEC. In DSEC, we want a taut AC. Here in DMAC, we need to make sure that after scrolling, we need to have the AC which is shallow and a very soft eye. Like in this case, you've seen it is open like a taco. So once it is open like a taco, you can go inside and put a little bit of fluid, or like what I am doing it from the above, you can just de-scroll it, and you just tap it. Unlike you just tap it from above with the AC much shallower to make it in the center. Once it's in the center, you can put the air bubble inside, and as you can see that L mark, it's correct orientation. This is the end product. So thank you so much. This was a case which was done post cataract surgery for saving the cornea. So thank you so much. And I must say that this is my captain right now, praying to God that our team should win. Thank you.
Thank you, Sheetal. That was fantastic. Now I invite my last player, none other than Shreya Ramamurthy. Shreyas.
Thank you so much, sir. And at the outset, I'd like to thank the entire BOA team for having me over. And thank you, Amar, sir, for including me in OPL. So today I'm going to be presenting a case of very end-stage advanced SJS, which has a dermalized surface. Now, in these very advanced dermalized surface, there's not too many options that we have. Either you have to go in with the very difficult and complicated osteoodontokeratoprosthesis, or you have to do a very prolonged 2-stage procedure of doing a mucous membrane graft, and after the mucous membrane graft, trying to put a K-Pro underneath it. The type 2 keratoprosthesis, which would be ideal in this case, is not commercially available in India, and it is difficult for most corneal surgeons to access. So here I'm presenting a modified technique, which we have now done in 7 cases, and find this quite repeatable and very suitable for these very advanced end-stage SGS, where we are actually trying to use the patient's own pannus as a cover, like you would use the lids in a patient where you're doing a type 2 keratoprosthesis. So here, meticulous dissection is required to ensure that the pannus is lifted as a single piece, and you're trying to dissect out and get the right, identify the right plane. Once the pannus has been lifted off the surface, it's very important that you keep it safe, it's anchored separately, and then you go ahead with the rest of the dissection. Now, the next challenge is going to be to identify the pupillary center, because if your K-Pro is not at the pupillary center, then the purpose of the entire surgery will be lost, as it would not be aligned towards the fovea. So I do a partial trephination to try and remove the rest of the pannus and to actually go down into the cornea. And you'd be quite surprised to see that in these patients, because it was a very advanced toxic epidermonecrolysis in the first stage, that the surface dermalized so rapidly that the cornea is actually quite pristine, and you can easily make out the pupillary center. Now you go ahead and refine the cornea, and like we do in all these K-Pros, once it's refined, you have to go ahead and remove the lens material as well, and the entire lens material has to be removed, and the patient has to be left aphakic. You could also either leave the PC intact, or you could do an anterior vitrectomy and remove the PC as well. I prefer to leave the PC intact in some of these cases, because it does reduce the chance of a retroprosthetic membrane, which can develop in these cases to cause traction on the vitreous and subsequent retinal detachment. So having a PC and having a compartmentalization always helps. Now the K-Pro is sutured in. This is a slightly modified type 1 K-Pro, otherwise known as the LVP K-Pro, manufactured by Orolab, where the central stem is a little higher. Now what I do is, after finishing the suturing of the K-Pro, I go ahead and completely cover up the pannus, and the entire thing is sutured, leaving no gap whatsoever. At the end of the case, it'll look as if nothing has been done inside the eye. And then you wait for 6 weeks. This is the picture after 6 weeks. And as you can see, it's almost as if the eye has been left untouched. Now here we go about making the central opening and trying to identify and expose just the central cylinder. The central 3 to 4 millimeter over the front plate is what we want to expose. Any extra part around it beyond 3 to 4 millimeters which has been exposed is then sutured back so that the pannus heals around it, and only the central cylinder is left in situ. So you then again cauterize the edges to prevent the pannus from growing over the cylinder. And this was just one such outcome of a patient who went on to have a 6/6 vision from PL positive preoperatively. We've gone on to do this over another 7 cases, and by God's grace, so far all of them are doing quite well. Thank you so much for your kind attention. Stop sharing.
Fantastic, Shreyas. That was fantastic. I mean, I've seen this one before, but this was unbelievable presentation. And thank you, judges, for not continuing this program and deselecting the other 2 teams, because your science has ended now.
Done. Contact Quresh.
Thank you very much, Kumar. Let's ask Quresh. Quresh, some comments from you, because being a top corneal surgeon, and these are a couple of nice corneal cases. Can you hear some comments from you, Quresh?
Yeah, the first one, Sheetal's was a classical DMAC. I think it was a textbook teaching exercise, which was very well done. Shreyas, I've seen him do this. I've seen him present this K-Pro, the Oro K-Pro, the Type 2 K-Pro with this. The only issue is, long term, what happens is that it's similar to our Pintucci K-Pros that I've been doing since 25 years now. When you leave the edges there, those edges tend to again close. The dermalized, keratinized epithelium tends to grow over, and you might have to go in again and cut it off. It's not such a big thing. I've sometimes cut it 5 times, 6 times, cauterize the edges every time, and doesn't matter. You just have to tell the patient that I won't be charging you subsequently, and he's quite happy to come. Well done,
Agreed,
Shreyas.
sir.
Thank
Agreed.
you very
Thank
much.
sir. I mean, unlike the
Suresh.
mucous membrane grafts, which grow back very rapidly, fortunately, these panises are not as vascular and not as proliferative as the mucous membrane graft. So I've only had to do it in one patient so
So
far.
this is
So
early,
maybe they're
Shreyas.
not as
It
proliferative.
sometimes grows
Maybe in
after
over
4 or
years.
5 years. Yeah, yeah.
Yes,
But
sir.
no problem. Yeah.
10, 15 years also, Shreyas. And
Yeah.
actually the
Yes.
story begins once you do this K-Pro. It doesn't end here. It begins from here.
Listen, Namrata, can I have your comments also on this? Because I think there's nobody bigger than you in this whole country
No,
in
no,
this
Dr.
corneal
Qureshi is
surgery.
great. Yeah,
Some
Qureshi
comments
is-
from you also,
So
Namrata.
I just wanted to say that all K-Pros are, they do have a wow factor on day 1, on week 1, on month 1. But when they come to you, they just come to you suddenly, with no vision or sudden diminution of vision. And you at that time actually dread, when they sit on your slit lamp without, having any vision. Because like I was telling Shreyas, and he also knows it, and all of us know as corneal surgeons, that the story actually starts from there. What they might come up with complication, I mean, you cannot predict. Could
I
be
think
a
the biggest
CME,
problem
could
is the
be RD.
infection which you can land up with
Yeah,
all these.
CME, RD, infection, anything can happen so suddenly.
And I have Rupal also here with us. Rupal, are you there?
Yes, I'm here.
Rupal, I want to hear some comments from you also, Rupal, on any topic in the second team.
Wonderful video. And Kumar, you can stop praying and act your doom for now.
No, your package has reached us.
Haha, that's nice. So now let's move on to the third team, which is Namrata's team. And Namrata, I hope your team is ready there. We have the Vaccine Avengers with Namrata as the captain. Then we have Gaurav Luthra as the vice captain. We have Srinivas Joshi and Ellen Kumaran. Namrata, all yours.
So I just want to share this with you. I don't have to tell you, you all are so intelligent and you all know it all. So of course, we are the Vaccine Avengers. You may be looking at the warriors, you may be looking at the masked people or masked superheroes. You may also look at the black fungus fighter, but I'm so sorry, you are always looking up to us to get rid of it completely. So you have no choice. We are the Vaccine Avengers, and we are all looking forward to us, and we are all looking forward to the vaccines. So we'll begin our presentation, and the first presenter is none other than Dr. Gaurav Luthra.
Thanks, Namrata. And yes, we are going to vaccinate everybody else very soon, and then Kumar will be left praying again. So there goes. Now, this was a patient that was one-eyed, fellow eye had been lost to penetrating keratoplasty and graft rejection and graft failures, multiple things. So this patient had been postponing his second eye surgery for almost 2 years, eventually went on to develop a cataract. And when he was down to finger counting 1 meter, he was offered a corneal surgery and a combined procedure, but he again refused because of his previous experience. So we had to take him up for a cataract surgery. And we thought we'll see how much our cornea surgeon suggested that patient is not willing for a graft. So we decided to go with the best that was available at the time was to do a chandelier-based surgery because the cornea was really bad. And we used the chandelier illumination, and that really improved our visualization for this cataract surgery. And with this, we could now at least make out what was happening much better than what we could with the microscope light. And this has been used by quite a few surgeons before. And we have been using it for a few of our patients very successfully. But here things were not going to work out as good as it was. Otherwise, that's why this is an OPL video. So as we went along and everything seemed to be going perfectly well, we managed to get a good hydrodissection, and everything was going really well. And I was able to crack the nucleus into 2 pieces when suddenly everything went dark. And I didn't know what happened. So I kept asking my team that, have you done something to the microscope? But the microscope was not the one to be, blamed, because what had happened was that the chandelier had slipped out suddenly. For a moment, that we had darkness, the chandelier just slipped out, and we had to put the chandelier back. And this is one small complication which everybody has to be very careful about when using the chandelier illumination. that the chandelier light source has to be very well supported just in case it gets tugged on. And since we are not all VR surgeons take utmost care that this does not happen. But as we went back, we were now going to encounter a very, very small pupil, and we suddenly realized that the nucleus was not to be seen. Probably the chandelier had gone and struck the posterior capsule as it slipped out. And now we were in a desperate situation. So we used iris hooks. Visualization was, as it is a problem, the VR surgeon was paged to come immediately. And we tried to clear off whatever little anti-vitreous that we could give better visualization to the retina surgeon. And within about 10 minutes, we had the retina surgeon with us. And we had to deal through a very, very bad cornea with very poor visualization to do a pars plana vitrectomy. And at this point, the surgeon was very craftful, and this was going into the late night for the surgery. We managed to somehow remove the whole posteriorly dislocated chunks of nucleus. There were 2 big chunks which had to be removed. And following this, we could close the surgery, but this time obviously we could not put in a lens implant. But this patient definitely needed a more definitive treatment. So even post-op, it didn't look really nice. 7 weeks post-op, this is how it looked. We managed to convince the patient now to go for a graft, and a graft was planned by the cornea surgeon. And at that point, we were able to use the Fleringer's ring and finish off with the lens implantation in the same. An IOL was implanted into the sulcus. We were lucky because the rexus rim was intact, and only the PC had been broken. So a lens could be implanted, and following this, the graft was placed. And in the end, we were lucky because the patient recovered 6/36 vision with all this happening to his eye. It was a one-eyed patient, and it was a big relief when he could improve to 6/24 with correction. He had significant astigmatism. At the end of the day, I think it saved the day, and we were able to vaccinate and save the world. So with that, I'll pass on to our next speaker.
Gaurav, next time, all this originated because your assistant didn't have the finger on where it's supposed to be.
Absolutely.
So she's
I've
got to
already
be
got
doing.
lessons from my VR colleagues on what to do next time.
Thank you, Gaurav, for that fantastic video. Now I'll request Dr. Ilan to give his presentation. Ilan, you are there?
Yes, ma'am. Thank you. Thank you for the. At the outset, I would like to thank Bangalore, Bombay Academy, Professor Lahane sir, Dr. Ragini ma'am, and Dr. Amar sir for the opportunity. Yeah. Not always. Most of the times, yes, but not always we get away with our phacoemulsification. With the advances we have made, phacoemulsification appears very simple. Most of the times we don't have any complications, but is it true in all cases? In some cases, we are forced to have a situation like this where there is no capsule at all. What are the options we have? We had the suture fixation, scleral fixation of the IOA with sutures, initially 10-0 and then 9-0. Later on, Dr. Amar sir introduced this, wherein it's a glued IOL, the haptics are tight. But what was important, in both those cases, there was a necessity of a flap. And in the first one, suture fixation, we needed a suture, either 10-0 or nowadays we do 9-0. How would it be if we can do a surgery without any flaps, without any cuts? That's how this particular technique came in. Yamane introduced this. This is intrascleral haptic fixation. What do we do in these cases? First of all, mark the center so that the line what we mark has to pass through the center. Pass in 27. Here I'm using a 27 gauge needle, and then take the haptic out. Make sure that you create, apply heat cautery and create a small blob over here. Just push it into the sclera. It should not be touched. A couple of times I've touched it there. That's one of my early cases. But we should make sure that the tip is not touched with the cautery. Luckily for me, this was a low heat cautery. The same thing is done with the inferior haptic. And once the flange is created, it's pushed into the sclera. Very simple, isn't it? But there are certain things that needs to be looked into. Number one, centration has to be accurate. Number two, there should be at least a 2 millimeter track in the sclera. So 2 millimeter behind, 2 millimeter away. That's how we use it. Take the needle inside. Make sure that the bevel of the needle is facing towards the haptic that has to be caught. That would make it easier. And then make sure in the initial cases, push the haptic inside the needle so that there are no surprises when we are pulling it out. And then slowly bring it out. This is the first case I did. I have used a heat cautery here. Again, that can also be used if Bowie cautery is not available. The problem we faced in these cases initially was this second haptic going inside. It was tough to push the lens as well as the haptic. So what is the modification that we started doing later? I'll show it in this case. This is an extremely dislocated IOL post-trauma. ICC was done. You can note the deficiency of the iris also. Again, centration is marked carefully. Needle is passed. Nowadays, I use a 30 gauge needle. Previously, we were using a 27 gauge needle. Wide bore 30 gauge needle is also available. Okay. Now, the inferior haptic was the one we always had trouble. So instead of taking the haptic inside, why not bring this needle outside? I copied this procedure from Dr. Divyansh. He taught me this procedure. In fact, many others were doing it before, but I learned it from him. And then cauterize, create the flange, and push it inside. Fill it, shut it, flange it, shut it, forget it. Thank you for the opportunity provided.
Thank you, Ellen, for that fantastic video and lovely animations. And now I will be presenting to you a case, a difficult case, in fact. So this is a case of 2 eyes and 2 lives, both affected by by a disease. 28 weeks pregnant lady who came to us with bilateral peripheral ulcerative keratitis and was admitted to our ward for investigations. And we wanted to plan what next. Now the risks out of the treatment outweigh the benefits if you medically manage such cases. Because of the fact that it's an active PUK, you may have to give systemic steroids and immunosuppression, which you cannot give in a pregnant lady. Now, this is the picture 2 weeks later. She had worsened despite our topical treatment because we did not start anything systemically after consulting with our rheumatologist. So the patient finally had to be taken up for surgery. Right eye worsened and the patient was planned for bilateral sclerokeratoplasty. Now the obstacles were that the patient was not cleared for surgery in view of high chance of preterm labor and fetal lung immaturity in these cases, especially if they gave anesthesia. So IV steroid injections were given for fetal lung maturity, and we had a whole team of ophthalmologists, neonatologists, obstetrician, and anesthetist managing this case. So finally, at the day of the surgery, the patient came accompanied by her husband with bilateral PUK, such as seen there. And this is the operation theater site where fetal monitoring is happening with the surgery which is being done. The anesthetist is there, the neonatologist is there. So this is the bilateral surgery which was planned. And this was, of course, done sequentially, but just to save time, I'm showing them together. The principles of the surgery were pretty much the same. The peritomy was done, followed by the cauterization of the bleeders. Then subsequently, the membranes which are present on the iris was removed. And important thing in these cases is that you have to preserve the iris as much as possible and do a lamellar corneal dissection in them, so that you don't just cut away the iris. So the dictum is that you have to preserve the iris as much as possible in these cases. And these surgeries do take up a lot of time because you can give anesthesia only once for doing both the eyes. It takes almost 2.5 hours to do one eye and then subsequently go on to do the other eye. Because of the distorted anterior segment and the distorted anatomy, it is again important and imperative to do a careful dissection. And also you have to form the anterior chamber as well as take care that there's no expulsion of the lens, which can occur in these cases, given the fact that it is an open sky procedure. Preoperatively, you have to give mannitol in such cases also. And these are large grafts which are being sutured. 10-0 monofilament nylon sutures are being applied, and again, like I said, these such cases do take time because you have to apply more than 16 sutures in these cases. Of course, you have the intraporosity microscope to give you an idea of what your chamber is going to be post-operatively. And after applying all the sutures and after completing the surgery, the patient was followed up 2 months later. She looked pretty good. She looked like this. And of course, the sutures were in situ. This was the bilateral picture, the right and the left eye. And the patient had also delivered the baby. So it was about 2 lives and 2 eyes. And
Wow.
this is the beginning of new life. So thank you very much for your kind attention.
Amazing, Amrita.
Now I would request Dr. Srinivas Joshi, who is going to take you to yet another field, and that is macula, and his topic is macular surgical strike.
Yeah.
Yeah.
Thank you, everyone. At the outset, I would like to thank Amar sir for conducting this OPL and having us here. I sincerely thank BOA team, Dr. TP Lahane sir, Ragini madam, and my 2 elder brothers, Dr. Preetham and Dr. Swapnesh, for having me here. So let's go with the macular surgical strike. So in a 62-year-old diabetic patient who underwent vitrectomy, membrane surgery, and ILM peeling for the PDR. Like any other routine surgery, we went ahead and removed the fibrovascular proliferation over the disc. Everything went well. I had removed the ILM as well, but after 9 months, the patient developed diminution of vision, and he presented to the hospital 4 to 5 months late because of the pandemic, and he had developed fibrovascular reproliferation and traction, leading to eccentric macular hole. So this was the traction area. You can see that the fibrovascular white membrane, and my God, the macular hole was nearly 700 microns, and he is a one-eyed patient. So I went ahead and removed this membrane in the second part, and slowly after peeling this membrane, everything was going fine, and suddenly one small blood vessel exploded. So I have to prepare for something unexpected now. There was no ILM. So I went ahead and put PFCL. The bleeding had stopped a little bit. My plan was to do a neurosensory retinal graft. You can see here I'm just cauterizing the part of the retina so that I can get the piece of the retina. Now you can see I injected a 42 gauge syringe to create a bleb because I don't want to damage the choroid or the RPE. And bimanually using the chandelier, I'm just trying to take a small graft and slide it under the PFCL. If we take it above, then it starts floating because it's very light. So placing the graft in the blood filled area was slight a challenge. But some authors have even used the autologous blood to close the MAC hole. So it was like a double vaccine, the 2 doses of vaccine. One is the blood and the second one is the neurosensory graft. It's almost like the blood was like a boon in disguise. And finally, I did a fluid air exchange and the gas was injected. And after successful graft placement, I was bold enough to chase the enemy. And you can see a nice closed graft with the final visual acuity improving from 660 to 6/9. I was really surprised. The graft had taken so well. So looking at the smile and the happiness of the patient, even our Josh was, "Hi, sir." Jai Hind. Thank you very much for the patient listening.
Thank you, Srinivas. Thank you so much. So the vaccine Avengers have answers to everything.
Thank you very much, Namrata. I think before we move on to the last team, I want to mention one thing that about Namrata, and that is, she's among the top 100 women ophthalmologists, which has been voted by the Ophthalmologist Journal. I think that's salute you, Namrata, for that. It's phenomenal. I mean, you definitely deserve that position, but for us, it makes us all very proud. We have Dr. Natarajan with us here. Natarajan? Nati? Is he there?
Nati is a
okay. We have Parikshit
never, no, Amar. Nati never sit at one place for few minutes.
What about Parikshit?
He is unstable, stable person.
Parikshit or Shashi Kapoor? Anybody here? Partha?
Hi, Amar.
Yeah, Shashi. Few comments from you,
Yeah.
Shashi.
Amar, it's very heartening to see, non-cataract interesting cases and amazing corneal surgery and macular surgery. So it's been a good break from the usual OPL.
Nice, Shashi. And what about, do we have here Partha with us? Because we didn't have to get
Yes.
any comments on Partha before.
Yeah. So this team has really done well. I'm sure the next team is going to do better, but Namrata, with her challenging cases of cornea and the institutional management of this, really calls upon a big kudos to the whole team which took part in this. Of course, Srinivas is, of course, the bulleting and the gung-ho is really fantastic. Both the clot as well as the graft. Fantastic. Ilan and Gaurav, very nice phaco's that you have shown, really good. And Gaurav, look up to you for even better ones in the next times. Thank you.
Thank you very much. Do we have Parikshit Gokte here? If he's not there, we'll move on to the next team, which is going to be the masked superheroes. And the captain there is Prashant. And with him, the vice captain, Sonu Goyal. Then we have Himanshu Mehta. And finally, Swapnesh. So Prashant, can you take it from here?
Yes, sir. Thank you. Thank you, Amar sir, for this wonderful opportunity, and BOA and MOS for this opportunity. So here are the masked heroes. Bura mat bolo, jada mat bolo. So we speak less, we don't speak bad. We are here in principle with the mask here. Follow in principle whatever you teach the world. And here is the team, masked superheroes. And we have my vice captain, Dr. Sonu Goyal, and the other team commanders are Dr. Himanshu Mehta and Swapnesh. Dr. Sonu, will you please share the video of our team and then followed by your presentation?
नाचेंगे सारी सारी रात टांग उठाएंगे नाचेंगे सारी सारी रात टांग उठाएंगे विकेट ली है सारे आज टांग उठाएंगे.
So here we are. So Prashant, am I audible and visible?
Yes, sir.
So the show begins. So my dear friends, it's Mission Dangal.
There's no science without experiments. Experiment नहीं करेंगे तो हमें अपने आप को देने का कोई अधिकार नहीं.
So here we are, 360-degree subluxation. And believe me, this is what Professor Chi Soon Fik has taught me. Don't sit back, but push yourself hard. And yes, we can.
कैसे fit करेंगे? This is impossible, sir.
This is Dr. Sonu Goyal, mission London for subluxury lenses. Initiating command for.
Go, sir, go, sir.
So here I go. I take the challenge. 4 side ports, cushion viscoelastic, and supporting with 2 rexis forceps. Getting the rexis right. Yet another case, triamcinolone in, limited anterior vitrectomy, viscoelastic in, a good capsular rexis, and then a good capsular support. But mark, be careful. So low bottle height, phacoemulsification, the capsular tension ring goes in. Capsular hook support, gentle irrigation aspiration. I prefer using a 3-piece lens here. The Ahmed segment with the 8 Gore-Tex. And this is the lasso technique. I push in the Ahmed segment here in. And then this is gradually pulled out through the Hoffman pocket. And just see the Ahmed segment there. The lens back complex getting stable. And why 8 Gore-Tex? Because it doesn't degenerate over a period of years as compared to the 9 or 10. Prefer using a 3-piece. Anytime I can convert what Dr. Namagrawal says, the blue diode technique. So I trim this Gore-Tex, and this Gore-Tex is then pushed underneath the Hoffman pocket. And this is what I achieved. Day 1, a very central lens back complex. And this is this, look, this is my friend from South, Dr. Mohan Rajan. And this is called the Lungi exchange. So this subluxated lens with phimosis, it was a Bausch & Lomb C-loop type lens. And this I learned from my friend, Sri Ganesh. I use his dumbbell technique. And I pass to 6-Proline and then gently cauterize and make these bumps here and achieve a stable lens back complex in an otherwise 1.1 incision. So if you observe carefully, a traumatic dialysis with traumatic lens subluxation. So what here I have to address is the lens has to be placed centrally, and at the same time you have to repair the iris. So I learned from this stitching technique where I thread this 9-Proline inside this 26 gauge needle, and what I do is now just mark this 26 gauge needle engages the iris, externalizes the tissue, the suture from the scleral tissue, and just look very carefully. I'm able to stitch the iris to the sclera using a 9-Proline. So this is what our team stands for. Mission Impossible. Thank you so much.
Thank you, Vice Captain. So that's Masked Heroes. We speak less, we perform more. Now it's time for me as a captain to share my screen.
Please put your mask.
Yeah. Thank you. Thank you, Manshu sir. So this is a presentation from me. Can you see my screen?
Yes.
Hello?
Yes, yes, screen is visible. Yes.
Yeah,
We can see Dr. Prashant. Complaint of gradual decreased vision, along with intermittent episodes of pain and redness in the operated eye, who had undergone 6 months back 3 procedures in a span of 10 days. The operated eye had corneal haze with plastered iris and decentered IOL with anti-chamber reaction and raised IOP in spite of 2 anti-glaucoma medication. Fundus showed inferior vitreous hemorrhage with CME with epiretinal membrane. This was the slit lamp picture. Naturally, her diagnosis was UGH with secondary glaucoma and early corneal decompensation. The pachymetric analysis showed a significant loss of corneal endothelium, that is, the count had reduced to 1023 and pachymetric value was 600. UBM showed tilting of the IOL with haptic rubbing against the iris posterior surface, thereby plastering the iris to that area of cornea. OCT showed central macular thickness of 950 microns. The plan of action was to do revitrectomy with IOL, either repositioning or scleral fixation of the original IOL with intravitreal ozodrex with internal limiting membrane. But the challenges were plenty. The fear of corneal decompensation for the reasons cited, need of IOL exchange versus IOL repositioning, and peeling of a periretinal membrane in a cystic macula. Conjunctiva incised at 10 and 4 o'clock meridian. Partial thickness scleral flaps created using crescent at 10 and 4 o'clock. Intrascleral tunnels created using 23 gauge trocars. Vitrectomy completed, ILM stained with brilliant blue and peeling being done. Tight ports created with myringectomy and IOL dislodged into vitreous. With vitreous cutter, IOL removed from the surrounding adhesion. By handshake techniques, haptics being externalized and then buried into the intrascleral tunnel. Antechamber deepened with visco and with the cannula removing the iridocorneal adhesion. Pupil circular at the end of the procedure. At post of 4 weeks, the patient's vision was 6/24 and pressures were controlled with 2 anti-glaucoma medication. Macula was flat. Another story of 70 years old gentleman who had undergone intraocular lens implantation elsewhere, who complained of poor quality vision and shadow on and off in the field of vision. His best corrected vision was 618 parts. He had an anterior chamber IOL which was smeared with pigments as well as corneal endothelium, and fundus examination revealed a foldable IOL in vitreous. The plan of action here was to do a vitrectomy with both IOL explantation and then to put a scleral fixated IOL. Challenges here were also same. 3-port standard vitrectomy, IOL being isolated from the vitreous by doing complete vitrectomy. It's a foldable IOL. Antechamber entry done with 2.8 millimeter keratome, viscoelastic port, and with iris hope, the antechamber IOL tugged out. A Teno suture being placed, IOL being picked up with a vitreous forceps and with handshake technique brought into antechamber under plenty of viscoelastic and now being delivered out through the corneal section. Viscoelastic again filled into antechamber, 3-piece IOL being placed into anterior chamber. With handshake technique, the haptics externalized, the first haptic being externalized, the second haptic being externalized over here. Handshake technique you can see, appreciate, and now the haptics, externalized haptic being buried into intrascleral tunnels. The post-operative vision here was again 612 parts with white pseudophacos and a white fundus at the end of 1 month. So, friends, thank you.
So that was an inspiration from Dr. Amar Agrawal, how to go ahead with it. And now we move on to the next participant, Dr. Himanshu Mehta, the superstar of Bollywood now.
Yes. 1 second. So ये प्रशांत बानकुले एंड सोनू ने प्रूव कर दिया कि जब मास सुपर हीरोज़ बोलते हैं वहीं से स्टोरी शुरू होती है और जहाँ वो रुकते हैं वहीं से लाइन शुरू होती है. तो ये बात होती है आगे मास सुपर हीरोज़. Ever so often you see subluxated IOL back complex, which is regularly with more of pseudo-exfoliation, younger patients with capsular phimosis. And all ophthalmologists are Superman. They can always solve most of the problems. The idea is to see how we can ourselves realize that your friend and the best friend that was the capsular bag and the IOL. But sometimes your friend becomes a foe, and all your friends, all the other superheroes can start working against you. But this is where the Superman uses his superpower to see things way faster, way earlier, even than the Flash, so that he can sort the problems and see that the vision comes through. You make a scleral tunnel, just a tunnel, you have a 90 proline ready on one side, you take a 26 number needle with support and traction from the opposite side. You have got a 26 number needle going, and you can railroad the 90. It's a difficult thing because there is fibrosis, but now we are going underneath the optics, and this is what happens. Just when you want to do the right thing, but yet there is going to be some kind of resistance, but that's where the Superman has to use his power. All ophthalmologists have to get together and understand that the right track to take is to do the right thing, because that's the way only it can go. You can go left and right, but there is only one way it has to go, and the right place. And once it has been given the guidance to go to the right place, you have taken your first major step of anchoring the IOL back complex, which is your friend and not your foe. You don't want to remove it, you don't want to cut it, you don't want to traumatize the cornea. It saves your corneal endothelium, saves vitrectomy, saves a lot of manjan and masti. You got that thing coming out. No big incisions, no consistent flows of fluid, no irrigation. And here, once as you taken just underneath with the haptic optic junction together with the bag, you got one part of your needle going there. The second one is a lot more easier. You're ready over there. The needle is waiting to be fed into the 26 gauge needle. You can always railroad that back into that. Now this is the easier part above the bag complex. So you have a knot which is pulling up the IOL bag complex with the fibrosis now acting as your friend, because that is going to give you a good support. A similar thing is done on the opposite side also, and you have to support it with the other hand. See how you can pierce that underneath the IOL bag complex and into the capsule, from middle of the capsule to the anterior capsule area. This is another case. Similar thing, you change your positioning and you change your angle, but how you can manage to see that your railroading happens and your own friends who had become your foe, the bag and the lens, can be readjusted to help you to be at the right place. They just lost direction for some time. They just have to be given the right direction, and all of them can get together. And that's where the vision is so important, faster than a flash, because many things happen in surgery even faster than a flash. By the time you blink, there's a posterior capsular rupture. By the time you blink, the lens can just topple down. And that's where that sixth sense of an ophthalmologist, the earlier you detect the problem, the faster you can slap it, get it out of the way. And ophthalmology always wins, science wins, and you can have the best vision for the patient. Thank you.
Thank you, Dr. Himanshu. Didn't I say the Bollywood punch? That was a Bollywood punch from here, from mass superheroes. And now we have the last, but not the least, the final salvo. The final salvo from Dr.
Prashant.
Yes, sir.
ये तिरछी टोपी है.
Yes, sir. It's for superheroes. So, Dr. Swapnesh Sawant over there.
अरे आमचाच मुलगा आहे.
Yes.
जिंकला रे बाबा.
Thank you. Thank you.
So thank you all the seniors for giving me this opportunity. So let's start with the case. So
Swapnesh, but you're already a winner, because all this, especially the OPL and the program, you have done so much work for it. Without you, all this was not possible. So you're already a winner.
Thank you, ma'am.
Thank you, madam. We are encouraged. So other teams must be envious of us.
So this is a case of
don't worry.
Pseudophakic RD in a young patient. And the challenges that we are going to face is because of the vitreous, which is so adherent, vitreous, which is so plastered anterior to the brakes. So we need to have a good skill set, as well as we need to have modern equipment to tackle with this complex case. As you can see with the modern vitrectomy cutters and the modern vitrectomy machines, you can see that stiff retina, especially anterior to all the breaks, there is possibility of doing a good peripheral vitreous shaving with the wit shave mode on. So that's technology for you. But the fundamental principle is the ora vitreous base has to be cleared nicely, otherwise you will have recurrences. Again, the fundamental principle in chronic retinal detachments is to do a fluid-fluid exchange because there is chronic SRF. So you need to remove that, otherwise it will create SRF pockets later on. So that's the fundamental. And the technology is that because of these improvised cutters, you can go very close to the retinal surface. And even if there is too much traction, and sometimes it can lead to a large extension of the break, because of the modern cutters, you can really go close to this. Skill is you need to be ambidextrous. Over here, I'm using my left hand. The rolled up margins of a retinal hole need to be trimmed properly, otherwise it leads to the PVR changes. Fundamental. Endochrometry has to be done to mark every break. Otherwise, once the retina is flat, then identifying these breaks is very, very difficult, and then you can miss lasering these breaks. Here the FGE is done. Technology. Initially we used to do with flute needle. Now we do with suction mode on cutter or extrusion pipe also. Fundamental. We can roll the eyeball in a position so that the break is in the most dependent position. What this does is allows the subretinal fluid to gravitate towards the break so that the entire SRF can be drained towards the drainage retinotomy. Skill. You go in and node loose patients do repeated attempts. Technology. Curved endolaser probe to do endolaser around the breaks. Fundamental. Keep the break in the most non-dependent position so that the retinopexy is very good. Fundamental. Laser anterior to the breaks. And oil is inserted to close this case. So this was a case of Stickler syndrome. A BB is put, which is the most important fundamental, and this is the post-op result.
Wow.
So sometimes you are faced with a complex case.
Are you chewing up, Kumar?
And the surgical skills are challenged. You look out for the new technology to help you. That is your vitrectomy machine. So along with your surgical skills and the new technology, you try to kill the difficult case, but it's a struggle. The difficult case does not lose. It again stands up to face the surgical skill and the new technology. But the fundamentals are the one which win you the success. And the difficult case loses. Thank you very much.
Thank you, Swapnesh. That was a final punch from the mass superheroes based on technology and your expertise. Over to you, Amar Agrawal, sir.
Thank you very much, all of you. I want to just mention something. One is about Himanshu Mehta. And Himanshu, as you all know, it was such an honor when Amitabh Bachchan personally himself wrote on his blog about Himanshu and the great surgery which he has done. Himanshu, you make us all very, very proud. The second thing I want to mention to everyone here is about Namrata Sharma once again, because the ASCRS this year in 2021 is honoring her with a Richard Lindstrom Gold Medal. And if I'm not mistaken, this is the first medal being given of Richard Lindstrom's name, and that's been honored and given to Namrata Sharma in the ASCRS 2021, which is a huge, huge honor, I think, for all of us. The third person I want to mention is Ragini, who's always in the background, but the whole brain is working continuously. And Ragini, it's not only BOA or MOS, but AIOS as a whole, and all of us who are so happy that it's used, pushing the whole system with Professor Lane, obviously there. But we want to thank you all personally for that. Saying that, we'll now move on to the judging. And to be honest, everyone here is a winner with this COVID.
so much,
lockdown and all.
and
You know
thank
how
you
the mess
everybody
is
for the
everywhere in
love.
the country. You know, I want to say that everyone here is a winner. So I will ask Lahane Saab at the end. I will move first to Preetham. Can you tell me whom would you rate as the best entertainer among these teams? And it's Preetham. Can you give me a name? Preetham?
Sir, you're putting me in a dharam sankat.
Yeah, obviously.
My secretary, my own secretary, Swapnesh, has presented a case, and now you're asking me who's the
So
best.
has he paid you any money for that? No. He's taken off your patience.
Sir, if I take his name, then I'll be killed by other people. If I take
you're
someone
neutral.
else's name,
No issues. You can be neutral. So Parikshat, is he there? What about Shashi Kapoor?
None of them will say anything.
So okay, so shall we do one thing? We will say all
Shashi is there,
16
Shashi
are
is
winners. Okay, Professor Lahane, you are the final decision maker, sir.
That I will do, but they should also say, na, Shashi, कौन आदमी है जो entertain?
Sir will also not say anything right now.
Sir, Swapnesh.
Election.
Swapnesh, huh? Shashi?
Most entertaining
Yeah.
video was
Okay, Swapnesh is the most
Match
entertaining.
fixing.
Partha, you have any name?
Dr. Ranjit Manyar is ready to say.
Ranjit?
Who is, yeah.
Dekho, the best two videos that were there, they were not just entertaining, they were more educative.
Okay.
And that was Shreyas and Namrata. And I think between the two, Namrata wins.
Okay, so we'll come to the scientific portion next. What about entertaining? Tell me anyone entertaining you feel.
Best entertainer was Srinivas Joshi. Macular
Srinivas
strike.
Joshi. Okay. Rohit Om Prakash, what about you?
I think it was Kumar Doctor.
Kumar's. Okay, who is left? Partha?
Swapnesh.
Who?
Swapnesh.
Who?
Swapnesh.
Swapnesh. Okay. So Rupal is there. I think Rupal has left. So Rupal, you're there. Great. Rupal, tell me.
It had
Kumar. So now the tie-up is between Kumar and Swapnesh. So
Kumar has promised me
Dr. Kumar. I think Kumar takes it, yeah. Kumar takes
it. What about Lahane, sir? We are going to give it to Kumar Doctor then. Okay, so now let's move on to the next one. The best video. Already I got a name. One I got was Shreyas and Namrata, and he said Namrata is the best. Anyone else give me any other name?
Anybody who
Preetham?
can differ has to answer to me.
Okay, no problem. They will answer to you, sir. Don't worry. Sir. Preetham, what about you? Any name? Scientific video, Partha?
Srinivas.
I go with Namrata also.
Okay, Namrata gets, okay. Partha gave Srinivas Joshi. Shashi, what about you?
Paisa avi gaya ne kuch?
Yeah, Namrata.
Namrata, okay. I think Namrata is taking it. Natrajan? Nati is not? No, not there.
No,
Okay.
no, Nati is
Rohit?
never there.
Rohit?
Sonu Goyal.
Sonu Goyal. Okay. And Quresh?
Namrata.
Okay. Rupal, what about you?
Namrata.
Okay.
Oh,
So
yeah.
Namrata, just hands down. Hands down. That's a great video. So let's move on to the final thing, which is Professor Lahane. We'll start with you on this. Which is the best team, Professor Lahane?
Fungus, black fungus.
Black fungus. Okay. Preetham Sawant.
Sir is muted actually. Sir is trying to say something.
Let him be neutral.
Masked warriors.
Amar, the team, best teams, I think, our maximum, they have done very good things. Comparatively, you will see all are having the same mark. There may be a 1 mark here and there. But few presentations are very, very important. Those presentations can give the maximum marks to the team.
Okay.
So I will ask all the people who are with me. I will ask Preetham, which team was the best.
Preetham, give us a name.
Masked warriors.
Huh?
Masked warriors is Prashant's team. Okay. So next person,
Prashant.
Partha, what about you?
What about the Parikshit Gokte is there?
I can't see him.
Okay, Shashi Kapoor.
The Masked Warriors, Prashant Bhawankalekar.
Prashant Bhawankalekar.
Suresh.
Okay, Partha Biswas.
Again, Ragini, which team you say?
Namrata's team, sir.
Namrata's team. Okay.
Namrata's team is
Ranjit Manyar.
Vaccinators.
Okay.
I would
1 minute, 1 minute. One at a time. Ranjit Manyar.
I would give it to Kumar's team, hands down.
Kumar.
Okay.
Hands
Okay.
down.
Rohit Om Prakash.
Black fungus.
Huh?
Black fungus is Kumar's team. Okay. So we have got 2 for masked for Prashant's team.
1 minute. I have remembered. Quresh Maskati.
Vaccinators.
Maskati, my vaccinator.
Namrata's team.
Namrata. Namrata got maximum.
Ragini, what about you?
1 minute. Rupal.
Maniyar sir.
Yes, I believe in long term, sir. So let's
Sir,
see.
somebody talk about COVID warriors also, sir, please.
अरे कौन है भाई ये कौन है?
No, see, 1 minute. Rupal किसको है?
Sir, vaccines. Namrata's, Dr. Namrata's team.
Namrata's, okay. So Namrata's team has got maximum marks, and the video of the Namrata and what she did, I think that is not only the national but internationally that will be the excellent video, and
Yes.
that has got the maximum marks. So Namrata's team won first.
Vaccine Avengers, Namrata, congrats once again for winning it. Not only the best video, but the best team also with you, Gaurav, Srinivas Joshi, and Ellen Kumaran. Congratulations.
Thank you.
And Professor Lahane, few words from you now. We want to hear.
See, the thing is that I'm very happy that Amar came. I'm very happy that everybody took part in that. And really, I must respect the friendship of Amar, and I salute, because see, I was knowing that, okay, Amar is not keeping well, but he's excellent, and grace of God, and done good work. So I think he did a very good thing, and all the team members, really,
Thank you for all the
my
blessings of everyone, all of you, for making me all right, sir. To be honest to you, I want to thank you, Professor Lahane, Ragini, Namrata, everybody, for your good wishes to make me all right. Thank you so much.
Yes, yes.
All the best, Amar.
No, it is the blessing of the millions of patients that you have treated with your innovations and the teachings and the blessings of everybody and your karma, sir. You came out of a very difficult time, and from all of us here today, a big clap for you, Amar, sir.
Yeah.
Long live Amar, sir. I will tell you, Amar,
Nothing will happen to you, Amar.
without Amar, OPL can't happen. If you are not there, मजा नहीं है. OPL तो करते हैं, लेकिन अगर मजा है, एंजॉयमेंट है, तो I think it is Amar, and I think as the name suggests, you are Amar only. Don't worry, you will be Amar.
Thank you
So
very
I'm
much.
happy. I congratulate
Once
all the 4 teams. For me, all the 4 teams are the winner.
Yes.
But see what happens. My people who were the judges with me, they were biased. Because of that, they might have given to one person.
All our votes to you, sir.
For me, all 4 are winner. Because I am contesting, so I will have to say everybody is winner. Otherwise, what will happen? अरे इसने तो हमको नहीं दिया है.
पर आपने हमें बहुत कुछ दिया है. So
सही बात है, बहुत कुछ दिया है.
And
Thank
I
you very
think,
much, everyone. And now we'll move on to Harshal. I think your session will soon be starting. Wish you all the best.
Harshal, best of Harshal.
Bye-bye.
Ilan Kumaran, thank you, Ilan Kumaran. Ilan Kumaran, thank you very much.
Please take care. Please be safe, and thank you so much.
Until you are marvelous.
Sir, Lagane sir, all the best, sir.
Thank you, thank you.
Thank you,
Mohan, thank you. Tamil Nadu, you will have to take care.
Yes, sir. I'll get
All the best,
Rajinikanth for you,
Lahane,
sir.
sir. Best of luck.
Thank you, thank you, thank you. So now Ilan Kumar is there. He is going to take care of Karnataka. There is no problem. And Partha, he is going to take care of the Pasim Bengal. Okay.
He has to take care of
Indirectly, sorry, indirectly, not directly. And he is there. Kudlu is there. I think Kudlu is a very nice person, and I think good friend, excellent friend. And this Rohit is also there. Gaurav is there. So all these people, this Rupal is there. Kumar, Srinivas is there.
Sir, I'll ask Rajinikanth to endorse for you, sir.
Huh?
I'll ask superstar
Sonu,
Rajinikanth.
Sonu to kya hai? He is like a brother. Sonu is also there. I think since beginning, I will tell you, the Sonu always phones me. See what happens in the election. Sometimes few things require, so he always calls me. So I think everybody is with me, and I am very happy. Everybody is there, and also endorse Namrata also. She has really done good work, and I am proud that Namrata is not only the 1 out of 100, but she will be 1 out of 1 in the world. So I wish her best of luck. It should happen. So thank you, everybody. Thank you.
Sir, you have to wish Partha sir all the best for the upcoming conference.
Partha, we are there. Partha, we are there for upcoming conference. Anything required, you just tell me.
So many things are required, sir.
We will be there.
Everything is
Partha, you just WhatsApp me, your work will be done.
Can I speak from Partha's heart, sir? He requires sponsors, sir. Am I right, Partha, sir?
Absolutely. Thank you.
Partha, no, he has a lot of sponsors. He's already taken some from the AIO's headquarters. He doesn't
No,
need
but
any
अरे सोनू पार्था को कैसा स्पॉन्सर लगेगा? पार्था तो I think he can bring the this one sponsor. But if you have got any problem in sponsors, tell me. I will definitely help there also.
Absolutely, sir.
Okay.
Thank you so much.
Then Kumaran sir, thank you very much. Thank you
Can
for
I say
sparing the
something?
time.
Thank you, everybody. But elections apart, elections or
नहीं,
no elections or
election आज
whatever
है, कल है,
happens,
उसमें क्या है?
we are one family. We remain family. Relations are more important than these things which
Harshul.
come and go in life. We are
Harshul,
one
thank you.
family. We
Harshul,
remain
thank you.
family forever.
My pleasure.
हाँ, yes. इलेक्शन कभी आता है, कभी नहीं आता है, जाता है. It is forget. But we are friends from 15 years. We will remain friends throughout. It is not one day's job.
Thank you, sir.
Thank you. Thank you.
We need your blessings, sir.
All the best, sir. All the
So
best.
Harshul, yeah, stage is yours. And I think I will request all of you. You can just mute the video and you can listen to Harshul what he is going to do.
So
Wonders.
he is the judge for the MOS seating. Arshul, can you please?
It is 7:15, na?
Yeah, yeah.
So he's giving us a little break. No, we need to have tea and all and then join back.
Yeah.
Okay, okay.
All the best.
Bye, ma'am. Bye-bye.
Hi.
Bye.
Bye. Thank you, everybody. Thank you. Lots of
Great
love. Be
fun.
safe
Natti,
and
कहाँ
please
गया था
take
तू?
care.
Where were we? Where are you?
So thank you, Swapnesh, Preetam,
Thanks, Swapnesh.
Ragini, and Dr. Lani, sir.
Yes,
And
yes, yes.
entire
I think
MOS team, Parikshit.
Swapnesh, Sumit
Thank you.
deserve the biggest
Yes,
hand.
Swapnesh and Sumit deserve, and Dr. Preetam, they deserve the
And
biggest.
Preetam and
Yes,
Parikshit.
yes.
So Swapnesh and Sumit, the biggest
स्वप्नेश
hand.
एंड
Then
सुमित
the two presidents.
Yes,
दोनों ने
sir.
बहुत
Superman.
अच्छा काम किया है.
I think 3 cheers for all the entire QA team. Hip hip.
Hooray!
Hip,
Hooray!
Hooray.
Thank you very much. I think Ragini, Pritam, Swapnesh, and Sumit, they are not slept for near about 1 month. 1 month. So they are on the toes. But I think it was a Pritam's idea and a totally successful conference. It is, I think, it is seen by 30,000 people. Actually, I also went inside and saw 30,000 is a very big number. I'm very happy for that.
But it has been a success only because each and every one of you really came.
Yes.
And see this love and warmth. I mean, this is, baki kuch nahi chahiye, this is good.
Next year Mumbai में आएंगे, madam. We are coming to Mumbai next
We
year.
are one
आपको
family.
एक बात बताता हूँ. Now you will see the different warmth in Mumbai because we are Mumbaikar. You have seen in BOA. It will be same in the AIOS also.
Absolutely.
I will also sponsor TADA to each and every person. Also the hotel for AIOS also, not BOA. Everybody, those अरे टीचर्स है, टीचर्स लोगों को यहाँ आने के बाद उन्होंने क्यों खर्चा करना चाहिए? Everybody who is teaching, he will be taken care of, and all the faculty I will give free room. I am not going to ask कि तुम पैसा दो ये करो, है ना? अपने पास trade है, they will pay. So
But
everybody,
Partha sir, we are looking forward to Mumbai, but you know,
Absolutely.
Calcutta is not something that we are going to let go. The
No, 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 no.
opportunity to stay
We are
with
going
my
to come to
brother,
Calcutta,
तो वो तो
Partha.
बाकी रह गया.
Yes, sir.
in the conference I will be there in Calcutta.
Absolutely, sir. Absolutely.
Huh?
Yes.
So I will meet your chief minister. You know, no? She is my friend.
Yeah.
Yes. तो
Yes.
मिलना है मुझे जाके.
बिल्कुल, sir.
Thanks, sir. All the best for the AIOS.
Thank
And
you.
Mumbai will be good, not because we are doing it, because all of you will be involved and there's a lot
Everybody,
of work in
everybody.
AIOS and we'll be doing it together.
एक आदमी कुछ नहीं कर सकता है. सबने मिलके.
Hopefully, Mumbai will be physical conference.
Yes. मुंबई में फरवरी में कुछ नहीं रहेगा. कॉन्फ्रेंस होगा.
एकदम, it will be.
It's in April, no? Namrata, April of 2022.
जो भी है एक दूसरा महीना इधर उधर, but we will
We
have a
haven't got the
conference.
dates yet, but we'll get the dates. soon.
Okay. Thanks a lot.
Right.
Thank you.
Hopefully
Bye-bye.
we'll meet
Bye.
each other soon.
Yes. Yes, thank you.
so much. Thank you, sir. Thank you, sir. Thank you.
Really, thank you from bottom of my heart.
Thank you.
Thank you.
Hi, Ragini.
Bye. Prashant bhai, we forgot. Hi dad, how are you? Where were you? Prashant bhai, your hard work for the quiz, we have to mention it. We forgot to mention it. We forgot. एक हफ्ता हो गया तो.
घर वाले लोगों को कैसे भूल के क्यों थैंक यू बोलना?
That is not good. Biggest
नहीं,
thing.
घर वालों को थैंक यू बोल के उनकी वो मत करो मैडम सबके सामने.
नहीं, घर वालों को थैंक यू बोलना ही नहीं है, बट आई हैव टू जस्ट से दैट यू डिड. आपको थैंक यू नहीं बोल सकती और सब घर वाले ही है, किसी को थैंक यू नहीं. Till we meet again.
Yes ma'am, looking forward.
Namrata, you rock.
Thank you so
Namrata
much.
has been the brain behind, Preetham and me thinking ki yes, this can be done. And having seen her do it, we could take the jump, and she was the one inspiring and the motivating force. Ki do it, and you can do it. Namrata motivates, inspires, and always
Thank you,
is
Ragini.
positive.
Thank you.
Chalo, let's call it. Bye-bye.
Great, Namrata. I enjoyed your case, Namrata.
Oh, thank you, Nati. You're always there. I know that. Always. Thank you.
Thank you, Ragini.
Thank you, Dad.
Thank you, sir.